स्टार्ट करें। I request you all to be seated as we are starting our conference today. A very good morning to our excellencies, distinguished delegates, scientific advisors, speakers, ladies and gentlemen. It gives me an immense pleasure to extend to you all a very warm welcome on behalf of the organizing committee. I, Dr. Amrit Kaler, consultant molecular pathology and genomics at Kokilaben Dhirubhai Ambani Hospital, Mumbai, feel privileged to be your host for today. Kokilaben Dhirubhai Ambani Hospital is a top multi-speciality healthcare institution with a center of excellence in oncology. We are all gathered here for the Symposium on Precision Oncology and the Personalized Medicine, which is being conducted in-house, and we are also live on YouTube. So hello there to everyone joining us live. The last few decades have witnessed one-size-fits-all kind of conventional treatment strategies. That is a similar line of treatment or usage of the same drug to treat a particular disease. With the breakthrough of the whole genome sequencing in 2000, led to the identification of the genomic aberrations leading to the pathogenesis of cancer. Cancer is now known to have a genetic etiology. The focus of treatment has evolved, shifting from a tumor type-centric to gene-directed, histology agnostic with the innovative adaptive designs with the goal to improve treatment outcomes, also known as personalized medicine. We knew cancer was a deadly disease, and we looked for hope and we prayed for the treatment response of the patients. We have dawned into an era where we have found answers to some of our questions, and we are finding it extremely confident in approaching few cancers tailored on biomarker profiling and treatment strategies. We are hopeful, the future is bright, and cancer treatment is giving years to patients' lives. It is gratifying to note that the scientific program today will provide a plethora of knowledge and awareness on the ever-yearning field, yet poorly fulfilled comprehension on the discussion of personalized medicine practices and precision oncology. So before we begin, I would like to invite Dr. Rajesh Misri, Director of Oncology at Kokilaben Dhirubhai Ambani Hospital, Mumbai, for the welcome note and lamp lighting. Over to you, sir.
Thank you, Amrit. Welcome you all to Kokilaben Dhirubhai Ambani Hospital. A very good morning and a big thank you for making it on a holiday Sunday for this meeting. Now, whatever had to be said about precision medicine and personalized medicine has already been said by Dr. Amrit, and we'll be discussing all along this day. But I will, take the liberty of telling you about my experience of how treatment for cancer and particularly lung cancer has evolved and how it has become more and more complex. So when I started my career in oncology, and I'll be talking mainly about lung cancer, as a surgeon, the only thing that we needed was diagnosis of either it is a small cell carcinoma or a non-small cell carcinoma. So as a resident, we used to just collect cytology or take biopsy or take pleural fluid for cytology. And with answer of small cell CA or non-small cell CA, the whole treatment was decided. It was very easy. There was no problem at all. But then in 90s, it started becoming clear that all non-small lung cancers are not similar. Adenocarcinomas behave differently, squamous cancers behave differently, and you have different set of drugs for these cancers. So, it became necessary for us to get tissue because cytology was not good enough at times to differentiate between squamous cancers and adenocarcinoma. And then, of course, they needed more tissue to, do various things. So that is when the phrase tissue is an issue was coined in. And there used to be a lot of discussion about importance of having tissue, importance of diagnosing adeno-CA versus squamous CA and other subtypes. And then things kept evolving, from pemetrexed and gemcitabine, Taxol, things like that. Slowly it was realized that, it was not enough to know only subtype of histology, but the oncologist wanted what was happening inside the cells. They wanted molecular data, the genomics of the lung cancer. And hence, tissue, which was an issue, became tissue is the most important issue, because everybody was fighting for tissue to get the diagnosis, to get the histological subtype, and then of course all the molecular studies. So, over this last 3 decades, there have been a lot of changes. And fortunately, I'm a surgeon. For us, things are very simple. It is not complex. You have stage 1 cancer, stage 2 cancer. You go ahead and remove the disease part. But when it comes to medical oncology, things are very, very difficult. It has become very complex, and particularly stage 4 cancers. But thankfully, because of all these advances today, you have a lot of patients, even in stage 4, who are surviving for more than 5 years. In fact, sometimes we feel whether, as a surgeon, we are able to deliver that kind of survival. But that is all thanks to better understanding of the cancer biology, evolution of molecular biology, and all this personalized and precision medicine. So this whole day we will be discussing, on this, and Dr. Sandeep Goel and his team have lined up various lectures and panel discussions where we will be discussing importance of precision medicine in various types of cancer. But before we start the meeting, we'd like to invite all the foreign dignitaries for the symbolic lighting of the lamp, and then we will actually proceed with the meeting. So, Amrit, so may I invite Dr. Ognard? Dr. Oxnard, I'm sure you are familiar with this ritual of lighting of the lamp. Dr. Shetty. Yeah. Yeah. And Dr. Sandeep Goel, yeah.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता.
Now that we are done with the symbolic ritual, we can start with the actual conference. Yeah.
Now, without much further ado, we shall begin with our first scientific session. The topic of our first session is new therapeutic targets in lung cancer. Lung cancer has been a poster child of precision oncology. So, targeted therapy has emerged as an important mean of the disease management for patients in non-small cell lung cancers. So, to discuss this, I would like to invite the chairpersons, Dr. Ajay Bapna, Director and HOD of Medical Oncology at Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Rajesh Mistry, Director and Consultant Surgical Oncology at Kokilaben Dhirubhai Ambani Hospital. I think Dr. Ajay Bapna is not able to join us, so I would like to invite Dr. Maneet Gundwala, Mumbai, Consultant Orthopedic Oncology, Kokilaben Dhirubhai Ambani Hospital. And to moderate the session, we have Dr. Mehboob Basare from Mumbai. He's a Senior Consultant, Medical Oncology, Jaslok Hospital, Mumbai.
The panelists for this session are Dr. Geoffrey Oxnard, thoracic oncologist at Dana-Farber Cancer Institute, USA. Dr. Anuradha Chogle, ex-professor and consultant in charge, medical oncology at Molecular Lab at Tata Memorial Hospital. Dr. Shailesh Bundarde, director medical oncology, Shatabdi Super Speciality Hospital, Nasik. Dr. Bharat Chauhan, consultant medical oncology, Bombay Hospital, Nanavati Hospital, and Criticare Hospital. Dr. Pushpak Chirmade, consultant medical oncologist, Jupiter Hospital, Thane, and MGM Navi Mumbai. Dr. Kshitij Joshi, consultant medical oncologist, co-founder and consultant medical oncologist, MOC, Mumbai Oncocare Center. We welcome you all.
Yeah, Dr. Basade, all yours.
Thank you. Good morning, and thank you, Dr. Shetty, Dr. Rajesh Mistry, Sandeep, and your team for inviting all of us over here. It's wonderful to be the opening batsman of the conference, and we wish all the best to you for the excellent discussions going forward. And today we will be discussing about the newer therapeutic targets in non-small cell lung cancer and the case-based discussion. So I would be giving some cases in between and ask the expert panel what are their opinions and how would they will manage the patient. Time is, I think, 45 minutes. Yes. Is there any timer so that, I will finish within time? Okay, please. Otherwise, I don't want to overshoot thing. We all know that as Dr. Rajesh Mistry rightly said, that the treatment of non-small cell lung cancer, especially the metastatic, has really changed, and we are seeing long-term survivals of the patients who have some targetable mutation. So all the time, our emphasis is on to find some targetable driver mutation and treat the patients according to that, so that we have the longer survival for such patients. And you can very well see from this graph that the patients who have the driver targeted mutation, and if they are treated with that therapy, the survival is probably the longest in such patients. So if a patient of a non-small cell lung cancer metastatic comes to us, so let me ask the panelists, so what are the tests they would like to ask? Because yesterday, Geoffrey and we were there together in the discussion that whether you would like to do the small targetable panel or you want to do full NGS-based or CGP, complete genomic profiling for this. So let me start with Kshitij and from there onwards. So what do you do?
Hello, am I audible? Yeah. So our conventional way is that we are doing the short panel PCR, but nowadays there are more and more evidences coming up, like exon 20 and all may not be picked up with this. So, and many labs of NGS are available, and it is available at a lower cost as well. So whenever possible, we are trying to do NGS in lung cancer.
Possibility, yes. For the moment, consider that everybody is affording. What do you like to get it done first?
NGS.
NGS. Okay. We will come to turnaround time and other thing later on. Pushpak.
Yeah, I also usually prefer NGS because we have newer mutations and driver mutations that we have figured out, and there are targetable drugs that are available. So it's better to have that upfront information. We are seeing that first line usage of these drugs is also increasing, and there are trials that are supporting it. So I go ahead with an NGS usually. I also request them, there are few labs who give EGFR status within few days on the same block by EGFR ALK. So I prefer that approach also.
Okay, so Shailesh, I will come to you, Anuradha.
So I would like to go for a broad panel, but in my practice, I usually go for around a 12 GIL panel, where we routinely get the ones which are available and easily procurable.
Okay.
Otherwise, I would like to do a broad panel.
So practical purposes, what we do is we send the short targetable panel first, and then we like to get the NGS because of the turnaround time. Dr. Jaffrey, what do you do?
At Boston University, we do have rapid EGFR and ALK testing, and then NGS, generally a broad NGS is sent in addition to that. I agree that exon 20 insertions are tricky. Met exon 14 splice site mutations are tricky. In the US, I think that has really shifted to NGS to capture this full complexity. And the difference also in the US is liquid biopsy is so widely available that we're quick to send off a blood specimen and to get that result back within 10 days. I know that's sometimes a little different than the availability in India, but it has very much made NGS much more accessible to patients in many settings.
Okay, Anuradha, in TMH, whenever the sample used to come to us, so what targetable mutations you were processing first, and what is the usual turnaround time?
Yeah. When I had started, it was just a single gene EGFR testing. So naturally, and we used to give it in within 5 days because that's a very important thing for the EGFR. But now over a period of time, now since we know there are many driver actionable mutations involved in the lung cancer, we prefer doing it on NGS. But yes, EGFR should be given first, but minimum 50 gene panel should be there where you have all driver actionable prognostic and predictive indicator biomarkers included in that. So I prefer that, but again, we have to keep the turnaround time in mind.
So I have shown here few target biomarkers, we can say that, which are recommended by both NCCN and ISMO. Are these one you are doing, or in addition, what you are doing?
As it has been mentioned, the PDL1 marker, which has been done parallelly along with the NGS. So these are the very important, as per the ASCO guidelines. Now we have to include all this EGFR, NTRK, ALK, KRAS, MET, exon 14 skipping, and so on. But there are some missing markers like PIK3CA is there. Then many other important mutations like FGFR3, which has been now frequently detected in the lung cancer as well. So we need to add some of these markers. As I said, at least minimum 50 gene panel we should have for that. Because for other markers, you can have a broader markers, biomarkers panel, but as you know that in India, we don't have the many FDA-approved drugs available in India. So for the middle class family and all, I think 50 gene panel, which is relevant for the
Okay. So there are some additional, as she said, that PIK3 kinase mutations and HER2 and MET amplification can also be done on the sample so that we have few targetable drugs against them so that we can treat the patients according to that. Shailesh, let me just ask you, though we are talking of the targetable mutations and other things, if there are the NTRK comes positive, for example, so what do you do in such cases?
So actually, along with this, I would also like to add the tumor mutation burden.
TMB, okay.
Because you might have an IO-IO combination if the tumor mutation burden is positive.
You will also like to get the TMB, yeah. Anybody else want to add any other?
If I would like to add, TMB is not much needed in the lung cancer because we see very low TMB mutations. So I will not prefer that. But yes, for the IO therapy, we can rely on PDL1 and MSI. That is very.
Okay, Geoffrey, you would like to add something?
I have been using TMB. I don't see much MSI high in lung cancer. In those patients with TMB above 20, I can try to avoid the chemo and favor immunotherapy. And I at least in the US, I feel like we maybe give too much chemo, and some of these patients, it's the immunotherapy that's the real magic. And so I'm always looking for patients where I can avoid the chemo, and TMB can help me with that. Are we taking questions from the audience? I see a hand up.
Somebody wants to ask? Yes, please. Let's be interactive, we will discuss. No issues in that.
Looking for TMB?
No, right? And I won't be looking for PDL1 either, right? PDL1 can be false positive in a RET, ALK, EGFR patient. So I very much think the driver trumps. The caveat being, MET exon 14, they can be very immune sensitive. And so for a MET exon 14 or even a BRAF, I'm sometimes thinking about the targeted therapy versus the immunotherapy. But for RET, ROS, ALK, EGFR, in those, immunotherapy doesn't count in my practice.
So even for MET exon 14 skipping, I had 3 cases in which the PDL1 expression was extremely high. None of them responded. And actually, they ended up responding to crizotinib because those were the time when we didn't even have capmatinib or tepartinib. So I will think, if you have a driver mutation, your first objective should be to treat driver and not look for PDL1 or TMB.
Agree with that. The driver mutation is the most important in all treatment perspective. Anuradha, I mean, how can you reduce the TAT, the turnaround time? We know that NGS is the most important, but our patients can't wait. If somebody in India, the situation is that if you tell somebody cancer and you say the treatment will start after 10 days, they will, go haywire.
Yeah, first of all, you need to have in-house your molecular biology lab, so to reduce the turnaround time, because many of the times the time is wasted in outsourcing it. Second thing is one, we have to immediately start with the at least with the DNA extraction or the RNA extraction and keep it ready. We should not go with the batch-wise thing. But yes, collectively on NGS, we need to go on the batch-wise thing. But nowadays, you get to see for Thermo Fisher, like where they have Genexus and they have their own cloud. So you can very well go into the 5 days turnaround time, and you get to see, like, what a few labs have started giving the reports of NGS within 5 days also.
Yes.
So that's very important.
Things are changing now. We can get the NGS reports little early also. The other question is the liquid biopsy. Geoffrey, do you do the liquid biopsy only for monitoring or at the baseline also along with the tissue?
One trick to reduce the turnaround time is to send the testing earlier, right? And so if we are waiting for the path specimen, so for example, the pathologist won't let me test it until they fully finish signing it out. Wait, I'm not ready yet. Hold on, a couple more days and I'll sign it out. And all of that extra time delays the molecular testing. What's great about liquid biopsy, at least in the US, we're sending it earlier, right? The patient presents with advanced cancer, send the blood out while the biopsy is pending. And so I think there are some operational tricks, as you described, that we can use to move things along and get that result back faster.
Okay. Anybody wants to add liquid biopsy?
So definitely when the tissue is an issue in lung, and because many of the time tiny tissue is a very important criteria we get to know in the lung cancer FFP blocks. So there I think we shouldn't wait parallelly. If the patient can afford, we should go for the liquid biopsy testing.
Yeah, Shailesh.
I just want to ask you, do you do both together, the NGS on the blocks as well as liquid biopsy? And does it add any additional information, especially the liquid biopsy might get additional mutations as compared to the tumor block?
So we published on this recently. If it's a good tissue specimen, if it's a good tissue NGS, you should not need liquid. I don't think liquid adds anything, and our evidence is that the extra liquid biopsy only adds cost. The question is if the tissue specimen's variable quality, right? If the tissue NGS might miss something, or if the tissue testing is more limited, or if it's a few genes, that's where the liquid biopsy can add. So I think if you trust your tissue NGS, you shouldn't need liquid biopsy. But if you're unsure of your tissue result, that's where liquid can be additive in my experience.
Yeah, I agree with you for that. But many a times there is an intra and heterogeneity which is there in the FFP blocks. So spatial and temporal heterogeneity is there. For that matter, to have a false error in the negative or the positive samples, I think liquid biopsy parallelly, if you do it, will give you the comprehensive report.
Especially for resistance, right?
Yes.
For EGFR resistance, I very much agree. Liquid can be additive.
So we are fortunate that we have.
Sorry, just a question. How many times we can start if there is no it is not possible to obtain the solid biopsy? We done the liquid biopsy and we end up with getting some random mutation KRAS, maybe they're in other tumors. So can we rely on that, or we have to start?
If I see it's one of the reasons I like having all of the KRAS mutations on the panel, right? If you see a KRAS mutation, driver negative, assuming this is a validated liquid biopsy that doesn't have false positives, that's a validated KRAS driver, start immunotherapy. And so that's how I use liquid biopsy to increase actionability.
I think Anuradha, we'll go ahead. Because we have a lot to
I
cover.
would like to add over here, suppose if you do, get only KRAS G12C.
We are coming to
Okay.
KRAS. So because we are seeing the newer, so I'm coming to KRAS later on. So we are fortunate that we are getting a lot of EGFR mutations in our patients, and that's where the treatment is easily available at the lower cost. But unfortunately, there are certain other hidden, or I would say that the complex EGFR mutations where the treatment probably is the difficult. So I will just show you the one case. She's my first patient where I sent to the foundation one, lung adenocarcinoma, and this was the report. EGFR amplification with exon 19 insertion, mate amplification, there was an RET fusion positive, there was an ALK fusion positive, but this is not the regular ALK, but it is the Stern ALK. There was MYC amplification and CCDN1 amplification. So you just name it. This is the first patient, and you got this googly. So let me just start. Yeah, I mean, you give the report.
How many prior lines of therapy?
Sorry?
This is previously treated, resistant?
Okay, so I will come to that. Okay, suppose this is the patient who had come to you, not targeted. I will give the history later on. But if suppose this patient comes to you today, let me start. Kshitij, what will you do?
So my first inclination is start with TKIs, EGFR, like osimertinib.
TKI for the EGFR.
Yeah.
Okay.
But there are so many factors over there, so expert can.
Yeah, no, I mean, that's okay. I mean, whatever you would plan it out. Pushpak?
So a really challenging situation here. It's difficult to identify what would be the driver. I think this is a heavily pretreated case because we have so many. I've never seen EGFR ALK together. But we also have MET amplification, which probably is an indicator that it's resistant to the EGFR TKI. I would probably, in this case, if she has not received chemotherapy, I'll probably choose chemotherapy because that would be the best option.
Just to add.
Yeah,
So,
yeah.
like as per the Tata trial, TKI plus chemo might be my first.
Okay, Shailesh?
I don't like this report. But anyhow, if you want to go for some combination, I think there is some studies with MET inhibitor with TKI, EGFR inhibitor. Maybe that combination, if finances is not issue, maybe tried, or I would just like to go for chemotherapy.
Okay, now Geoffrey. Now you have to justify the report.
I would be interested in the relative variant frequency. I presume the EGFR is the driver. If one of them is a dominant subclone, I might try a combination. Personally, I've given EGFR with MET, can work great. I've given EGFR with RET. I've given EGFR with ALK. These can each work on their own for resistance for years, but this much heterogeneity, I assume this patient's had prior lines of EGFR therapy. I'd probably give chemo, maybe with an EGFR inhibitor. But this is pretty daunting, and I assume this is a liquid biopsy, given all the clones together.
So the ALK is also a case report. You know, the ALK Stern, I just saw that there was a case report of this is a very rare, 1% of the ALK positives are having this ALK. So let me give a little background of this case so that this was the first means it was in 2018. So the things were just, everybody was learning. The laboratory people were learning. We were learning how to treat the patients. So this lady had a metastatic disease, all driver mutations, EGFR, ALK, and I think one more was done that time in 2018, were negative in the lab, done wherever it was. I won't name, but it was negative. So she received chemotherapy, responded well, PEM carbo and PEM continued, then progressed, then second line therapy with the DOSI, and then further progress, Nevo had come, so we started with the Nevo, no response, nintedanib had come, so gave the nintedanib, no response, meanwhile developed the brain mets, received radiation, very poor GC. Practically, family said that we want to finish the marriage in the family, give something. So I just gave erlotinib and patient went home. 15 days back, she came walking and running. So I looked back whether I was wrong in reading the reports or what. but it was all negative. Then I sent the liquid biopsy. This was the first patient, and this is what it is. So then I changed to osimertinib, and this patient lived for almost a year. Then she progressed. Another thing, she didn't respond to the alectinib in the second line. Yeah, with this, I mean that there was nothing available. It was the osimertinib was available, so she responded with this for almost a year with the osimertinib. So yes, go in. Okay, I wanted to, but EGFR was almost 61%. That was the driver mutation, and she responded well.
Probably that will help us to choose a treatment.
Right. There were other 2-3% like that, but that was 61%.
And if we had seen her today, maybe I would start her on amivantamab, that targets both EGFR and MET.
Okay, so this was an interesting case, so I thought of sharing with all of you. And then the next patient came was exon 19 deletion. This was another patient who had exon 20 insertion. I'm sorry, exon 20 insertion. So how do you treat today, Shailesh, exon 20? Because these are rare. What percentage of your patients, Shailesh, you get exon 20? Very rarely?
Last 2 years, I have seen 2 patients.
Rarely. I mean, percentage-wise, we may put it around, say, maybe 5-10%?
5 to 10? No, not even that.
Not than that?
Less than 5%.
Lesser than that, okay.
So we have a drug, amivantamab, which can be tried. Never given it, but there is a drug which is available. I think mobocertinib is another one which can be tried.
Okay. Yeah, Pushpak.
So I've had these mutations coming up lately. I have had 3 patients in the last 6 months, maybe with exon 20 insertions. So as per the data, I've started them on chemotherapy as of now. They have responded well. For the second line, if progressing, then I'll be probably considering amivantamab for them as the second line agent.
Yes, sir. For my last 2 mutations were found. I think it is rare, but still it is there. So the chemo was first started. That time I reviewed, there are some real life evidences. They said that the combination of therapy, which addition of some chemo along with that, addition of therapy with TKI plus chemo and BEV addition have shown some responses that I have read. But currently my approach is to start with the chemotherapy, and now the patient is progressed. So there is a compassionate program for mobocertinib available now. So that is.
Okay, so the data suggests that somewhere around 12% of the patients have the around exon 20. So let me ask Geoffrey. I had next patient exon 20 and exon 18 deletion. Exon 20 plus 18 combined. How will you go ahead? Metastatic disease.
It was exon 20 insertion or point mutation?
Point mutation.
Right. So S768I is an exon 20 point mutation, which can co-occur with exon 18 mutations. I'll treat those patients with osimertinib or afatinib, and I think they can respond. I do think, exon 20 is tricky. There's T790M, which osimertinib can work for, S768I, which can be a co-mutation that TKIs can work for. But for the insertions, I was involved in mobocertinib development. I've had some good experience with mobocertinib, and that's been my favorite drug.
So the exon 18 and 20, my patient, initially as she was in severe pain and the reports exon 20 came little later, I had started already on chemotherapy, the pain disappeared. So I just continued 3 cycles, and after that response was good on the PET scan. Then I shifted to osimertinib, what he said, but unfortunately after 3 months of osimertinib, she progressed. So exon 20 have poor survivals, as you can see from here also, as compared to the others. The options what we have are mobocertinib as well as amivantamab. These are the various other approved therapies. But NCCN, the ISMO suggests that you can go ahead with the chemotherapy first and then can go ahead with the targeted therapy in second line. Anybody wants to add anything about the exon 20 here? There are many other new drugs in exon 20 which are in pipeline, Posio and other drugs are there. We don't have any experience. You want?
Just a question for Dr. Jeffrey. So does exon 20 insertion have a high tendency to have brain mets? Because these patients which I have been treating, all three have brain mets. I don't know exactly.
In my experience, the problem is the drugs don't get into the brain. And so
They presented de novo with brain.
I don't think it's a different biology, but I do find that the brain mets are more problematic because the drugs won't work like osimertinib will.
Just a question, because I was a part of one panel in the recent past. They said that exon 20 mutation has to be treated not as only one mutation, all sub-mutations, and has to be analyzed, and treatment is depend on that. That certain sub-mutations are responsive to first-line TKI also. So your point.
We have the data. I mean, just I showed because we have to cover so many things. But recommendation at present is that to go ahead with the chemotherapy first. Yes.
Thank you. Thank you. Just short comment that in the afternoon, I will show a case report actually of a non-small cell lung cancer case with an exon 20 mutation. And actually that patient responded to afatinib extremely well for years in complete remission. But that was a very particular type of exon 20. So we have to be careful generalizing, even on the level of the exon. We have to really specific of the exact mutation, but there can be a difference between drug sensitivity based on the exact mutation. So that particular exon 20 responded to afatinib. Thank you.
So going beyond osimertinib in our regular 19 and 21 mutations in the non-small cell lung cancer, there are fewer other, like formotinib is the another drug which as compared to the gefitinib had shown a longer, and I think probably it is the same kind of response what we see in the osimertinib. So Jeffrey, are you using any of the other than osimertinib practical wise? No, it's osimertinib is probably the last at present, yeah. Maybe there might be few something.
Lazertinib is coming in combination with amivantamab, but it's not really being used.
Okay. So the first patient, what my was there, so there is a data of EGFR mutant with MET amplification like TEPO plus gefitinib, and this is what the inside data is there, where the median OS was 37.2. So if that would have been there, probably this would have been the treatment, tepotinib plus gefitinib would have been given to that patient.
My only caution on that is that's high-level MET amplification, right?
Yeah.
Some reports will show you this marginal MET amplification. MET inhibitors won't work. Like, be judicious on who you treat really as MET positive.
So my question to you from the foundation point of view, I mean, not as a clinician, but as a foundation point of view, that when you see such reports, so do you segregate something this, or you just give percentage of allele per frequency like that?
Putting on my foundation hat, the report only reports what's really there, right? It's been really titrated to not have any false positive errors. I think I trust them when I see them on a foundation report. I think it can be variable across tests, though.
Okay, so the next case was MET skipping mutation of exon 14. Anybody has experience now? What percentage of your patients you get this thing? Shailesh, any experience
Not
with such
seen
patients?
any patient having this.
Or rare mutations?
So probably de novo it's a little rare, but after EGFR, I've seen few patients who have developed this as a second
mutation, second line you can get that.
As a resistant.
Anybody from the, yeah?
We have reported this. We had seen around 2.7% in both predominantly adenocarcinomas, and lately when we have started doing squamous. So largely, this is around 2.7%.
So a small percentage of the patients can have an de novo, and we have the two drugs which are available now here in India as well, capmatinib and tepotinib. You can go ahead and give the chemotherapy to such patients as well, and then if not responded, then one can go and see the other things. So these are the trials for all those things. Now let's look to the KRAS. So okay, so let me just come to another report what has come to me from the foundation. You can make out from the font and the colors of the reports. So this is the again, metastatic disease, KRAS, G, you can see that 12D. What do you do in such patient? This patient has already received the chemotherapy plus the immunotherapy and progress from the day one. This is the report only coming in. We did multiple times because of the progression of the disease, but this is the only thing. Yes, Anuradha, you were saying about KRAS. So
Is this a liquid biopsy report?
this is liquid biopsy report.
Okay, so then we can consider 0.37% as good enough to take it positive. But as we don't have any actionable drug for this G12D, so I don't think we should take it into consideration. Only we should have a close follow-up with it because it's a bad prognostic indicator as well. But if it was G12C, then again, and only that driver actionable mutation, then I think we should go, though we have the drug for that, but if it is not available, nowadays the mature data is coming up that we can have the IO therapy if there is only KRAS positive.
So what percentage of Indian patients have 12C? In your series, in TMH, what was that?
This looks a little bit high, not 42%, but definitely we have around 12% or so for the G12C.
Okay. We do get the KRAS intermittently, but 12C is the most commonest, and we have the drugs available. Anybody has used KRAS TKI? The experience in India, the drug is not available, obviously, so compassionate or somebody might have used. So let me ask Geoffrey, what is your experience with the KRAS mutant with the targeted therapies?
These drugs definitely can work. I don't think they work all the time, right? They can be tolerated. They have some GI side effects. I think of them as a little less reliable than MET inhibitors, but worth a shot. I still, when I see a G12C, I look for a clinical trial. There are more and more combination therapies being attempted. When resistance happens, it's incredibly complex. Your resistance case, I mean, that's what G12C resistance looks like. Lots of subclones. And so combination therapies to prevent resistance are probably going to be the next generation of treatments.
So fewer drugs like adagrasib is the one which has been just presented, and you can see the response. It's excellent response. I mean, even in KRAS have been good. There is another monotherapy drug which is GDC 6036, which is also showing a good response to this thing. There is one sotorasib plus immunotherapy. This also is showing a good kind of response in few cases, so where they have been treated. So, you know, its KRAS is not at that bad story now. Probably we are going to get some better results and other things. So any other targets you are looking other than this? TROP2?
So HER2, I have had recently few patients.
HER2, yeah. So you look HER2 amplification, mutation.
It was amplification.
Okay.
For 2 patients basically. So I've enrolled them in the trial of TDX, which is going on at Tata. Upfront, first line TDX, which allows a crossover also. And these patients have been young patients, about 30-year-old male. One was a 30-year-old male and one was about 40-year-old female. So that was one mutation I have been now recently been adding to the.
Okay, so as you said HER2, let me go down. HER2 is that we have now ADCs coming in the lung cancer, and trastuzumab deruxtecan is another one where in HER2 mutant non-small cell lung cancer, and you can see the response, which what are showing an excellent response, though the OS and PFS are not that great, but yes. So these are the first few where things are doing better. Geoffrey, what is your experience with the HER2?
Trastuzumab, not that reliable in my experience with HER2 positives. I have occasionally had a great afatinib response to a HER2 mutation, but I agree that TDXD seems to be more reliable across these HER2 positives. More of the published activity is in HER2 mutants, actually. Is yours are amplified? So that's cool. Amplification has been hard to treat, and that's exciting if we can really start to treat this with these new drugs.
So anybody looking for the TROP2? Because these are, again, you know, some newer antigens which have been there, which are linked to the prognosis and survival in non-small cell lung cancer.
I tend to think of these antibody drug conjugates as chemo on a stick, right? They're really just chemotherapies. They're not precision therapies. But for your KRAS G12D, like this is a next generation of chemo, effectively, precision chemo that might be an idea down the line.
Okay, so we have a few data of the sacituzumab govitecan in the patients who have TROP2, and they are all, I mean, I think there is slide for that sacituzumab. There is another one called as dato that is also, it's coming as a new drug, and here this is the, you can see this, the graph, which is of the response rates of the patients who receive the dato. Okay, so these are the few things which are quite common. And if you don't get any mutation, this is the last of my presentation, and if you don't get any driver mutation, which happens in more than 50% of our patients, so how do you go ahead and do the manage? Shailesh, what's your approach to the patient? Upfront chemotherapy plus IO to everybody, or yeah, go ahead, please.
So it depends. You will do the PDL1 levels. If it's more than 50%, not too much of a tumor burden. I mean, you have few lesions here and there. Then I would go for a single agent IO. Otherwise, in all the patients, I will be IO plus chemo.
IO plus chemo. Anybody, any difference of opinion or just?
So yeah, definitely PDL1 I'll do. See the percentage. I'll also look at bulkiness of the disease. So how the patient has. So if the patient has an extensive disease, I'll probably start with an IO chemo combination, in spite the levels being more than 50%.
Okay.
Just one question, because we would like to use IO to everyone, but unfortunately in India, the costing and everything. My question here is, if the PD-L1 is highly expressed, what is your take on low dose immuno that is currently coming into picture? Can we use that in lung, which is?
See, the low dose thing is all for the cost saving. Let's not discuss the scientific flora where here we are discussing that patient can afford anything. Those are things where, in day-to-day practice, we can say that, but
scientific evidence.
You are going to get the PDL1 expression done for all. If the PDL1 is less than 1% or 0%, how many of you are saying that immunotherapy has no role to play? Or everybody is willing to give? Yeah, we are all sold out that even 0% immunotherapy will work out. Geoffrey?
I think the foundation of our therapy, if driver negative, has become immunotherapy. And the question for me is, do I need the chemo or not? Yeah. And a lot of my patients honestly don't want the chemo. If they're really high tumor burden, I see bevacizumab on here. If it really needs a response, I might add that. But my preference is to find immunotherapy alone whenever possible, because I think that's the real magic for these patients.
So this is the FDA pool data in the first line setting where PDL1 expression is more than 50%. I mean, you can't directly compare, but you can see over here, those who receive chemotherapy plus immunotherapy have better PFS as well as OS as compared to the immunotherapy alone.
I think they found no significant difference in this analysis, which is the chemo. I agree, we use the chemo, but it's a short-term solution. What really changes the biology is the immunotherapy, I think. So there's some debate still, and there are randomized trials ongoing in the US.
And sir, these trials also have a slight bias in patient selections, because combination is usually selected for fit patients and IO only is for those patients who maybe not tolerate the chemo. So that bias.
Elderly patients probably, yeah. Yes, Hemant.
So, Dr. Jeffrey, I'd like clarification on that comment. For you, for a non-small cell lung who doesn't have a driver mutation, everybody gets immunotherapy with or without chemotherapy. Is that right?
I agree. I think that's the foundation of therapy, assuming no contraindication.
Yeah, sure. Okay. So that's a little bit of revolution for us here in India.
And I will acknowledge, though, what dose of immunotherapy, how much immunotherapy, I'm not quite sure. But I want to get a little bit into them because it has the potential for such dramatic effect.
So any choice of immunotherapy, forget about the sponsors. I know, what is in clinical practice? What do you start?
Usually pembrolizumab or nivolumab, because we are used to these drugs, but atezolizumab is also.
Okay, first line nivo data isn't not much.
No. So first line mostly pembro.
Pembro, okay.
So it would either be pembro, which is I'm more comfortable because I've used it in many patients, but atezolizumab is also one because of the cost constraints. Atezoli is a little more
cost effective.
So I have been recently trying to prefer that if the patient is not very affordable.
Shailesh?
I agree with Dr. Pushpak, Pembro or Atizo, and second line, it's Nivo.
So, Geoffrey, it's the insurance drives you to choose, or you have?
Most widespread use is pembrolizumab because of the extensive trial data. The Ipsos trial is interesting to me for my patients who don't want chemo. This is a randomized trial of atezolizumab versus single agent chemo, and they unselected, and they found immunotherapy can work. So I think there's some more creative uses I'm looking for from, and I like all the sponsors because it pressures each other to be more creative with their use of these drugs.
So I had one question. Where do you prefer an IO-IO combination as an upfront strategy? Which specific patients do you?
I don't currently use IO much in first-line lung cancer. I think it's mostly in BRAF negative melanoma where I see it used.
So there are few trials people are trying to look at it, even Pembro with EP. There are combinations, whether it will work or not work, we don't know. But yes, what happens when the patients who received, like my patient, which I showed that the KRAS was positive, she has already received chemotherapy with the atezolizumab, second line chemotherapy with atezolizumab. The mutation has not changed, everything remains the same, that KRAS 12D which was there. So what kind of an option after failure of such things do you in practice?
Docetaxel or the Mirati G12D trial.
Okay. So chemotherapy, she already received second line chemotherapy, Rossi along with that. So not much of options are left for such patient. People are trying durvalumab and there are various other drugs, but the overall survival for the such patients is poorer because once they fail on and there are no targetable mutations out there. So
just question, immunotherapy after progression over immunotherapy. So take on.
I mean, in practice, what we do is that we change the chemotherapeutic drug and go ahead with that. But to change from one Keytruda to the atezolizumab usually is not done. We try to continue with that. Okay, so this is my last slide, and if any house, yes, please. P53 mutations. The first patient had P53 mutation as well. Yeah.
On first liquid biopsy after diagnosis, Osimer 80 milligram was started, and TP53 also was there in that. And another variant now has come after.
No, let's one by one. What is your opinion, Anuradha? You were saying about P53. What is prognostic implication on this patient?
TP53.
Is there any medication is available for TP53 and its new variant also?
I don't think, I think recently the TP53 drug is coming up, but I'm not sure whether it is in India. But we need to take it into consideration the VAF of the TP53, whether it is close to 50 or whether it is close to 100, because then it indicates there may be a familial history of having the lung cancer in those patients, because it can be heterozygous or it can be homozygous if it is close to 50 or 100. So right now, I don't think we just need to take a close follow for the TP53 if it is present at the baseline and not in the follow.
Is there any research is going on?
It is prognostic in EGFR mutant lung cancer for a bad prognosis. The FLORA-2 trial is looking at osimertinib with chemo. I wonder if these prognostic features might steer some patients toward chemo TKI versus TKI alone. There is a drug coming for the Y2C mutation. It's in phase 1 studies globally, but it's not clinical yet.
So we have just 2 minutes and 2 questions, 1 minute each. Comment, no question, okay? You can introduce yourself.
TP53 clone is the dominant one. You could send the patient for a clinical trial for V1 inhibitors. Especially the research is going on, but in SCLC models.
Yes.
Jeffrey, how often do you see TP53?
All the time.
All the time. So in my opinion, 80% of lung cancers have TP53 alterations.
I would say more like 50%. I do think it differentiates a bad prognosis versus a.
As long as you are using a biomarker-directed therapy, I don't see any difference in the responses. Maybe in chemotherapy, probably you will have some sort of a resistance. And my one comment to what Anuradha said. So if you have a TP53, PTED, PIK3CA, if these STK11, these are the 4 mutations which are so common that you don't go chasing based upon the WAF, the germline alterations, or the Frau-Mani, or for juvenile polyposis syndrome, etc.
Thank you for the comment. Sorry, we finished. We are dot on 10 o'clock. Thank you. I thank you, my panelists, for excellent discussion, and thank you, everyone. Thank you.
Thank you. Thank you for the excellent discussion, and we're bang on time. We start with the next session.
That was an insightful discussion by Dr. Mehbood Basari. He's a senior consultant, and he's also a current president of Indian Society of Medical and Pediatric Oncology. So moving on to the next session, the next panel discussion is on the recent advances in the therapeutic strategies of triple-negative breast cancers. As we all know, triple-negative breast cancer is very common in Indian scenario. It's aggressive, and it has a complex genomic profile. So various molecular subtypes has been defined in triple-negative breast cancer based on the distinct phenotypes and transcriptomic analysis. So with that, I will invite the chairpersons, Dr. Mandar Nadkarni, Mumbai. He's a senior consultant, surgical oncology, breast and colorectal oncology, Kokilaben Dhirubhai Ambani Hospital, Mumbai. Welcome, sir. I would also like to invite Dr. B.C. Goswami. He's a director, State Cancer Institute, Assam, professor and a radiation oncology department. And I would like to invite our moderator, Dr. Shona Nag. She's the director, oncology, Sahayadri Group of Hospitals, Pune. And also the moderators of the session, Dr. Nilesh Lokeshwar, Mumbai, Senior Consultant Medical Oncology, Asian Cancer Institute, Mumbai. We have Dr. Gohar Shafi. He's a Vice President in Translation, Research and Computational Medicine at INDX Technology and the Chief Informatics Officer at One Cell Diagnostics. We have Dr. Rakesh Taran Indore, DM Medical Oncologist, CHL Hospitals in Indore. And we have Dr. Bharat Bhosle, Mumbai, Medical Oncologist at SL Raheja Fortis Hospital in Mumbai. Dr. Satish Sharma from Ranchi. He's a consultant medical oncologist at HCG Ranchi. Welcome all the panelists and the chairpersons. Over to you, sir.
So thank you very much, everybody. Welcome to the breast panel. So without spending any more time, madam, maybe we can start the panel discussion. Dr. Shona Nag, very senior medical oncologist from Pune, and a very good friend of ours. So thank you very much, madam, for coming all the way here.
Thank you very much for having me here, and good morning, everyone. May I have a list of all the panelists, please? So after that wonderful session where we were literally spoiled for riches with lung cancer, I'm going to try and do a little bit for the cause of breast cancer. And although we don't have that many mutations to show off, we certainly are progressing in a very molecular direction. So to set the stage, the last few years have seen 3 new FDA approvals for triple-negative breast cancer. That's the mandate today. We traditionally define it as ER, PR, and HER2 negative on IHC. The clinical behavior of the ER low group mimics that of triple negative, and PAT-CR rates also similar. The use of neoadjuvant systemic therapy has increased substantially in this subtype, Risk-adapted therapy for residual disease is very important. It's now important to know the nature of this residual disease, and the correlation of PAT-CR with EFS has also made choices very, very complicated for us. So if we go back, in 2016, Lehman came up with this molecular classification of 6 different subtypes, which later on was cut down to 4. And a very practical classification was put forward by Bernstein, where he had just 4 subtypes: BLIA, which is the basal-like immune activated, the immune suppressed, the mesenchymal, and the luminal androgen receptor. Now, all these classifications have been great, and we do them by gene expression profiling, but it's important to understand the heterogeneity of the disease and help us to figure out predictors of response. But these are more of research assays. We're not going to use them in the clinic. And biomarkers in triple negative, for example, BRCA and PD-L1, are very useful in choosing our treatments today. So the discovery of genomic drivers may redefine molecular classification beyond estrogen receptor and HER2. And as you can see in this diagram, you have the PIK3AKT-mTOR pathway, which is largely mutated in almost 40% of advanced breast cancers, the DNA repair pathway, the estrogen receptor signaling pathway, the cell cycle regulators, and the growth factors. So let's set forward a clinical case, and this is something you will all identify with. You've all seen it in your clinic day after day. She's a 35-year-old lady who's a IS officer, that is in the Indian Administrative Service, premenopausal, evaluated for a right breast lump in February last year, and clinically a T2N1 disease. On inquiry, her maternal aunt died of breast cancer at 50, and maternal cousin has recently been diagnosed, so there's a strong family history. The core biopsy of the right axillary lesion shows invasive ductal carcinoma, grade 3, poorly differentiated adeno, and a triple negative disease. The PET scan shows localized disease with a 3-centimeter primary and multiple axillary lymph nodes. So let's start with Dr. Bhosle. What are your neoadjuvant choices? And are there any other tests that you would like to consider at this stage?
Definitely. Young patient with strong family history and cost is not a constraint, I assume, over here. I would like to investigate. My neoadjuvant strategy will be based on doing a germline counseling and getting the germline testing upfront. Now, I can look at it now in 3 ways, using the platinum in the neoadjuvant setting, but I need to know the BRCA status.
Why, if you didn't have a BRCA positive, you wouldn't use platinum?
I would use, but then if the residual remains, and if the patient is BRCA positive, I would be using a PARP inhibitor in the adjuvant setting.
Right.
Because that clearly indicates those patients who are not achieving PAT-CR are benefited out of PARP. So that 5% of the population I want to rule out in the beginning only. Second thing, I would also request for PD-L1, in case the BRCA is negative and the patient opts for immunotherapy, this is the best place to use the immunotherapy in triple negative breast cancer. And third thing, those for the cost content patients, if everything is ruled out, I would like to use the Tata regimen where 8 weeks of Paclitaxel carbo along with the EC upfront. Even I won't mind for the node negative, a little bit tumor which is more than 2 centimeter. I would use that regimen because you get a PAT-CR for less than 50%. The delta for response rate PAT-CR is amazing. And that is true in our population of patients, not the Western population of patients. So it is better to do all the biomarker upfront.
Okay, Dr. Nilesh, the turnaround time for the BRCA is 4 weeks. Are you going to wait that long to start the neoadjuvant therapy?
So the initial BRCA report is not really going to impact my NACT. So my choice of treatment based on the recent data that's coming from Tata also would be to incorporate a platinum in this. So a dose-dense therapy including a platinum-based therapy, so an AC or a EC followed by 8 or 12 week of Paclitaxel carbo would be my standard of care. The BRCA would help me down the line for the maintenance adjuvant therapy, also from risk reduction therapy if that's being planned for this patient. And additionally, while I might do a PD-L1, it won't impact my initial treatment choice. So even if I'm going to consider using pembrolizumab as an IO, as an NACT drug, it's for all comers, not just for patients who are PD-L1 positive.
Dr. Rakesh Taran, do you agree? Would you test for PD-L1 upfront? Is it necessary to start IO in this patient?
No, I don't feel so. It's the recent data which is saying in any triple negative, you're supposed to start with IO plus chemo and then assess for the response.
Do you routinely, Doc Satish Sharma? Yeah. Do you routinely send BRCA upfront?
Yes, ma'am. In all the TNBC patient, we send it upfront because then the report will take time.
Is
and
there
then
any
it's-
age cutoff you use?
No, ma'am. Like on TNBC, we are sending it.
All right.
So, to address
such a strong
your
family
last
history, ma'am.
question,
yes.
To address to your last question,
Yes.
any other test, will you not consider mammography at least to evaluate the contralateral breast?
Sir, we are assuming all that is done. We are talking from a purely a precision oncology, but I take your point. It is well taken. We do see many patients with a PET scan, breast cancer, and no mammography done. So yes, point is very well taken. So, all right, so these are all our chemotherapy regimens. There's a very old meta-analysis showing that platinum certainly does improve the EFS. And these are the data more in detail, nice hazard ratios of 0.56 and 0.66 respectively. And our very own Tata Memorial data. It's a shame Sudeep is missing this, but 720 patients randomized presented at SABCS last year. The results were driven by 70% of women who were below 50 years of age. There was a delta of 14% improvement with the addition of platinum, a EFS benefit of 12.5%, and an overall survival benefit of 11.2%. And this is certainly not negligible. I think it should become standard of care. So the patient opts for IL, and this goes along with the dose-dense AC and paclitaxel carboplatinum. And after completing 3 cycles of pembrolizumab with AC, the BRCA report is available. So can I ask Dr. Shafi to comment on this report? Sudeep, you don't get away. You sit right here.
So looking at this report, it's looking like that is a BRCA germline mutation, and therefore, this patient is deficient in homologous recombinations. As a molecular person, what I understand from this, this patient could very much benefit with platinum-based therapy and PARP inhibitors.
Okay. Anybody in the panel notice anything with this report? Any issues?
T53 along with the BRCA.
Yes. And what is the variable allele frequency, VAF?
83%.
So does that tell you something?
So in the first panel, Dr. Anuradha mentioned anything which is no VAF of more than 50%, one should
Anyone
counsel it.
from the audience notice any issue? Yes.
I think the VAFs are too high.
Yeah.
Any VAF between 0.4 to 0.6 is good for a heterozygous germline alteration.
Right.
When it is going to something like 86 or 88, I'll be a little wary.
Yeah.
Why shall that be so high?
Yeah.
And both of these are deleterious. Both of these are deleterious alterations.
Yeah.
One is a splice site, and the other is leading to termination after 106.
Any comments on the sample set? So we ordered a HBOC panel, and the registrar by mistake sent off the blocks. We wanted a germline HBOC. All right, so that's a little bit of a catch here. So what would you do next?
So this was actually a tumor tissue alteration.
Correct.
Okay, then it's fine. Then it's fine. But you said it's a germline. Then I will probably do a Sanger to confirm whether it truly exists or there is a problem.
So we did a germline, and we confirmed that the P53 was a somatic mutation, and the patient had the same founder mutation in BRCA1. Okay. So I'm going to digress a little bit since we are talking about BRCA. So this is another patient I had very recently. She's well. She has absolutely no family history. She's 38 years old. She presented with fibroids and an incidental breast lump. And as she was young, below 40, ER positive, we sent off her germline status. And this is what was reported. Dr. Shafi, any comments?
Yeah, so I would like to see here, again, VAF here, but seeing both BRCA1 and BRCA2 together, which is not that common.
So the VAF is around 60% for both.
60%. So maybe, it could be then germline. And yeah, I think that's what it is.
Is this in the blood?
Yes.
So what's the confusion? So I'll tell you the thing here. The problem is that very, very few patients have coexistence of germline pathogenic mutations in both BRCA1 and BRCA2, but it is reported. If you look at all papers, the last row is BRCA1 and BRCA2, which is very, very, very uncommon, but it is not reported. And ideally, because these are heterozygous, most often heterozygous, the variant allele frequency should be as close to 50% as possible.
Possible, right.
So that's,
So
I mean,
any
this would be
confirmatory
very
test?
uncommon.
Any confirmatory test you'd want to do to ascertain this is an accurate report for the variants? Is there anything else you would like to do? No, I'm just asking the audience.
I mean, you can do a Sanger sequencing if this was NGS, but sometimes you do it, but most often you don't.
But we did it because it was so rare, and the co-occurrence of double mutations in the BRCA, both BRCA1 and BRCA2, have been reported as case reports. They're not very common. And this is probably an index case. Would it be useful, any of my panelists can take this, to test the parents? Although my argument is she should have presented much earlier had she inherited one each from her parent, but would it be worth it?
It would be useful. You may open a can of worms as well, but
Yeah.
anyways, you should test the parents, and maybe, one is inherited from the paternal side and the other one is inherited from the maternal side.
So
It
you
is
would
possible.
test, so you would test the parents for both mutations.
Yeah.
Right? And
So one question, was it a
Yes.
genomic DNA or a liquid biopsy? This test,
This is genomic DNA, blood.
genomic DNA.
Yeah.
Okay.
From the Buffy coat.
From the Buffy coat, I mean.
I mean, I'm answering for you, but I suppose that's the
no,
case.
you jolly well, this was your panel, Sudeep. Okay, so would somatic testing help at all? You've got two mutations. Is there any other information you would gain except academic from the doing a somatic?
The possibility of reversal of BRCA mutation.
Okay, that's one. All
that you
right.
may find.
The others, you'd possibly get some information as to the driver. If you did the somatic, it would tell you which one of those. Yes, please. Yeah.
It's amazing. I'm telling all my presentation from the afternoon. So I will present a case with a triple negative breast cancer case with a BRCA mutation, who we did a somatic sequencing, and it turned out that it was not really triple negative because there was a tyrosine kinase mutation in the EGR2. So
Right.
it was actually a driver mutation in the ERP2. So
Okay.
that is why it was worth to look for a driver, because BRCA is helping the tumor to develop, and it's now targetable, but still we should know the real driver in this case.
Right. Okay. So, Sudeep, we did present the TMH study before this, and we talked about platinum. So we finished the treatment.
No, but I will beg to disagree with you that you should do a somatic testing if you've got the germline mutation. I mean, what, I suppose you're asking for a comprehensive genomic profiling. Is that what you're asking, or what somatic testing? For
No,
these
just
two
to know whether BRCA1 or BRCA2 is that, like I said, it could be an academic exercise.
but-
Would you be interested in knowing?
No, but somatic testing for what? For these two mutations?
Yes, to know which is the driver.
If they're in the germline, for sure they will go into the tumor. because every single cell of the body will
Correct,
inherit
but won't the frequency tell you
the
something?
no, but that will not tell you whether it's a driver or not. Why would it tell you? I mean,
So that was
because
my question, yeah. So I wanted
every
to know.
single cell in the body contains 50% of those mutated gene, the mutated protein of each BRCA1 and BRCA2.
Right.
So I don't think that somatic testing will help
Help in
you
any way.
decipher whether
Point taken.
it is a driver or not.
Okay. So we've already established that immunotherapy with chemo in the neoadjuvant setting. Yes.
Yeah, just one comment. Yeah, I mean, you're absolutely right, but of course we need also an LOH of the, so typically we see a silencing of, or maybe an LOH of the real driver. So from the the allele frequency from the somatic testing, we might know if one of these mutation is the real driver. So it's possible that both, but it can be that only one. But of course, the question is, what is the clinical relevance knowing it?
Yes.
That's your question.
That's my question.
Yeah, so that's interesting. So it seems that not all BRCA mutations are equal in terms of deciding which PARP inhibitor we want to choose. There might be some consideration which PARP inhibitor we want to choose in the presence of different BRCA mutations. So that might be some, and also the level of pathogenicity, and that will also drive our decision of how much we can rely on a PARP inhibitor or not. Of course, in this case, with the double mutation, of course, I would
going to
guess
work, yeah,
that
at some
the
point,
PARP
yeah.
inhibitor will be the best choice, but still, it's still good to know what the real driver is. Thank you.
So the question, most of the panelists agreed that immunotherapy with chemo was the right neoadjuvant choice, and we have good data to show that it works well. It works in all subgroups of triple-negative breast cancer, and this has been updated with the Keynote and the JEPA-NUVO. The question then arose, does it work in patients with BRCA mutations as well? And certainly we have a bit of an overlap, as we can see from the Impassion study, and about 7% of patients who were BRCA mutated also were PD-L1 positive. And it was this group that also seemed, so they did seem to benefit from neoadjuvant immunotherapy, irrespective of the BRCA status. Toxicities of IO remain a concern, and we are going to give these treatments for a year in patients who are otherwise fit, well, eager to get back to their lives, so that's something we need to look at. So the patient completes her neoadjuvant therapy. She has a near complete clinical response. Surgery is done, conservation with axillary lymph node dissection, and a bilateral BSO in view of the BRCA status. She's not willing for the bilateral prophylactic mastectomy. So Mandar, a question to you. You see a lot of these patients. You talk to them about risk reduction surgeries. What is the uptake of bilateral prophylactic mastectomy in the population you're seeing today?
Hello? Yeah. So most patients, especially young patients like her, are not really very ready. But when you look at a node positive lady, triple negative, I would not really even push her to get a upfront bilateral surgery done. Salpingo-oophorectomy, yes or no, if she agrees, because as it is, her risk of relapse in the next couple of years or 3 years is going to be a bit high.
Yes.
So I would use that time to probably help her make her mind up. So initially, I will discuss, because I have to discuss. Those who are willing, I will go ahead and do it. But most patients do not agree when they are young. But I have no problems with that. I wait for 2 years and I give them that time. 2 to 3 years later, if they're really disease-free and doing very well, that is the time I may just pile on the pressure. And by that time, they have heard, they have discussed, they have read, and more or less then they start turning around and then they say, fine, let's do it.
All right, okay. So we get the surgery done, and HP reveals a 2 millimeter residual invasive disease with negative nodes. She's a YPT1A. What are her adjuvant options? Let's start with Bharat.
So
She's on immunotherapy.
Yeah,
She's
so new
completed her AC Taxol carbo, and now she's come to you for adjuvant treatment?
So germline positive patient who has received neoadjuvant chemo and immuno, and this is the pathological, near pathological or major pathological response. 2 millimeter, again, this is a very tricky situation where I would think of de-escalation of immunotherapy and adding a PARP inhibitor only in the adjuvant.
Okay.
Rather than continuing.
Have you done that in the clinic?
No.
You haven't done that. Nilesh, any experience with this?
So no experience, but in patients who are not complete responders, escalation of therapy would be two options. One would be the CREATE-X based on the capecitabine study, the capecitabine based on the CREATE-X study, versus giving a PARP inhibitor for a year.
Right.
And considering that she's BRCA1 positive, I would prefer to use a PARP inhibitor.
Okay.
And continue the pembrolizumab for a year, because as of now, there's no data that we can stop the post-operative adjuvant therapy.
Right. Dr. Rakesh, any thoughts?
I agree with Nilesh and Bharat.
So you would use IO and PARP together?
Given a chance.
Okay. Dr. Sharma?
I'll continue olaparib and this pembrolizumab. But then one question is there, how many patients are going to afford both of it?
Right. So Deep, have you done this in anybody? And if you had a choice between both, which would you choose and why?
Both means?
IO versus PARP in this setting.
No, pembrolizumab one should continue because this is not a complete response, and the greatest benefit of the drug was in patients who did not achieve a PAT-CR. And I missed out what was the baseline stage, but I heard from Mandar that she was
T2N1.
She was T2N1. So definitely I would continue with pembrolizumab, and maybe like he said, most patients will not be able to afford pembrolizumab along with a PARP inhibitor, but if given a choice, maybe one would give her a PARP inhibitor also.
Bharat, what do you think the safety would be like of the combination? Because you've given IO separately to patients, you've used PARP inhibitors separately. Do you think there would be any additive toxicity?
Toxicity. I have no personal experience of using both together.
No, so I'm
but
just.
Then the PARP inhibitor is toxicity, the long-term toxicity or the hematological toxicity, or short-term toxicities are also hematological toxicities. Here, the patient has already started developing the endocrine toxicity, which is evident in most of the patients with no thyroid dysfunction. So my only take was this is node positive, would be probably heavily node positive, which has been converted by the IO. When the tumor was in the body, as a neoantigen was present, you have removed the neoadjuvant. I really don't know if the patient is affording, can continue both the things. But if the patient is germline positive, maybe that is why I said monotherapy with PARP inhibitor and de-escalation of the immunotherapy, because the recent trials which have been coming across the tumors are in the neoadjuvant setting and de-escalation in the adjuvant setting if you have a major pathological response. And that is now a co-primary endpoint along with the PAT-CR measure, which is where less than 10% of the tumor is remaining.
So just to be different, I would be more inclined to go with the PARP inhibitor because she's clearly not responded to the immuno. And as we've seen, switching the treatment in adjuvant like the Catherine trial does help. And clearly BRCA1 is the driver here. So I would push this lady for a PARP inhibitor. Let's talk about
the trial results. Can you show that? Can you just go back one, go back. Yeah, here. See,
I know the point you're making.
The
I know the
patients who
point.
did not achieve a PAT-CR are
Still
actually
did
the ones
better.
that have a huge benefit from continuing with the pembrolizumab. Those who achieve a PAT-CR, you can discontinue pembrolizumab.
No, it's not a huge benefit. It's more than those who didn't receive pembro. So no PAT-CR, pembro versus no pembro. The pembro arm did better, but there's
better
still
by
a
a whole
big
lot.
gap between
You've
the ones
circled it.
that had a PAT-CR.
So in this study, both the two arms either did not receive pembrolizumab at all throughout the year, or they got pembrolizumab for 1 year.
But we don't know if the continuation of the pembrolizumab is what led to the benefit versus the first neoadjuvant
So
cycles
what this
that led
tells
to the
us is,
benefit.
as long as you got to the endpoint of PAT-CR, you were okay. Whether you got to that endpoint with or without the IO, but if you did not get the PAT-CR, there's clearly a huge benefit of the
But these
of the drug.
patients, only 11% of these patients were BRCA positive. So we don't have data for that.
I just also want to say that
olaparib was not used in this setting. It was not available.
No, I agree with that. I just wanted to also say that the toxicities of PARP inhibitors and pembrolizumab are non-overlapping. So if cost is not a concern, one could possibly
might as well
give
give
it.
both. Yeah. All right.
Just
yes, Mehboob.
As you said that you would like to use PARP than the immuno, where will you keep the capecitabine? And which is eligible for the capecitabine?
No, but in BRCA positive, if you look at the survival benefit with a PARP, you'd prefer you clearly can't, you have to choose between capecitabine and olaparib. So in BRCA positive patients, I would use olaparib. In BRCA negative patients, I would choose capecitabine, and that's how I practice.
Just one question. Suppose we have not given immunotherapy and neoadjuvant in this patient, and she's BRCA positive with residual disease. So what do you like in adjuvant setting? Only olaparib, or will you also consider capecitabine?
I think the combination of chemotherapy with olaparib is really very toxic. They are both myelosuppressive drugs. You're giving capecitabine in a reasonable dose. You're giving olaparib at a huge dose. There are a lot of overlapping toxicities. There's no way your patient is going to tolerate.
Only after that olaparib we should continue. Like if the patient has not received immunotherapy.
So if the patient can't afford olaparib, then capecitabine would be a reasonable choice in this patient. And that's how I think a lot of us practice.
There is no good answer to
There's
this
no
question. That is
randomized data.
evidence-based. So it is, one person's opinion against the other. And, one could also reasonably choose to use capecitabine also, I suppose, as per the CREATE-X.
So this was the Olympia study. And the last question I have on early TNBC is...
So before you move on, Shona, one quick comment from the experts. Can you use another PARP inhibitor in place of olaparib? Yes, no? Something which is available in our country?
I usually don't. I have a few patients on Talazo, on compassionate use when it was started by Pfizer, with breast cancer doing very well. But apart from the Talazo and Olad, I don't think there's evidence. So the last question is, what if this patient's HPOC report revealed a pathogenic PALB2 mutation? Would you still treat with an option?
So I wouldn't treat if this is a PALB2. We know that the HRR genes are not, these patients are not necessarily sensitive in breast cancer, unlike in ovarian cancer where I would probably consider.
Dr. Shafi, any comment?
Yeah, I think, there are a lot of studies which have shown that, patients who are BRCA1, BRCA2 negative and other gene like PALB2 or even all HRR genes negative, but loss of heterozygosity high, they have responded to PARP inhibitors. So I think we should look into that data as well.
Sudeep, what's your take?
I mean, if the baseline risk was high, one could consider it. I mean, it's not, as Nilesh said, that it's not strictly evidence-based with a huge amount of data, but one could consider it.
So we have data from the metastatic setting beyond BRCA study. Nadine Tung did a very nice phase 2 where she showed that patients with germline PALB2 and somatic BRCA in the metastatic setting had a superb response of between 50 to 80% with olaparib. So I know it's tough to extrapolate from the metastatic setting, but clearly there is activity for this drug in PALB2 mutations. So I was thinking about this, Dr. Shafi, and you mentioned it. Why can't we start doing HRD in triple negative? Because they're driven by the same genes. They have the same, so it's cause and effect. You're seeing the scars. You can do the RAD51 foci. You can do all these different recombination defects. So do you think that HRD will come into play like it has in ovarian cancer in breast as well, triple negative?
Yeah, I believe, yes, it has to be there because, HRD is a complex phenotype.
Right.
And which is, driven by all these HRR genes, loss of heterozygosity, and telomeric allelic imbalance, last state transition. And now we are getting more and more data. And, we have to start adopting and seeing the role of the HRD testing, comprehensive HRD testing, so that, you get, patients who might benefit with PARP inhibitors.
All right. Okay, how much time do I have?
Can I have one comment? So HRD in ovarian is easier because it's such a flexible disease. So you can have a really noisy biomarker. So I would say as we try to push HRD into breast or lung, it just needs to be much cleaner. And so let's just ask our biomarker to be clean and validated for that disease application because it gets tougher as you push past ovarian cancer, I'd say.
The validation is tough in these tumors.
And to that, I also want to add that, the utility of synthetic lethality with a PARP inhibitor in either BRCA, somatic BRCA, germline BRCA, or HRD, the evidence for that activity is much stronger in ovarian cancer than it is in breast cancer. If you look at all the trials, whether metastatic or adjuvant. And as he said, HRD is not a very cut and dried test. I mean, you can look at telomeric imbalance, you can look at large-scale state transitions, you can look at genome-wide loss of heterozygosity. There are various cutoffs. And it is my personal, and there have been some studies that have correlated the activity of DNA damaging agents with HRD in triple negative breast cancer. And although there is a signal, I don't think it is as strong a signal as it is in high-grade serous ovarian cancer. So I will.
So it's not ready for prime
In my
time.
opinion, I will not extrapolate from there.
Okay. How much time do I have? That's it? Okay. All right. Who wants to say?
I wanted to call out the FDA ODAC on Friday that resoundingly said for prostate cancer, test. Don't not test, right? Just all-comers approach has been rejected by the FDA, which I appreciate.
Okay. So here we have a metastatic lady who 8 months after adjuvant capecitabine triple negative develops a whole lot of metastasis. What do you normally do in your metastatic setting in a triple negative who's come to you from somewhere else and not had any tests done? And she presents with visceral disease, bone disease. So are there any tests that you do in a standard fashion? Bharat, let's start with you.
So now we have a patient, we have a very short DFI and she recurred in spite of giving the TNBC, a new adjuvant in TNBC, there was a residual disease. So if these tests are not been done in the past, better to investigate for PDL1 and BRCA. NGS, okay, if somebody is affording and insist, nowadays patient only insist for this thing because they are more informed. So it's better to do it because I look at it as a very bad prognostic. Patient has recurred with badly in 8 months. So I would like to explore all the possible options.
So you would do a comprehensive genomic profiling?
Yes, better do it.
So PDL1 definitely?
Definitely.
A germline BRCA definitely?
Definitely.
And
as
if,
well as
but
the
if you're
NGS
doing a
somatic
CGP, then you don't need to, so you do a comprehensive.
So nowadays, no, NGS reports are quickly, and in Mumbai also we are getting the reports very fast. So first option is PDL1 and NGS, definitely, and then you can go ahead with the jump.
Would you wait to start your treatment, or would you start?
If the patient is symptomatic, why should one wait? We know that we have been treating TNBC, and if at all they are germline positive, majority of them do respond, as sir rightly said. These patients, when we a decade back never tested for these, and these patients kept on responding, and you give chemotherapy, they respond because of synthetic DNA damaging agents. They have good response, again they recur, you use another agent. So we have TNBC patients who have been surviving with chemotherapy with multiple lines of therapy.
So Nilesh, you have started this patient on gemcitabine and platinum, okay? Because that's something she's not received in the past, and she's relapsed very quickly. Now the CGP report comes. It comes after 4 weeks. You've already started to get a response. She's feeling better. Would you change your treatment based on that CGP report if it throws up an interesting target?
So I'll go back to what he said. By and large, in TNBCs, the fruitful result in a CGP is very rare. I'm unable to understand what would we have actually got, which is a biomarker-driven therapy in this setting. So I would not. I would utilize the line of treatment that is working, and if I have something that is targetable, I would consider it for a later line. Although I'd be interested in knowing what that target would be in this patient.
Right. So The CGP is done, Dr. Shafi. And the patient has been on immunotherapy with gemcitabine platinum, and she's progressed in her 6th month. And these are the host of mutations that you're seeing. You're seeing an NF1, an ATM, KEAP1, and STK11. Is this telling you something?
Yeah, this is clearly saying that, IO will not work because of STK11, which is the resistant
Right.
markers for
Right.
immunotherapy.
Right.
That's how, it becomes very important when we get the CGP. We should, properly understand and interpret the report and to
Of
understand
course.
these resistant markers.
Yes.
So that you can avoid these, expensive treatments.
So I think the take-home message is CGP is just not to find a targetable mutations, also to learn about co-occurring mutations and mechanisms of resistance as to what could or what possibly could not work. I think that's very important. All right, comment from Dr. Rakesh. Any comments on this report?
Olaparib is not going to work. ATM is resistant to olaparib, so it's not going to.
So you'd continue with what? You'd switch your line of chemotherapy. Sudeep, any interpretation of this report? Would you give olaparib a go with the
I
ATM?
would not get this done because I don't think that this is very useful.
Okay, she comes to you with this. You
If-
would not order it.
You see, if STK11 is such a cut and dried marker for resistance to immunotherapy, then why not just test for it instead of 500 other genes? So, I will ask the patient whether she can afford sacituzumab govitecan. I will ask the patient whether HER2 was at least 1 plus or 2 plus. Can I offer her trastuzumab deruxtecan?
Deruxtecan.
Instead of, wasting resources on comprehensive genomic profiling, which will give you a whole lot of information that is actually not actionable, I will discuss those options with the patient. If she comes to me with this report, I will look at it, but I can't, I don't think it changes anything. As somebody said, they will just continue with gemcitabine and cisplatin and just continue with that.
Can I just make a quick comment there?
Yes.
And could you go back? The CGP was done on the tissue, isn't it?
Pardon?
Well, that was the tissue.
Yes.
And would you really go to the point? It's just 0.2%.
Yeah. That's
That,
the other
actually,
thing.
that shouldn't be reported ideally. No, they say this is tissue.
No,
If
sorry,
it's
it's a liquid
then-
biopsy.
okay,
Sorry, it's a liquid biopsy. Okay, so this is the last slide. We know this pathway PIK3CA, AKT-P10 is really altered in a lot of metastatic triple-negative breast cancer. We have conflicting data for AKT inhibitors. So any clinical experience from our panel on using, targeting this pathway in metastatic triple-negative? Have you used? Yes, please.
We participated in the Capitello trial.
Right.
And in some patients, there is a prolonged response, but that doesn't tell you anything because we were just one of the many recruiting sites. There is some signal of activity, but it is not nearly as good as, for example, trastuzumab deruxtecan is in its own indications, or even sacituzumab govitecan is in its indications. There is some signal of activity.
And it was used with weekly paclitaxel?
Yes, it is. It was used with weekly paclitaxel on day 1, 8, and 15, and then it is to be given for 4 days every week. And it does have some side effects, but they are tolerable. They are not intolerable side effects.
Is there any experience with using low-dose everolimus in these patients with paclitaxel?
I don't have it, but maybe others.
No? All right. So thank you for that. That was very exhaustive and very interactive. Thanks to the panelists and thanks to the wonderful audience.
Thank you, Soha, and your panelists for nicely conducting the panel discussion. With this, we conclude this session.
I will also like to thank Dr. Shona Nag because, I had to be in Delhi and I was preoccupied. So she accepted my request to moderate in my place. Thank you very much.
Thank you, Dr. Shonanag, for the excellent moderation. So moving on to our next session, which is a keynote lecture for which we all have been waiting for. And for that, evolution of precision medicine in oncology with special emphasis on liquid biopsy. For that, we have our chairpersons, Dr. Suresh H. Advani. He's a director, medical oncology, Jaslok Hospital and Research Center, and Sushrut Hospital, Mumbai. Welcome, sir. We also have Dr. Ramesh Hariharan, Bangalore. He's a co-founder and CEO at Strand, and he's an adjunct professor, Computer Science Department of Indian Institute of Science from Bangalore. And we have our key star speaker now, Dr. Geoffrey Oxnard from USA. He's a thoracic oncologist at Dana-Farber Cancer Institute and an associate professor of medicine at Harvard Medical School. The aims of Dr. Oxnard research is to develop clinical applications for cancer genotyping technologies to advance the precision cancer care. Welcome you, sir.
Thank you all so very much for having me. I'm incredibly impressed by the tenor and quality of the conversation so far today. I'm going to wait a moment while my slides come up. I'm no longer at Dana-Farber. I'm going to catch. All right. I left Harvard a couple years ago when I took a role at Foundation Medicine. So a lot of my time is spent in industry. Today I come to you as a physician. I work at Boston Medical Center. I still see patients part-time, and it's incredibly rewarding and satisfying to see patients and use that time with patients to feed the questions I ask and the questions we all ask as we think about approaching patients with a precision oncology lens. And so I'm going to speak to you today about a take on precision oncology, where we were, where we are, I think, and where we're going, certainly from a U.S. lens and from where I think this is happening now in India as well. My conflicts of interest acknowledged that I do work for a Roche company, and I thank Roche for the sponsorship today. So let me start with the past, and I'm going to speak in cases as we've used today. This is a patient of mine from a few years back who's a former smoker. She was an elderly woman, 74 years old. She presents with pain. She has bone metastases. Imaging shows lung mass, liver mets. Biopsy shows lung adenocarcinoma, TTF1 positive, PD-L1 10%. I'm not quite sure what the opportunities are for this patient. She is unwell. She sees me after a hospital stay. She's actually in a wheelchair. She has limited mobility. And what I'm looking for is something that can change the story for this patient who has a bad prognosis, and I want to try to turn things around. I'm looking for the magic of precision oncology to help this woman change her story. As we think about the therapies for a patient like this, or for our patients with breast cancer, as we just talked about, what is it that the patient is looking for? Is it a therapy which will prolong her life regardless of toxicity? Everolimus was mentioned. I mean, this is a therapy with considerable morbidity and some modest benefits. Is that what patients are looking for, right? Or is she looking for a therapy which will change the story of her experience of cancer and prolong her life while minimizing her toxicity and minimizing her risk? And I really do think it is the latter that patients are looking for. That this is the difference between precision therapies and empiric therapies. Precision therapies pick the right drug for each patient. They require a complicated molecular evaluation, but they help that patient maximize benefit and minimize the therapeutic risk. As opposed to what I call empiric therapy. Empiric therapy is the guesswork, right? Every patient walks in the door and I say, you get the same approach, the one-size-fits-all approach. And I think that's increasingly the approach of the past, and we're moving more and more for more of our patients from that guesswork of one-size-fits-all to a precision approach for each patient. When I look back 20 years to my first experiences of lung cancer as a medical trainee, it was trials like this. This is the famous Schiller et al. New England Journal of Medicine trial. To clarify, this U.S. trial randomized first-line lung cancer patients to 4 different therapies, okay? Randomized trials of 4 different arms are very complicated. And what you see here is it makes no difference. No matter what you do, the same bad outcomes for all of lung cancer. And this experience of different therapies, no different outcome, led to a pervasive, I would say, pessimism in lung cancer care in particular. No matter what we do, it doesn't change the outcomes. This is the past that we're trying to move away from. If you go back 14 years, this is the IPASS trial. For the first time, through testing, we can get dramatic differences in our outcomes. And so now, in each of our mutant patients, You can have dramatically different progression-free survival if you give them a precision therapy versus a chemotherapy. This is the beginning of progress, the beginning of optimism for our lung cancer patients, the allure of testing. And based on these results, for the first time, every patient with lung cancer now needs testing. Even hospitalized lung cancer patients need molecular testing because in that patient, sick in the hospital, performance status of 4, even in the ICU, if you find that mutation, if you start that pill, they can have a Lazarus response and raise from the bed and walk out of the hospital through the power of precision therapies. This begins to change the story. And then the story evolves. It's not just EGFR. This is crizotinib and ALK. This is called a waterfall plot, right? All of the lines going down. I love it. There's the waterfall we want to see, right? This is our expectation of precision therapies. The expectation that everolimus doesn't deliver on, but the expectation we increasingly expect from the new therapies that are showing up in our armamentarium. And we keep track, right? We keep track of which drugs will give us this kind of reliable outcome versus the drugs that are a little more hit or miss. And so now we've all experienced this, that treating patients with precision therapies is different. We have a high pretest probability, right? That patient comes in, and when I see an EGFR mutation with all those different co-mutations, I zoom in on the mutation that I can rely on, because I know with that mutation, I can get a reliable outcome. Patients where I've started the treatment, and the scan a couple months later, the radiologist says, I'm not sure it's working, and I say, don't tell me that, radiologist. I know what working looks like. I trust my own clinical instincts more than your scan because of that confidence, that pretest probability that this drug is going to work out if we just have patience. These are often very tolerated. It used to be patients would say, you'd say you have to have the toxicity for the treatment to working. But today, no. I want dramatic benefit, no toxicity. That is the magic of precision therapy. Amazingly, often these work in the brain, whereas therapies didn't used to. And patients come to me and they say, you know, I take my pill once a day and otherwise I forget that I'm living with incurable cancer. Crazy that patients have had this experience. I've had patients commuting in to see me from miles and miles away. You probably have, maybe you have this experience as well. And I say, all right, see me in 2 months, see me in 3 months, see me in 4 months, see me in 6 months. Stage 4 cancer. I'm seeing them every 6 months. They're living on a pill, changing the course of their disease. This is the optimism of lung cancer care that is why we're all here today, enabling this world of precision therapy. And it is an optimism that we need to make sure our cancer patients palpate and participate in and don't have the futility and the nihilism of care of the past. And so treating patients with precision targeted therapies is different, but guiding a patient to targeted therapies is tricky. And so how do we deliver on this opportunity? I'm going to walk through some cases to try to think about how I've been doing that in the US and how some of these tools can be used here in India. So in this patient, elderly woman in a wheelchair, former smoker, needs radiation, I need testing. And so I order tumor testing, and as I order it, the patient decompensates. She ends up admitted to the hospital, she has cord compression, she needs radiation, things are looking bad. What I want is this. So this is the story of lung cancer drivers, and we heard about all of these, but steadily over history, the pie getting richer and richer with more targeted therapies. Do I have a pointer? Maybe I have this one. No, that's fine. Okay. More and more therapies as the pie gets increasingly large. I will still say there's a big gray part with no pie identified, right? But what I'm looking for is one of these to play out for this patient. I don't know which one. As we discussed, I need to test across all of my bases to find one of these driver alterations. And through doing so, I hope that her story will change. In the end, as she decompensates, as her care becomes more urgent, I send a liquid biopsy because I know I need a result back as she finishes radiation so I can get that Lazarus response and change her from poor performance status to good performance status. And the liquid biopsy comes back with a RET rearrangement. As we pointed out earlier, someone in the audience said, these low-level variant frequencies can't be trusted in tissue. Why? Because of formalin artifact, right? Tissue specimens are processed. Tissue specimens have all of this artifact accumulated because of that processing of the specimen. But blood is fresh. The DNA is as clean as you can imagine. And so that fresh, clean DNA, assuming it's been handled appropriately, can give you low-level signal like this. This is a rearrangement detected in DNA. There's no RNA floating around in the blood, all right? There's well-designed DNA testing can find these fusions, even the complicated ones, and can help a patient like this get to precision therapy. And so for this patient, based upon detection of the RET fusion, she actually was enrolled. I now see the world of today where I can treat these things. And why do I think I can treat a blood test? Because of trials like this. So this is the BFAST trial. In the BFAST trial, this is a bold trial launched by global investigators saying, we are not going to enroll anyone with a tissue positive result. If you come in with ALK on tissue, you can't come on our study. You can only come on our study with a blood test. We're going to try the world of only treating based on blood. And what they found, enrolling all these patients with blood positive, ALK positive disease, fantastic progression-free survival, response rate 87%. Sorry, the font's not coming through quite, right? Dramatic responses, durable responses. It's this experience that has convinced us that we can trust these liquid biopsies to act on, and that is the reality of today. Is that the reality in your practices? Let me just ask you. When you see a liquid biopsy back, do you say, I trust this, I can treat this thing? Or do you say, I'm not so sure? And I don't know the answer for you. I want a world where our diagnostics are so validated and so convincing that we trust them when we act on them. And fortunately, I'm able to experience this with liquid biopsy today. So based on that positive RET fusion, she consented to a trial, the first in human trial of selpercatinib that I was a part of, and she managed to actually get on that trial. Despite her delicate performance status, we confirmed her eligibility. She had a dramatic response, and she walked again, her pain was controlled, and she lived for years more. And yes, she's one of those patients, like we all know, right, that has stuck with me, given my ability to change the course of her disease, even in a short and very critical time. It's cases like this, it's evidence like this that has led the ESMO guidelines to endorse liquid biopsy as one of the tools we can use to enable precision cancer care, not just in the US, now in Europe as well, and now globally. The ESMO guidelines are elegant in how they frame this. I hope you will read this, right? Liquid biopsy assays with high analytic and clinical specificity, which means no false positive errors, right? The assays that don't lead you astray can be used in practice, understanding their limitations. And the limitations include the fact that shed is variable, and sometimes, though we know ctDNA, and you have to be cautious with your negative results. A liquid-first strategy, so reaching for liquid as one of your first tools, is now recommended to be considered as an alternative to tissue testing when the time to result is clinically critical, so in those patients with a short time frame where you need an urgent result, and where the tissue biopsy is unavailable or inappropriate. And the key is you got to collect those blood samples when the patient is progressing. So I love the description of patients who've already started chemo and you're trying to plan for next line therapy, right? Very reasonable. Don't use liquid biopsy for those patients. Those are patients where you get your tissue testing, you save that for down the line, and you consider that for second line clinical trials or targeted therapies. Liquid biopsy is in those progressing patients who have a significant burden of disease and where there's urgency to get that blood out the door, get that result back, and get them on first line therapy. So let me give you another case example about how precision oncology is evolving from history to reality. This is a patient I met in clinic, a 63-year-old Asian former smoker, heavy smoker, right? Extensive smoking history. He comes in with an aggressive cancer, skin nodules. He presents with a mass in the back of his head, okay? Really behaving actually like a squamous carcinoma. Biopsy ends up showing squamous carcinoma. He has a lung mass, he has brain mets, he has bone mets. Do you test this patient? I see a nod. Does anyone test squamous lung cancers? Do you do genotyping on squamous cancers today, right? I love that I'm seeing believers in the audience, okay? And what this is a movement from is testing just never smokers, testing just adenocarcinomas, testing all non-small cell lung cancers, testing all of oncology. I think we're all asking appropriately, is this patient a patient who will benefit? This patient's a smoker. This patient has squamous carcinoma. Some would say this patient doesn't have a driver, but he's from Thailand. Maybe it was my clinical instinct, right? And so I sent off a liquid biopsy. Maybe it was my hope that I could avoid him chemotherapy and avoid him brain radiation. But somehow that optimism led me to test this patient and find high levels of EGFR mutation, a VAF 22% on his test. And wow, instead of this patient having the terrible story of brain radiation and chemotherapy, I start him on osimertinib. His brain metastases melt away. And again, I salvage him from a patient who would have done much poorly to now he's still doing well on pill therapy a couple years later. And so this is a little bit of a belief, right? You start to be believers in testing and you find you're testing more and more patients. Now, don't get me wrong, we have to titrate. Is there a palpable benefit for each of these patients? I'm not saying it's a blanket for everyone. Someone asked me the other day, so do you test small cell lung cancer? No, I don't test small, except in a never smoker. Small cell and never smoker I'll test, but mostly I don't test small cell lung cancer. And yet I'm trying to figure out in my practice all of those patients where precision testing and precision oncology has made it a part of their opportunity. So liquid biopsy sent, I started him on osimertinib. He has dramatic brain response. I think it really is amazing that precision therapy is starting to change the story of oncology, right? Maybe not all brain mets need radiation. Like I didn't imagine that's the world I would be today, but really for ALK positive, EGFR positive, I'm avoiding brain radiation. I'm focusing on a pill. I can push radiation down years. And honestly, patients do better, right? Maybe genotype trumps histologic diagnosis. In retrospect, did he really have squamous carcinoma, right? Like, who has those situations? Now, I know there are pathologists in the room, okay, right? But still, like, sometimes I'm not actually as certain of the histologic diagnosis. And I feel like the genotypic diagnosis, you know, histology says hepatocellular carcinoma and genotype says FGFR rearrangement. Maybe it's really cholangiocarcinoma, right? Histology says large cell neuroendocrine carcinoma. Genotype says KRAS mutation. Maybe it's really non-small cell lung cancer. I think we're in a world where the genetics can bring to light some of these diagnoses and actually change our understanding of what is diagnosis at all. And so this drumbeat is happening. It's getting more and more complicated across oncology, more and more therapies. Every year it feels like the standard of care changes, and as soon as you have your favorite ALK inhibitor, there's a new ALK inhibitor. And as soon as you have your favorite ROS inhibitor, there's a new ROS inhibitor. It's happening in PARP. It's happening across oncology. As you count not just the number of drugs, but the number of targets, the number of targets are also constantly climbing. All of us trying to keep track of which of these targets are real, which of them are not, right? And I see P53 show up here for 2023 because I do believe that P53 inhibitors are coming. I'm hearing about them in clinical trials. It's crazy to me that we might be able to target P53. NRAS, will MEK inhibitors really work for NRAS? Or a couple years from now, will KEAP1 really be targetable? Will EZH2 ever play out? I'm not sure, but what we're trying to build or what I'm trying to anticipate is what's the next trial that's coming to my center? What are the targets I need to be testing to get that next trial enrolled? How can I make sure that my patients are a footprint that can enable this next phase of research coming over the years ahead? And I know not all these drugs make it to India necessarily, but they make it pretty quickly, it seems like. Like within time, they get here. When are RAS inhibitors going to show up, by the way? Really? No G12C inhibitors yet? Soon enough, soon enough. Okay, so let me get to some more complicated cases. This is a patient I met in clinic actually just now, I remember maybe it's about 6 months ago now. This patient is a former smoker. He presents with cough. He has a lung mass. When I meet him in clinic, I can tell this is an aggressive cancer. He's got a PET scan which shows bone mets, liver mets, adrenal mets. I get a biopsy. Only a small specimen can be obtained from this. We say, where's our tissue is the issue, right? But still acknowledging, sometimes you go in there and you get a necrotic specimen and you don't get enough. And do you go back in and get more? Does your oncologist say, come on, why couldn't you get me more tissue, right? Some of these patients, the tissue is ephemeral and isn't enough. And again, this is another example where, and I'll admit, I included all liquid biopsy cases, I think, today. I don't only use liquid, okay? But here's a patient where the tissue was inadequate, and I sent off a liquid biopsy, understanding that his aggressive presentation makes me think I need to meet it with aggressive care. So here's his liquid biopsy result. I'm going to pause, right? Ask folks to consider this case. What's the right first-line therapy for this patient? He has a couple p53 mutations, SMAD4, an aggressive biomarker, CARD11, ATR, maybe there's a future world where there are a DDR inhibitors, STK11, MET amplification, it's in the liquid. I believe that it's real. I'm not always using MET amplification as a first-line biomarker, honestly, in my practice. I'll probably save that MET amplification and think about it down the line. Elevated tumor fraction, so this means that this blood specimen has 11% tumor content in it, right? Some biopsies don't have 11% tumor content in it. This blood specimen is as rich in tumor DNA as a biopsy. That's an aggressive sign for this patient, right? I'm worried about the burden of his disease, MSI not detected, and blood tumor mutational burden 27. Who was it that said earlier they think about TMB? It is one of the biomarkers that I think about when I'm contemplating chemotherapy, immunotherapy, or both. I don't always believe STK11 necessarily means immunotherapy resistance. For this patient, the key finding is no classic drivers, right? Sometimes testing is positive, and that's great. And sometimes testing is negative, and that's also important for us. I think we just complained. You were like, a negative result. Why did I waste my time sending that? I think for some patients, that negative result means something. It's like, look, we did our due diligence, right? We looked for drivers for you. There is no magical pill that's going to save this cancer. And so we need to move to aggressive combination therapy. And what I like about this liquid biopsy is, even though liquid biopsy negative can't always be trusted, this is the kind of liquid biopsy negative that can be trusted. It has high tumor content. I trust that this is an informative negative result. And so I can expeditiously move this patient to immunotherapy, which is what he needs. Given his high tumor burden, I give him chemotherapy as well, maybe 4 cycles, and then I'll plan to focus on immunotherapy maintenance after that. Yes. I love the interruption, by the way. This is the first question. Anyone else can interrupt me and ask a question anytime, okay? Please.
Differentiated non-small cell.
Yes.
And as you concluded that because it's a negative liquid biopsy, we are going to start chemotherapy.
Yes.
As a clinician, we are still interested whether it is adeno or squamous, because pemicarbo or paclicarbo.
Or does genomics trump histology? Right? I'm not sure. I give him Taxol. He has a biopsy. He has a diagnosis, right? My guess is SMAD4. This is just a weird in between, not that clear. But when the histology is a little more messy, that's when I favor Taxol, honestly. And when the histology is a little more clean, that's when I favor adenocarcinoma. But if it's large cell neuroendocrine carcinoma with a KRAS mutation, is that adeno or is that non-adeno? Is that still going on? So sometimes histology fails me a little bit. And when it's messy, I just tend to give Taxol. I think I gave this patient carbotaxol immunotherapy. But yeah, so I guess I've become a histology skeptic a little bit. When that large cell neuroendocrine carcinoma shows an RB mutation, I give him EP, right? So sometimes I let the genomics help sway me. But in this patient, I don't think which histologic chemo is the critical decision for him, right? The critical decision is targeted immunotherapy with or without chemo, in my book. All right, others are invited to ask questions, please. Thanks for bringing that up, okay? Why is immunotherapy so compelling? Why is it important that we not only find our driver positives, but find our driver negatives and get them to this next generation of precision therapies? Right, it's curves like this. This is Keynote 024. And what you see here is the flattening. So look at the blue line, right? The blue line goes down, and then it bends, and then it's like it's just going to go straight, right? It's like these stage 4 patients are going to do so well that some of them may never, in fact, recur. I'm using the word cure in some of my immunotherapy patients. I am okay using this. These patients, their cancer becomes a part of the past, and they're stopping therapy and they're living their life. I love hearing a surgeon say, I'm worried these systemic therapies are going to be better than surgery, right? I don't think we're there yet, but I think about it. Actually, I'll show you some data in a moment where we're starting to favor immunotherapy even over locally curative therapy. It's because of this flattening. And so this is what drives me now. I want my patients to have this experience where their cancer melts away, and with immunotherapy, they have durable benefit. I love the conversation about how many doses of immunotherapy. I mean, who's had that patient? 1 dose of immunotherapy, they have toxicity, you stop it, and then their cancer's gone. Who's seen it, right? I've seen those patients. A couple doses. Immunotherapy can work. and it can work durably. And so for me, it's get a couple doses in, make it a priority, especially for those biomarker positive patients. What are the biomarkers? I think PD-L1 is one biomarker. I do believe TMB is a biomarker. I would say TMB10 is kind of a late line biomarker. Up front, I'm looking at more like TMB20 to favor immunotherapy over chemoimmunotherapy. This is the Keynote 158 study that led to the FDA approval. Single-arm study, not a randomized trial, but it even showed that in PD-L1 positive here, TMB high PD-L1 positive did better than TMB low PD-L1 positive. So I do think that TMB and MSI and PD-L1 are complementary biomarkers that we use as we try to favor patients for an immunotherapy-focused approach versus an approach with chemoimmunotherapy. And yes, like the patients that I've cured with immunotherapy are the ones that really sit with me and drive me to progress and getting it to more patients. Pre-surgical immunotherapy is happening, right? So these are two recently published studies in colorectal cancer, one in the New England Journal, one in Nature Medicine. Both of these in mismatch repair deficient cancers showing dramatic responses and leading to a world where pre-surgical immunotherapy is a reality for these cancers. It's a reality in lung cancer now. Immunotherapy is part of the curative care of cancer in rectal, bladder, esophageal, lung. Is it breast now as well? Even breast? No, not yet breast? All right, not yet. It is coming, okay? But man, is it coming, right? And so I think this really will change the story, even in our most vulnerable, potentially curable cancers. This is one of those waterfall plots I showed you before. But instead of measuring tumor change on radiology, this is measuring change in pathologic response. And so what you see here is that the red lines are the MMR deficient. So these are the MSI, the immunotherapy vulnerable cancers, often Lynch syndrome associated. And the dramatic response to immunotherapy are really in these deficient MMR cancers as opposed to the proficient ones. We see a couple green lines here that have had complete clearance. It's pretty amazing. So these are colon cancers that did not have MMR deficiency, but nonetheless had complete response to immunotherapy. Anyone seen this? And anyone have a hypothesis? Why?
But probably it is the MLH1 type or the Lynch syndrome or the Lynch-like.
Right.
I think they are the ones who show this kind of response where you give few doses of immunotherapy and then the thing is gone.
I don't think these green lines with complete clearance are biomarker negative. I just think they were negative with this biomarker, right? And maybe this biomarker didn't perform perfectly. I've seen POL-E mutations in these patients or some other Lynch-like phenomenon. So I still think I'm not satisfied when I see this. I want to know the biomarker and I want to find out more about the cancer. I still think we can predict this if we just test rigorously enough. Yes.
I think it's also important that we look at the neoantigen load and how well that would respond to the immunotherapy.
Right. And often that's what, did I do something? Tech interruption. Okay, it's coming back. I'm with you. So how do you measure neoantigen load though?
It's difficult, but possible, not impossible, because Caris, I think one of the commercial labs are doing it in their advanced panel with the AI. Also mutational signatures, if those have NAPOBEC or not.
So POLE signatures, right? MSI is a signature. TMB is a pragmatic measure of antigen load, but I'm not saying it's a precise measure. I agree with you.
The larger the panel, the better the TMB indicator.
Or adequate, yeah. And so I see a world very much where I want to be able to use these precision biomarkers even in lung cancer, right? I remember, I mean, are people using neoadjuvant chemoimmunotherapy in lung cancer? Are your patients? Yeah. I still feel like that might be more than is necessary for some of my patients. I remember a patient I enrolled on the LCMC3 trial, squamous lung cancer, node positive, little bit of hearing loss, didn't want to give him platinum. We enrolled him on the trial of neoadjuvant IO alone, gone, right? Surgery took it out, PAT CR, never needed chemo. And so I still hope for a world where this kind of use of neoadjuvant immunotherapy alone can allow us to give local therapy, avoid chemotherapy, maximize benefit, and minimize therapeutic burden on our patients. So let me go to the future, and I have, excuse me, I just lost my timer because I messed that up. So we'll keep asking questions if I end earlier, okay? So let's talk about the future, all right? I do think there are a growing spectrum of usefulnesses that we can get from our precision testing. And I want to think about how we as a community can demand more of our testing and in doing so get more usefulness out of it. We've talked about accessing precision therapies. We talked about accessing precision immunotherapy. Let's talk about another creative case. So this is a 50-year-old female never smoker. She comes in with a lung mass. She got bone pain. She went to the ER. CAT scan shows lung mass, bone mets. She comes to the clinic a couple days later, and she sees you. There's a fly up here, sorry. And she sees you in clinic not yet having finished a biopsy, right? She sees you during her diagnostic odyssey. This is pretty satisfying to me. Now in my practice, when I was in academia, like at sort of ivory tower academia, let's say, at Dana-Farber, people would wait in line to come into clinic, right? They'd show up weeks after diagnosis. At Boston Medical Center, it's much more community-based. We have trials, we have patients who walk right in, having never met a surgeon, seeing me as part of their diagnostic journey. This patient comes in and she's sick with bone mets. She looks like she's a never smoker with the real kind of, driver positive lung cancer. How can I expedite her care? How can I be as efficient in my workup of her so that I can get her to the right therapies? So I say, well, I need a lung biopsy. I need a pathologic diagnosis, right? I don't skip pathology. Let's be clear. I always believe in biopsies for my patients. I need a brain MRI, right, to complete her staging because I got to figure out, where does her disease sit. But is there a world where I could also, why is this fly? I'm sorry. Is there a world where also I could get a liquid biopsy, where liquid biopsy is part of her journey and part of getting her genomics done in an expedited fashion? Or maybe I need all three. And so this is what I've sent for this patient. I sent an expedited workup. Here's her liquid biopsy. I want someone to tell me the diagnosis or predict the diagnosis for me. And don't cheat if I've told you about this case before, okay, or if we saw it on Twitter. So this 50-year-old never smoker has 2 BRCA alterations detected, a Sybil rearrangement, an MEN1 rearrangement, and an RB rearrangement. It could be small cell, right? But pretty weird for a 50-year-old never smoker.
But I might go for the large non-small cell lung
Or
cancer.
is it some other kind of neuroendocrine? So actually for this patient, it's the MEN1 rearrangement that's diagnostic. This patient had a carcinoid, right? Now, I first want to tell you, what we are seeing here is aneuploidy-based detection of tumor fraction and 5 rearrangements detected on circulating DNA. I want us to demand that our liquid biopsies do hard stuff like this, okay? Now, don't get me wrong. I recognize that there are also, I was a big believer in PCR. I love it. It's fast. But like, liquid biopsies can do tough stuff if we demand the appropriate validation and development, okay? This patient has a diagnostic MEN rearrangement. She's got carcinoid. I don't like that RB1 though, right? That's a bad sign. That's probably a more aggressive carcinoid. Her tumor fraction, is it on here? Tumor fraction was like 20, 30%. Okay, so the amount of DNA in this woman's blood was like a rich biopsy. Okay, that's a more aggressive carcinoid. And then we've got these BRCA rearrangements. Who is it that said before that you only send certain mutations for germline testing, right? You mentioned not P53 and not LKB1, for example, right? And so ESMO actually has guidelines on this, where they say there are 24 actionable cancer susceptibility genes, which if detected on somatic testing should cue germline testing. BRCA, PALB2, the Lynch genes that were mentioned before by, RAD51, et cetera, right? And so I've always found in my somatic testing, stumbled upon these germline findings, and it frustrates me when the somatic testers don't cue the germline testing. As someone mentioned, often patients are sort of deferring the germline testing for down the line, right? They're like, well, I want to focus on my cancer today. I don't want to focus on my germline testing. I don't know actually if this BRCA rearrangement necessarily would be germline. It's only 25, 26%. But I do think it's one of the usefulnesses we can ask of our testing, right? We can let somatic testing be that nidus for follow-on germline testing. And my hope is then find more families, cascade this to relatives, and actually find more patients where we can prevent cancer. So incredible diversity of opportunities for this patient. What I ended up doing, I don't know, how do you guys treat first-line carcinoid here? Favorite carcinoid drug? Surgery, right? I'm with you. Normally surgery, unfortunately, not for this patient with bone mets, right? Because of the RB1 and the high tumor shed, I gave this patient first-line chemotherapy instead of octreotide, which I would often use. And so, it didn't guide me to precision therapy, but it did help me right-size the aggressiveness of how I should treat this patient given her disease burden. I was mentioning that DNA can detect rearrangements if it's designed with the appropriate hybrid capture, right? You really do need to have the right bait set, the right bioinformatics. This is data about rearrangements detected on a comprehensive liquid biopsy, Tempus-ERG, diagnostic of prostate cancer, BRAF fusions, and then, of course, fusions in FGFR and FGFR2 and cholangiocarcinoma, FGFR3 and bladder cancer. I'm really excited by the idea that as liquid biopsy has matured, we can demand of it more and more challenging things, and assays can step up and do this if they've been developed and validated appropriately. I do like that some of these are diagnostic, right? So beta-catenin rearrangements, EWSR1 rearrangements, Tempus-ERG rearrangements, right? Each of these rearrangements actually means a specific disease and can help us as we take a patient through the diagnostic odyssey. And so what I'm doing for you is building out the usefulnesses that we can demand of our molecular testing, not just finding pill therapies or immunotherapies, but clarifying diagnosis, incidentally finding germline alterations. We can ask all of this of our testing. I want to show you this data. This is a paper we're writing up with Christian Rolfo looking at our real-world experience of physicians ordering liquid biopsy before diagnosis rather than after diagnosis, right? This is this paradigm that we're seeing more and more. And so we queried this real-world database for situations where the liquid biopsy was done in parallel to the biopsy, not instead, in parallel, and in parallel with the staging to expedite the delivery of that report that can help get to therapy. This was querying the real-world database. So this is the collaboration between Flatiron Health and Foundation. It's called Clinical Genomic Database. And so about 3,000 lung cancer patients with a liquid biopsy, we found around 1,000 that were ordered around first line, and of those, 50 of them, the liquid biopsy was pre-diagnosis. This is not big. This is 2% of patients, but it's growing in its use, and it's a world that I'm excited about. So imagine that. The patient, sees the oncologist before the surgeon. They have a lot of disease. The oncologist sends the liquid biopsy off. In that world, the time to results, if you think about diagnosis as the time when the pathologic result comes out, and now the liquid CGP has been ordered before diagnosis, right? Getting a jump on the turnaround time. The time from diagnosis to CGP was around 4 days if you sent the liquid biopsy before diagnosis, and was around 26 days if you sent the liquid biopsy after diagnosis. And so I'm not saying all patients need that 2 or 3 week jump on things, but there are some patients with aggressive disease where I really think that can make a difference between getting them to first-line precision therapy versus them deteriorating and not making it to an effective first-line therapy. Time to treatment was shorter. There are many papers now who have shown this. And so this is a paradigm that is really growing in its use. And I think this is the future of how we think about using diagnostics. There was a time when our therapies weren't that effective and us being aggressive in testing wasn't that important. And now there's a time where we have more therapies, we have more opportunities, and every patient who misses out is another patient who could have really flattened the curve and changed the story. And so my hope is this gets more patients on pill therapies, gets more patients on precision immunotherapies, and overall increases the accessibility of this testing. We envision this happening maybe in carcinoma and primary as well. I think there are certain disease types where this kind of testing can help expedite the diagnosis. The catch with liquid biopsy is shed. So this idea that ctDNA levels can be higher or can be lower. This is looking across cancer types. On the left is those cancers with higher ctDNA levels in general, small cell, liver cancer, colorectal cancer, bladder cancer. And on the right are the cancer types that tend to have lower levels of ctDNA. Gliomas don't really shed. Pancreatic cancers actually shed less than you might imagine. But in a given patient, They can be anywhere on the spectrum. And so one patient, thank you, can have high shed or can have low shed, okay? That shed is prognostic. So these are lung cancer patients getting immunotherapy, and their levels of shed can predict how well they do. High shed cancers, worse prognosis. Low shed cancers, better prognosis. When I think about who should or shouldn't get CDK4/6 inhibition in breast cancer, is this an orthogonal measure of aggressiveness to help you figure out who needs more therapy, who needs less therapy? And so we have real-world data looking at this prognostic component. It's across all levels of ctDNA. This can influence prognosis. And I hope is a world maybe where liquid biopsy is part of even staging as we think about which surgical patients need more aggressive care or less aggressive care. Could ctDNA be a part of that? My final paradigm is the world of monitoring. I have one last case for you. This is a former smoker with non-small cell lung cancer, high TMB. He got chemoimmunotherapy a year ago. Great response. We gave a little radiation to consolidate. And now a year later, he presents with PET uptake. Lung uptake with the PET, bone disease. It's actually kind of joint disease, lymph node disease. He's not feeling that sick, and the PET is exploding with activity. I do a biopsy of a lymph node in his groin, and it shows granulomas, no cancer. What is going on with this patient? Is he really progressing? Is he not progressing? Does he have inflammation? How do I figure it out? Do I give him, what's my next step? Do I just switch him to chemotherapy for progression? Do I switch him to steroids for pseudoprogression? How can I decide if this patient really has aggressive progression or not? I think this, if there is any application for monitoring, is a patient like this. And so I send a liquid biopsy. And in his liquid biopsy, I find none of the mutations that I knew were present at baseline. He actually has completely negative ctDNA. And I realize, even though the radiologist promises me this is progression, this is bad, I start him on steroids. It melts away. I stop immunotherapy. Hopefully he's cured, right? And so I do see a world where imaging is confusing and where liquid biopsy could be an orthogonal measure to help us clarify when is a patient really progressing or not. I will say that monitoring is tricky, right? When you have a lot of ctDNA floating around at diagnosis, liquid biopsy is relatively easy, still pretty hard to do well. But as your levels go down, you need exquisite sensitivity. These monitoring tests are even more complicated in how they decipher ctDNA versus CHIP, non-tumor DNA mutations, et cetera. This is some data from a clinical trial of immunotherapy. The orange yellow is the imaging, not much change. The blue is ctDNA, dramatic change. And so these patients have stable disease on imaging, but in ctDNA have complete clearance. It can really clarify those monitoring situations where the imaging is less clear. We know these ctDNA changes can be prognostic. That's going to help you figure out which patients have had dramatic benefit versus not. This is the INSPIRE study published by the Canadian group. And finally, this same monitoring application can be applied in the post-surgical curative setting. This is the IMvigor O&O data in bladder cancer, I'm sure you're familiar with. In patients who are ctDNA positive, boom, they progress and they recur. Terrible outcomes. These are the patients we need to be getting towards intensified adjuvant therapy, as discussed, next generation adjuvant therapies. And the patients who are ctDNA negative, they're the ones who have the more dramatic benefit. And so I do hope for a world where as the assays mature and become validated, we can right-size our therapies so that the right patients are getting intensified adjuvant therapy and other patients might be able to avoid it. All right, I'm going to wrap up. Modern oncology care is precision oncology care, right? And we need to make sure that patients have the opportunity to benefit from this optimism and this revolution in how we're caring for patients. New diagnostic tools are needed to maximize the potential of these precision therapies. We need available, scalable, validated tools that don't lead us astray, but that we can trust to help get our patients on the right therapy. But we, the oncology community, have to demand even greater impact. I do think these tests need to be more and more useful. We have to ask for more usefulness. We have to ask for those trials that demonstrate usefulness from this growing diagnostic toolkit. And I will end at that. Thank you. Question?
Dr. Lefroy, can I ask you a question?
Please.
Yeah, I'm the chairperson.
Of course.
Okay, so I take the advantage of it.
Good.
And ask you two questions. One is that whatever cases you presented were with a high volume, big mass in the lung, big multiple bone metastasis, liver metastasis, nicely presented. Very good. What happens in the low volume disease? You may have a small mass in the lung and maybe one metastasis in the bone. Will the liquid biopsy will be equally informative?
Great question. And the short answer is, if there's low volume disease, I don't order a liquid biopsy, right? Those are the patients where I favor tissue testing. And I don't believe liquid adds anything, right? It's really, liquid is in those situations where there's urgency, where there's shed. If the patient has lower burden, I'll get a biopsy, I'll look for archival tissue, and I'll favor for tissue testing. And so I do think we need to fit these tools together. Some patients are better suited for tissue testing, some for liquid testing. Does that agree with your experience too? Great. I got the question right.
I have a second. One is that usually, what is the meaning of biopsy? Biopsy means you should be able to look under the microscope and give the tag. So the name is misnomer, I feel, because biopsy means you should be able to look into the microscope and diagnose. Can you do that for the on the blood?
I don't necessarily think biopsy means microscope. I think biopsy means querying the tumor. For example, these new cancer detection tests that are floating around, taking non-cancer patients and I'll magically find cancer, that's not a biopsy. That's a screening test, right? But a biopsy is in a cancer patient, querying their tumor biology, and being able to do it just based on DNA is very satisfying to me. And I would say my molecular pathology friends would object to you saying that what they do isn't a biopsy, just because they don't use microscopes that much, right? It's a different kind of microscope, I would say. But when applied to non-cancer patients, it shouldn't be called liquid biopsy. And I do agree that this term is a little bit casual and can be misused.
Thank you.
I have one question. Like you showed in the last case, excellent responder to an immunotherapy. After a year, you found out ctDNA is negative completely, and you took a call to stop the immunotherapy. So we all know that somewhere for the excellent responders, there is a way we can stop immunotherapy, and then they live a normal life after that. So is this liquid biopsy now shaping up to be that tool to tell us when to stop?
I think that's an incredibly exciting and honestly, it's a great research question for India, it feels like, where clearly there's resource constraints over how much you can use these drugs. I just want the test to be developed to meet that question, right? Because if you send a liquid biopsy to say, well, is your cancer gone or not, and you find some clonal hematopoiesis, some white cell mutations, a DNMT3A, you might say, oh no, there's cancer there, but it's not really cancer. It's non-cancer mutations. And so for us to do that, first we need doctors and patients to be open to the idea of stopping. And I think you're saying people are open to it.
Yeah,
and,
we are.
And then we need a diagnostic test that's been validated to be able to say, based on this kind of signal, intensify, and this kind of signal stop. I think it's a great research question. I would love to talk more about how we can investigate that using the tools we have today to really build the evidence to give us confidence to give that a try.
In a single word, liquid biopsy is complementary or supplementary to tissue biopsy?
I showed you a patient. Well, first off, you need a diagnosis. You need a microscope. Everyone needs a biopsy. Like, I think once I've treated a patient with an EGFR mutation, a 90-year-old lady who refused a biopsy. And there is actually a study from China where they treated a bunch of patients who refused biopsy based on EGFR mutations, and they did well on liquid only. That's not the world I see, right? There's something real about the diagnosis. There's something real about the pathologic specimen. And yet, the liquid biopsy provides the genomics and very much can. I showed you cases where the genomics is convincing. We don't need the tissue genomics. And so I think some patients are right for tissue testing, some for liquid. And sometimes you need both, but I'd rather not. And I'm out of time. And thank you all. We'll talk after, okay?
That was an engrossing session by Dr. Jeffrey Oxnard. Thank you, sir. Moving on to the next panel discussion. Panel discussion on precision medicine in colorectal cancer and case discussion. I would like to invite the chairperson, Dr. Imran Sheikh, consultant medical oncologist at Kokila Dhirubhai Ambani Hospital, Mumbai, and Dr. Indu Ambulkar, senior medical oncologist at HCG Cancer Center, Mumbai. The moderator for this session is Dr. K. Govind Babu from Bangalore, consultant medical oncologist, St. John's Medical College and Hospital. The panelists, Dr. Tejinder Singh, Senior Consultant, Medical Oncology, Apollo Hospitals, Mumbai. Dr. Anurag Mehta, Director, Lab and Molecular Diagnostic Services, Rajiv Gandhi Cancer Institute, Delhi. Dr. Kamal Raghav, Associate Professor, Department of Gastrointestinal Medical Oncology, Division of Cancer Medicine, the University of Texas, MD Anderson Cancer Center, Houston. Dr. Vamshi Krishna, Director, Oncology Services, Senior Consultant, Medical Oncology, Yashoda Cancer Institute, Hyderabad. Dr. Shyam Agrawal, Director, Navodaya Cancer Center and Medical Oncologist in Bhopal. Dr. Kaushal Patel, Senior Consultant, Medical Oncology and Hematology, Elite Hemat Oncocare Center, Surat. We welcome you all.
Good afternoon. Let me thank Dr. Sandeep and his team for asking me to be here today. And you have heard enough of precision oncology with respect to several tumors. So let's see how much we have evolved in colorectal cancers. So this is greetings from Bangalore, some of the nice blossoms that we have right now. I think one of our panelists is missing. Okay. So these are my panelists. So let me start with this patient. Actually, there's a patient who's come to us in 2019. So we look at what happened at that time and how we have progressed today. And if he had come to us today, how we are going to treat him. So this is a 60-year-old gentleman who on a regular health checkup was found to have liver metastasis on the ultrasound examination. So Dr. Bharat, I think Bharat is missing. Okay. So, okay, what did we do next was that we did a CT scan and a colonoscopy, and he was diagnosed to have carcinoma rectosigmoid with liver metastasis. So his comorbidities is that he's hypertensive and diabetic, well controlled. So how will you manage him? I think Vamshi is also missing. Oh yeah, you are here, okay. So Vamshi, what would you do? So remember, you're seeing him in 2019, not today.
Well, this is a left-sided colon. Definitely, I think we'll be, at least at that time, we were ordering the KRAS, NRAS, and BRAF. And for the liver lesions, I think we'll see whether we can see that it is a resectable or convertible lesion. And based on that, we'll plan for chemo with MAB, EGFR MAB.
Right. So this was the algorithm that we would have followed, seeing how this patient, his assessment, what your treatment goal is, and what your treatment strategy is. And as you mentioned, we had evidence for chemotherapy with biologics at that time. And this is just to show you that use of bevacizumab with oxaliplatinum-based chemotherapy consistently had an overall survival of over 20 months. And this combination with irinotecan also showed consistent survival over 20 months. And this is showing you that regardless of what chemotherapy was used, bevacizumab did have a good effect. And this is data from almost 4,000 patients. So evidence-based medicine forms the basis of clinical decision-making. And this has shown that there is consistent data. So this is, at that time, we had data from biologic agents for the first line with bevacizumab, cetuximab, and panitumumab. And the largest data was with bevacizumab. So this is one of the ESMO guidelines that is put up, saying that you actually group your patients when you see with this disease into 4 groups. That is based on what your decision of therapy would be. So maybe I'll ask Sham, do you agree with this sort of a workup or categorization of your patient? This is from the ESMO guidelines, actually.
Yeah, definitely. 2019, yes, but today is different.
Right. I think sidedness, Dr. Vamshi already mentioned. So Sham, you can continue with this. What are your thoughts on sidedness and CRC?
Yeah, now sidedness is also a kind of predictive marker. So if we have left-sided with the wild-type RAS, then definitely you'd like to use anti-EGFR rather than the opposite side, right-sided, more bevacizumab will help. So that is a predictive marker also.
So although this data is from 2 studies and a retrospective analysis, but the evidence is so overwhelming that we continue to use that in practice. We are not looking for randomized clinical trials with upfront data being driven. And this we know because of the embryology and the origin of colon. More important today, because we're talking of precision oncology, we know that the molecular heterogeneity is evident in the sidedness. And this is just to show you that there are different genes in different part of the colon, and that's what is responsible for the outcomes. So this is another slide just to tell you that tumor location is prognostic, not just prognostic, but also predictive when you're looking at EGFR inhibition. So that is what is the basis. So coming back to our patient, he received 2 cycles of chemo, FOLFIRI in 2020. And by the time he came to us, he had received 17 cycles of chemotherapy. He came to us for further management. He was evaluated for surgery. He did undergo some sort of chemoreductive surgery with some liver resection as well, but it was not an R0 resection, unfortunately. And at this point of time, we actually looked at the markers. He was tissue was HER2 gene amplification was negative. PDL1 was also negative. KRAS mutation was wild type.
To PDL1 and KRAS. So I would also like to add something like BRAF as well as MSI in this marker analysis. And it is KRAS wild type who has received lot to add anti-EGFR if the patient is still...
No, I'm talking about him reaching you today.
Yes.
I just told you what he had because we saw him in 2019. I'm just trying to bring out how we would today look at him in a different angle.
Yeah, so apart from the done markers, I would like to add 2 more markers like BRAF as well as MSI in this particular subset, and would like to add anti-EGFR along with the chemotherapy.
All right. So maybe I'll just go to Dr. Anurag now about genomics. So if you just look at this slide and you heard about lung cancer, if I had not put up the title, maybe you would have thought this is a lung cancer pie. So we have really made progress in colorectal as well, although non-small cell lung cancer continues to be a poster boy for personalized therapy. Yes, Dr. Anurag.
So I think he has already spoken that MSI is one actionable biomarker. The other is a BRAF V600E. The third is the HER2 amplification. PIK3CA, exon 20, that is H1047, in some databases has been shown to be actionable by alpelisib, but the data is still ambiguous. And if you look at the C-Bio portal, and 30,000 cases, 5 cases had ALK rearrangement and ROS1 rearrangement. So if you are looking at those tail end actionable alterations, non-recurrent in particular cancer, you can do those kind of very comprehensive genomic panels, and you can, if you're lucky, if that patient is lucky, and that shall be a shared decision between the doctor and the patient to go and do that kind of a panel, then maybe one can use targeted therapy for those kind of and NTRK, of course, NTRK.
That's right.
So
Yeah.
so I will take like NTRK, ROS1, and ALK have been identified in very large databases at a very low frequency. So one can actually look for those as well.
Correct. So this is just again to show you that we have several mutations, but most important for us to decide on a therapy is whether it is KRAS mutant or wild type, because then you decide on the EGFR antibody. And what's come out is that additional mutation analysis increases the proportion of patients with mutation. So again, I think Dr. Oxnard also told us that as clinicians, we need to drive the lab to what we want, and that has to be meaningful. So this is just to show you that the RAS mutations, the wild type continues to increase as you test for more and more mutations. So the impact of tumor characteristics on treatment decision. Tejinder, yes, you just arrived.
The last one to come, yeah.
Good. So actually, I put up the answer for you. So this is the algorithm that we generally use. And because we're looking into tumor characteristics and how you decide your treatment, you have so many options. Essentially, we look at the initial one is whether RAS is mutated or not, and BRAF as well. And now we are looking at several other markers as well. So coming to the NCCN guidelines 2023, this is the guidelines, and we also have recently published the Pan-Asian adopted ESMO guidelines. And as you can see, me and Dr. Chaco are two of the authors on this paper. And essentially, it's similar to this NCCN guidelines, which actually has looked at the first-line therapy options and pembrolizumab or nivolumab plus minus ipilimumab for this specific DMMR patients, and for those patients who are not appropriate for intensive therapy, again, looking at immunotherapy. So looking at MMR or MSI status has become mandatory in the first line. So what are your thoughts on this, Tejinder?
Yes, in a metastatic setting, I think it has become the first tool nowadays.
Right.
Patients who are basically eligible for immunotherapy, they should be started on MMR
Right.
from the day.
So this is the data for atezolizumab in the first line, and this is Keynote 177 for pembrolizumab, and this is showing you the overall survival. Dr. Bharat, what are your comments on this? Bharat is not there, so I'll ask Vamshi.
I think for those with MSI high, Pembro, I think shown in 177, and I think in real world also we are seeing the same responses in metastatic setting as a single agent IO. I think it's something which has least toxicity and can be tried for this MCRC.
Okay. So what's been your personal experience treating these patients?
MSI high, the percentage of patients being MSI high is not that high, actually, what we see. So majority, as well, what we have seen from the data, we see the KRAS mutated or the mutated patients. But if these patients, they increase, if we get more percentage, I think then we'll have better responses. But those who have positive, we have seen that the responses are good in these patients.
Yeah. Tejinder, you had something to say?
I had one experience of one patient. It's
Yeah.
Very, very good response. Last 1 year, but on CR.
Yeah. So in 2019, this was not even a thought in us. So today we have really shown so much of progress in our management. So this is the other one, BRAF V600 mutant patients, and this is the anchor study. And again, Vamshi, what are your thoughts on this particular study?
Actually, I think data is appealing, but no personal experience of using this drug at least.
Okay. How many of you from the panel, anybody can answer, how many of you have seen BRAF mutant CRCs? You have seen?
We have seen.
Okay. So I think as you start looking for it, you will see more and more. Even if the chairpersons have some comments, I'm sure you can go ahead. Do you have any experience, Indu, treating BRAF?
No, sir, I have not seen any BRAF mutant colon cancer.
So, Dr. Govind, those cases which are basically have CpG island methylator phenotypes, which are MLH1, which are MLH1 PMS2 negative on MMR IHC, great majority of them, or at least 50 to 69% of them will have BRAF V600E. So it is not rare. It is fairly common. The same makes up about 20%, including 2 to 4% lynch. The rest, 16% to 18%, are basically with the, of them, 60% will have BRAF V600E. So it's fairly common if you will start testing for these.
Yeah. So the point is we are not looking for it, and that's why we are saying it is.
Absolutely.
Okay.
I think you will have 10% of the cases at least. That's a ballpark.
Right.
With BRAF V600E.
Right. So I think that pie which I showed initially, in a few days, it will be like the non-small cell lung cancer pie. So HER2 amplification, it's said to be seen in 4% of CRCs, and it's said to be mutually exclusive with RAS and BRAF mutations. Dr. Anurag, what are your thoughts on this? I know earlier we thought EGFR, ALK were mutually exclusive in lung, but we also, from our institution, have published a series of that. So what are your thoughts on this particular statement?
I'm not sure whether they are mutually exclusive. But to treat HER2 amplification
Yeah.
with, as per the Heracelis trial, phase 2A trial, I think the B has failed. The one that had tucatinib with whatever, trastuzumab.
Yes.
For that, RAS negativity was essential. But I don't know whether the RAS and HER2 amplifications are mutually exclusive. So I think because they were very repeatedly writing that RAS negativity is necessary for administering that treatment, probably they may not be mutually exclusive, but
Right.
I really don't know that.
Yeah, I think this is still data and evolution. We don't have enough numbers to actually say, like, I took the analogy of EGFR and ALK. It was a categoric statement that they were mutually exclusive, but then we found that it is not so. So I think as we start testing, we will realize the same with this as well. So this is anti-HER2 combinations that we have. Sham, your thoughts on this particular slide? You have your multiple
No
choice.
personal experience, but I had a case discussion in one of the panel, and where we found that single drug is useless. Trastuzumab should not be used; should be always doublet. And secondly, the Druxtican is coming in a big way, and it's giving very good responses, and OS also in HER2 positive.
Right. Anybody with experience of using HER2 targeted therapy in CRC?
So I was just reading very recently, I think the Heracelis phase B, which has combined trastuzumab, deruxtecan, has failed. It has not met its objectives. But Heracelis A had actually met with its objective, which was tucatinib with trastuzumab.
Right.
The one thing that I would like to say is that when you are actually looking for HER2 amplification, the HER2 amplification should be looked for as per the Heracelis scoring system and not as per the ESCO-CAP for the breast
The
or
breast,
esophagogastric
that's right.
system. Though the CAP says you can, but because the Heracelis scoring system is a very tough system, but the scoring should be done as per the Heracelis scoring system in case you are actually wanting to get some responses.
All right.
Sir,
So since this is
HER2 amplification,
go
if I
ahead.
may intervene, sir. We have got two patients. One of them did really poorly with the combination, and one of them is surviving for 2 years.
Which combination?
Pertuzumab and the trastuzumab
Okay.
combination.
Okay.
It's a costly thing, but with FESGO coming in breast cancer, maybe we can carry it forward to this category as well. Though it's a very minute percentage of patients, but I think some of them can really benefit for a long period of time.
Okay. So the other mutation
Dr.
that
Govind, I just
yeah, go ahead, Sham.
going at HER2 should be tested in RAS wild type only, because the mutant never is positive in HER2. So that is what the comment I just want to make.
Correct. So this particular mutation, we always thought KRAS was a bad thing. Now we have a drug for that, and this has really made news last year. So this is the crystal study of adagrasib. Kaushal, what are your thoughts on this particular molecule?
I have no any personal experience because it's not available yet.
Yeah,
and
I
as
don't
well
think
as,
India was a part
yeah.
of this study as well.
Yes.
Yeah.
Theoretically, it's okay. We can say it, but once we get some experience with the drug regarding the efficacy as well as the side effects with our patients, then we can have some proper idea regarding the molecules.
Correct. Yeah. But the initial paper, which was actually presented of 12 patients, showed 100% pathological complete response. So we need to wait again, right? So this is the other study, combination of pembro with lenvatinib is coming up in almost every cancer today.
Yes.
Yeah.
So it can be an option of the treatments if it is not used previously.
Right.
Because it's MSI positive patients. MSI stable, sorry.
So the other one is the NTRK. I think Dr. Anurag was talking about it. In your hospital, have you seen this mutation in CRC, Dr. Anurag?
I've seen two of these, both in the lung cancer.
Okay.
And I know of one patient who had excellent response with entrectinib. What means
Right.
70% tumor regression with entrectinib.
So we spoke about the molecular changes between right and left colon. There's a paper talking about molecular variances between rectal and left-sided colon cancers. So it's getting dissected even more. And this is just to show you the mutation frequency of comparison between rectal and descending colon cancers. And as you can see, for the TP53, APC, KRAS, PIK3, BRAF, for all of them, there is some change. And this is again talking about the mutation frequency comparison between sigmoid colon and descending colon. So there is a difference. And this is for looking at microsatellite instability. So you can see for rectal cancers, it is pretty low, whereas for the splenic flexure and descending colon, it's high. And the sigmoid colon is in between. So I think it's becoming more and more important that we look at molecular signatures in each part of this colon. And this is again looking at the other one, HER2 overexpression and amplification. So we are being blasted with so much of data. This is what, as an oncologist, I think we would feel today. So what happened to our patient? He survived till 2021 with the therapies that we have given him. And this was the PET scan of March 2021. His hepatic lesions had increased. Retroperitoneal lymph nodes also were there. So what did we do for him? He was discussed in MDT. There was no role for surgery, so we continued chemo, FOLFIRI plus bevacizumab till March 2021. And in June 2021, his PET scan showed an increasing disease in the liver. We again did a biopsy, and we looked at, we now do a 500 gene panel for many of these patients of recurrent disease. This didn't show anything specific. So in July 2021, he was started with ramucirumab and 5-fluorouracil, which he continued till October 21. And in October 21, his assessment showed that there was progressive disease. CA had jumped to over 1,000, and he was started on FOLFIRI plus bevacizumab. This was a very compliant patient. His wife was also very compliant. In fact, she had a chart of how he was responding to each therapy from 2019. So it really helped me to look at it. And she said, this is a combination that he did well initially, and there was a long gap. So we went back to that. So this is his PET scan in March of 21 and October of 21. You can see that there is some response. So in December 2021, when he came, his ascites had increased. He had abdominal pain, and he also had a ventral hernia because of the previous surgeries. So what would you do now? Bharat is not there, so I'll ask Tejinder to take this question.
So he has taken FOLFIRI with Bev, then he took 5-FU with
Yes,
Rani also.
he had FOLFIRI, FOLFOX, he had cetuximab, he had bevacizumab, he had ramucirumab.
So I think the best thing is to go for Agar only, or best supportive care.
Rechallenge with anti-HER2 or anti-EGFR.
Yeah, in between he had a rechallenge as well. So at this point of time, I again discussed with him, and what I told him was that there was this phase 2 data of pembrolizumab with lenvatinib. That's a LEAP 005, and we started him on this in December 2021. And this was his scan in February of 2022. So he has definitely shown a response. So I just put this slide. Of course, this is an old one from 2007, which said that the median survival increases with increased lines of therapy. So if the statement was in 2007, I think today it's even more relevant. And so I just thought I should put the slide. And as you can see, this patient from 2019 to 2023 has 2022 has gone on multiple lines of therapy. Of course, your patient needs to be well motivated. He needs to tolerate it well. Those are all there. But the evidence is that as you give increased number of cycles, the survival improves. Today, we are looking at molecular biomarkers and targets. And one of the newer classifications is the CRC molecular profile. So I'll ask Dr. Anurag to comment on this.
So, the first is the immune one. We all know it's MSI high and has what do you say? It includes the lynch also. And
I think you need to hold your mic a little
closer.
closer.
The second one is the chromosome instability one, the classical one, the canonical carcinomas. The third is the metabolomic, which is a copy number alterations is pretty high. And I think the fourth one is a mesenchymal, which show epithelial mesenchymal transformation and also has a high copy number alterations. But this is really not practiced.
That's
what
right.
we practice is SIMP versus CIN.
That's
And
right.
that's how it goes.
Yeah, although this was published in 2015, and it seems to make a lot of sense, but it's not been widely accepted and followed today. So this is the current view of how we treat. We have so many things for us. I think a bit of it we have already discussed. So since we are talking about precision oncology, we have heard so much about liquid biopsy. Let's see what its role is in colon cancer. Tejinder, have you had any experience of liquid biopsies in colon
No,
cancer?
I don't practice liquid biopsy. The only thing which I felt is it does, I think in the near future it will have a role.
Okay.
So I feel the CTCs will help us in monitoring the disease.
Right.
Also. Yeah.
Yeah, I think you have.
Sir, I think liquid biopsy, as far as the literature goes, says at the time of diagnosis, it's not that helpful. But if a patient relapses, then the tumor sheds more of this circulating tumor cells, and there are more chances of picking them up. So at a relapse, it might be of more interest in and more useful in doing a liquid biopsy than at the upfront setting.
Second thing is that I think there is always a opinion that when you look at the radiographic progression and the CTCs give you help in at least 3 to 4 months earlier. The question is that how many of us really practice CTCs?
Yeah.
So if you are not going to drop cetuximab, and if you are willing to change the chemotherapy backbone, then maybe you need to test for the RAS at progression.
Right.
And if it is still wild type, then you can actually change the chemotherapy backbone. So I think that is the time when a liquid biopsy, because you may not want to take a biopsy from a metastatic site, or it may be difficult, a liquid biopsy can be helpful. But I don't think most of you physicians do it. And the third thing is that KRAS reversion is also well known. So you have to
Yes, I'll show you
progress.
some data on that. Yeah.
You're coming back on that? Okay.
Yeah. So, when we talk of liquid biopsy to CTCs plus the ctDNA, so this is a slide I actually put up because in September 2013, there were more than 400 registered clinical trials with CTC as biomarkers. But the CTC has really not taken off. And this is one paper in 2008 in JCO, which looked at the number of CTCs in colon cancer, and they said those who had more than 3 and less than 3, there was a difference. Dr. Shafi is here. Your lab has been working on CTCs. So what are your thoughts on CTC in colon cancer?
Patients who have found their CTCs, and particularly it's helping us to understand, where the meds goes, maybe liver meds, and we have found that there is a good differences if you find the CTCs. Now, next is CTC alone number is not sufficient. We have to functionally characterize those based on maybe genomics, transcriptomics. That's what we are doing now and seeing how it's going to help us.
Yeah. So roughly how many colon cancer samples have you had in your lab so far? And you're also looking at PDL1 testing on CTCs, isn't it?
Yes, we do right now PDL1 on CTCs as well as HER2 on
HER2,
CTCs.
yes.
Colon, I don't have an exact number, but altogether we have about 100 plus in a month.
Right. Thanks.
Thanks.
So this is one paper I thought had a fantastic title, Liquid Biopsy is a Spectrum of Opportunities. So I think that's very true. We have heard in the morning as well. And this is one paper which Dr. Anurag was talking about, dynamic monitoring of circulating tumor DNA to predict prognosis and efficacy of adjuvant chemotherapy after resection of colorectal liver metastasis. And this is a plot showing you all the genes that they looked at. And this is talking about those patients who had ctDNA only, that is in red. The blue one is tissue only. And the yellow one is for shared mutation, that is tissue and the liquid biopsy both had mutations. And the blue one is for, light blue one is for those who had no mutations in both. And this is again showing you that at baseline what the quantity of this DNA was. and those who got neoadjuvant chemotherapy and then underwent surgery. So there is a pre-op estimation as well, followed by post-op and post-adjuvant chemotherapy. And as you can see here, those patients who had a partial response are the ones that showed a decrease in the ctDNA, whereas those patients who did not respond or had stable disease, the ctDNA did not decrease at all. So this is a nice study which has actually used liquid biopsy to talk about the outcomes in these patients. And this is again looking at the levels here, looking at the survival curves. I'll go to the next slide just to tell you that in those patients where the post-op ctDNA was negative and post-adjuvant chemotherapy it was positive are the ones who did the worst. This is a red line. Those patients who had post-op positive and post-adjuvant chemotherapy negative, the light blue line, it's here. Those who had post-op positive and post-adjuvant chemotherapy also positive are somewhere here in between. And those who had post-op negative and post-adjuvant chemotherapy negative are the ones who are doing the best. So this is, although it's a small study, it shows that this is a way that you can actually follow it. So this is one of our initial studies that we were looking at liquid biopsies, and we did in lung and colon. 16% of this was from the lung, and this is just to show you the various mutations that we were able to detect on liquid biopsy. So this next paper is looking at circulating tumor DNA to monitor therapeutic response and resistance in advanced colorectal cancer patients undergoing combined targeted and chemotherapy. So this is to show you those patients who had KRAS and P53 together, and those who had KRAS and P53 not co-mutated. And again, they followed the serially in liquid biopsies and showed that those patients who did not have this co-mutation are the ones who are doing better. So the value of looking at liquid biopsies in minimal residual disease. And again, this is a small paper, but again, a proof of concept showing that you can actually detect the ctDNA. If it is undetectable, you can, this is the surveillance that they have done. If the ctDNA detection happens, then you look at what is happening. You could look at imaging for detecting. That comes much later. And this is a definition of minimal residual disease, that it is undetectable or just starts getting detected. And this is data from this Avino platform assay, which looks at 197 genes, and this is in stage 2 and stage 3. And as you can see here, that those patients who had a ctDNA positive, as you can see, the numbers are small, but again, showing you that in those who are, it was negative, those are the ones who are doing well, almost 1,400 days, and those it was positive, they're doing badly. So remember, this is stage 2, and for stage 3 as well, very similar graphs showing you that there is some value in looking at the ctDNA for monitoring. So there is a paper from NCI which looks at ctDNA application and integration into colorectal cancers. So this is actually showing you how you can use the ctDNA at clinical diagnosis, neoadjuvant therapy, surgery, following adjuvant therapy, in monitoring, clinical recurrence, initial therapy, additional systemic therapy. All this can be done with ctDNA monitoring, and of course, looking at the resistance pathways as well. So we were talking about whether you can escalate or de-escalate therapies, adjuvant therapies, and this is one paper to show you that it is possible. So in those patients where ctDNA is negative, this could be an opportunity to de-escalate standard treatment. And if it is positive, then it's an opportunity to escalate standard treatments. So this is another one looking at serial monitoring of these mutations and the tumor responsiveness. So again, this is just a serial following up of all these markers that are there. And again, showing you that liquid biopsy is a good way of trying to follow up these patients. So chemotherapy definitely has improved survival, but more needed to be done. And if you see the survival from 1980s to 2000, we have definitely made difference. but 5FU continues to remain a backbone for the chemotherapy part. With the biologics, we improved it a little more. And with novel targeted agents and immunotherapy drugs, it's come up even more. So I think that's one of my last slides. Any final comments from our panelists?
My one comment is that in colorectal cancers, we have a great opportunity of finding inherited cancer predispositions. 2 to 4% cases are Lynch syndrome.
Correct.
And then there are others like, FAP and MUT-YH, MAP, etc. So I think we shall always exploit that opportunity and find out inherited cancer predispositions in these families, and that can truly help giving a near normal longevity to those individuals who have been a healthy mutation carrier so far.
Absolutely. Anybody else? Any final thoughts?
Can I ask one question, sir?
Yeah, go ahead.
To the medical oncologist and Dr. Anurag also. Do you, with this MSI high thing coming in and showing such good results, do we club all MSI high together and see similar results with immunotherapy? Or do you see some categories like based on the MLH, MSH, or the PMS one, whichever is defective? Do you see some other, do you see some differences in the results, or they are all the same? They respond in a similar way? Experience on.
No, I won't have an answer for that. I have never tried to figure out whether they respond differently. No, I won't know.
I don't know whether any MSI high. Yeah, please, Dr. Shyam Agrawal.
Yeah, Dr. Shyam has something to say. Yeah, Dr. Jeffrey.
I can try to answer your question by not answering your question. So we looked at this for Pol E, for example. If you take all the Pol E mutations, some of them have no benefit to immunotherapy, but that's because they're VUSs. They have no Pol E signature, right? The ones that are true pathogenic Pol E mutations and have a pathogenic Pol E signature on tumor sequencing have the immunotherapy benefit. So my guess would be, is there any risk of noise in the assay, and are there some MSI high on your assay that aren't truly having an MSI signature? But I don't perceive in those cancers that have an MSI signature on genomics we haven't seen any biological outcome on therapy. It's just making sure you have a real pathogenic MSI signature.
Yes, Dr. Shyam.
Yeah. So, to highlight this issue of discordance of response to immune checkpoint inhibitors in patients with, MSI high. So now you have the approval in first line for metastatic CRC with MSI high. But if you have liver alone metastasis, responses are not all that good. So it is not in the guidelines to use immune checkpoint inhibitors upfront for patients with liver alone metastasis. So there are certain differences between the microenvironment for patients with liver alone metastasis, although they are all MSI high, but they are not responding that well, 70, 80%. So I think you still stick to chemotherapy for liver alone metastasis. The reasons are not clear. I mean, you said MSH2, MSH6 versus the other one. So those could be, certain differences which we need to understand.
Yeah, I think that again underscores the importance of tumor heterogeneity, intratumoral and spatial heterogeneity as well. And
I'll just
yes,
like to, add on. So we know that 90 to 95% are because of MLH1. MLH1 and MSH2. So the cells don't accept the redundancy there is no redundancy in these proteins. They are functional. But if there is any redundancy in MSH6 and PMS2, I really don't know. But in addition, sometimes biallelic loss of MLH3, endonuclease 3, like NTHL3, and pol can also lead to MSI high tumors without responding to the immunotherapies.
So, yeah.
Because regarding the talk given by Dr. Oxnard, some of them would respond exceptionally well and maybe in 1 or 2 cycles only.
Yeah.
I was alluding to that. Maybe the MLH ones are the one, the Lynch proper one or the Lynch-like one. They respond very early, and maybe maybe fewer cycles of immunotherapy are sufficient for them.
Correct.
As compared
So-
to just going on till
So
disease
my boss used to say why tumors behave differently is because they never read Divita. So with that, I think we have had, yeah, go ahead, Anurag.
Response to him is, of all those show loss of a protein, the least likely to have lynch is the MLH1.
Right.
Because great majority of them will be because of methylation and not because of alteration. Though overall number will be high, but the likelihood, if you have an MSH2 loss, 75% possibility it will be lynch. If you have MSH6 loss, 75% possibility it will be a lynch. I mean, if there is a combined loss or MSH6 individual loss, if there is an MLH1 loss, then the possibility will be 10 to 15% that it is actually a lynch.
Thank you. So I think with that, we will stop here, and I'm sure there's a nice dawn for all the colorectal cancer patients from what we have discussed today. For some time back, it was not like this, and we were looking at lung cancer itself. But I think a lot of things are happening, and we've seen how precision oncology is actually picking up in colorectal cancer as well. Let me thank all my panelists and the audience who are involved in the discussion. Thank you very much.
That was an interesting session. Thank you so much. Moving on to the next talk on the role of HRD testing in precision oncology. I would like to invite the chairpersons, Dr. Darshana Patil, Medical Director, Datar Cancer Genetics Limited, Nashik, Dr. Yogesh Kulkarni, Head of Gynecologic Oncology, Robotic Surgeon at Kokilaben Dhirubhai Ambani Hospital, and the speaker, Dr. Vamsi Viramachanani, Bangalore. She's the Chief Scientific Officer, Strand Life Sciences. Sorry.
Thank you all for inviting me for this talk. Today I'll try to talk about the role of HRD testing in precision oncology, and I'll also spend some time discussing in more detail exactly what HRD is, because there are so many different definitions of HRD and there are so many different assays coming up. I think it's important to understand the subtle differences between what they're trying to measure. The first slide, I think one letter is cut off. Hopefully the rest of the slides are not susceptible to that. So we're talking about HRD today, and it's about homologous recombination deficiency. So before we can talk about something being deficient, we need to understand what exactly is the pathway that we're talking about. So first, I'll spend some time talking about what homologous recombination repair pathway is, and then we can get into the deficiency aspects of it. And then the deficiency is defined by multiple metrics. So I'll try to talk about the different criteria that are used to measure homologous recombination deficiency, the permutations and combinations of the different metrics that are used, and then some of those metrics which have been used in trials and the approvals that have been obtained for use of PARP inhibitors when there is HRD. And after that, there's a whole slew of tests that are coming out that are aiming to measure HRD in different ways through sequencing, through imaging, and so on. I'll try to explain some of the core elements of what many of these tests are measuring, because as we progress and more of these tests come to the market, I think it's important for you to have an understanding of what is the principle on which those are based. And we have been doing HRD testing for the last 2 years approximately. And obviously, because we run a diagnostic laboratory, we just process whatever samples come to us. But the statistics of the samples that have come to us, I'll show you some preliminary results from those statistics. So let's start off by talking about homologous recombination repair. Cells are undergoing inserts all the time, and they're undergoing single-strand breaks, double-strand breaks. And there's a very robust machinery inside the cell that is repairing these cells continuously. But broadly, you can categorize all of the repair mechanisms into two large groups: single-strand break repairing pathways and double-strand break repairing pathways. So in terms of single-strand breaks, you have again multiple pathways that are involved depending on the nature of the single-strand repair that needs to happen. You have the base excision repair pathway, which happens to be one of the most active ones. Then you have the nucleotide excision repair, and then you have the mismatch repair. So these are three different pathways involved in single-strand breaks. When it comes to double-strand breaks, you have two major pathways. One is the homologous recombination repair pathway, and the other one is the non-homologous end joining repair pathway. So let's take a small detour into understanding how do these different repair mechanisms come into play. So let us say we're starting off with an intact DNA and it has a single-strand break. Then the main thing that comes into play is the base excision repair pathway. The damage gets repaired, the cell is intact, and the cell continues to thrive. But if you were to inhibit this base excision repair pathway, and PARP is an integral member of this base excision repair pathway, if you were to inhibit that particular process, then that single strand break is not going to get repaired, and it can change into a double strand break. And once you have a double strand break, then the double strand break repair pathways come into play. And the main pathway that plays a very accurate role in repairing the double strand breaks accurately is the homologous recombination repair pathway. And many of us are aware of the BRCA genes and multiple other genes, the CHEK genes, PALB2. Many of these genes, roughly around 42 genes, are involved in this HRR pathway, of which BRCA1 and BRCA2 are the most well known. So if you have the base excision repair pathway is inhibited by PARP inhibitors, then the single strand breaks progress into double strand breaks. The double strand breaks can get repaired by the HRR pathway, but if there is a homologous recombination deficiency, then even the HRR pathway is not active anymore. And then the NHEJ pathway comes into play. And this one is a very error-prone repair pathway, because of which it does not repair the cells accurately and results to what is commonly called as BRCA-ness or genomic scarring. And that is what eventually leads to cell death. So what we're really looking for, this picture tries to explain when and why PARP inhibitors are effective. PARP inhibitors will prevent the base excision repair pathway from progressing. And then if there is homologous recombination deficiency, then HRR also will not be active. And then it goes down through NHEJ, which is an error-prone repair mechanism, and cell death. So now we really need to look into when would you prescribe PARP inhibitors? You'd want to prescribe them only if the HRR deficiency is there. And what are the different ways in which we can assess whether there is homologous recombination deficiency? There are broadly two ways in which you can go about it at a DNA level. You could either look at the HRR pathway itself, and I mentioned there are 44 genes in that pathway, with BRCA1, BRCA2 being the most well-known of them. So you could do sequencing of the genes in the HRR pathway. You could do it as a germline test. You could do it, you could restrict your attention to only the BRCA genes, or you could look into the additional genes also. Or you could do it in the somatic context also, because some of these mutations might be somatic. So you can do somatic BRCA testing, or you could look into the 44 genes in the HR pathway. So in this way, you're looking mainly at the cause of the HR deficiency. And if you have high confidence in those mutations, that those mutations will actually result in HR deficiency, then you can go ahead. Or if you do not have a full understanding of the pathway, which is true in most cases, we do not have full understandings of how these pathways works, then we don't need to look into the mutations of these 44 genes itself. Rather, we can look into what is the effect that NHEJ causes, what is the genomic scarring that manifests when there's HR deficiency, and try to simply see whether we see HR deficiency cause genomic scarring, and use that as a surrogate way of checking whether HR deficiency is there in the sample or not. And in terms of HR deficiency, there are three terms which are commonly used: loss of heterozygosity, large-scale transitions, and the number of telomere allele imbalances. And multiple combinations and different combinations of these three metrics are used to categorize whether a sample has HR deficiency or not. So because these three terms have become so common in literature, and many people talk about LOH testing, HRD testing, copy number alterations. I thought we'll go into a little bit more detail about what exactly do each of these terms mean and how accurately can you measure each one of these elements. So the common picture that's usually used to depict these three types of events is shown here. When you're talking about loss of heterozygosity, usually you have two different alleles at every location and they're in equal amounts. That's the normal cells that we have. But if you have a loss of one of those regions, then you only have one allele present, which means you have loss of heterozygosity. Now here I've shown a loss of heterozygosity that is caused through a copy number deletion. So one copy got deleted, so there's only one allele remaining and there's loss of heterozygosity. There are other ways in which loss of heterozygosity could also occur. For instance, you could have copy neutral loss of heterozygosity, where one allele got deleted and the other one had two copies. That's also loss of heterozygosity, but I'm not showing that here. Then you have imbalance in the telomeric region. Here is where you have a deletion that is extending to the telomeres, and because of which in the telomeric region, you're having an allelic imbalance. And the third metric is large-scale transition events. Here is what you typically call copy number events, but these are not events that are going across the entire arm or the entire chromosome. Rather, you have multiple moderate-sized events that are happening across the chromosome. And you have some regions with copy number 3, some with copy number 4, some with copy number 1. So you have a lot of transitions in the copy number profile across the genome. And that's what's called as large-scale transition events. And all three of these types of events have been shown to be present in samples with BRCA mutations. And so people have used them as ways of assessing the homologous recombination deficiency in a sample. The nice thing is all three of these, it turns out that all of them came out in 2012. This is when a lot of microarrays were done where you had tissue samples, you're doing microarray profiling across the entire tissue. And using that microarray SNP-based approach, you were calling out segments across the entire genome which are amplified, which are deleted. And that resulted in many publications which talked about these three metrics. So one of the publications from 2012 is by Abkevich et al., and it talks about loss of heterozygosity. And I have kind of taken the liberty to take some sentences from their abstract. So LOH in 2012, they defined it as LOH regions of intermediate size. And in the paper, in the details, they talk about 15 MB as a size. And it was almost an arbitrary thing. It could have been 15, it could have been 20. They started their analysis with 15 MB, and that's pretty much what stuck. So you have regions of size 15 MB. So you're not talking about entire chromosome amplifications or deletions. These moderately sized changes where some allele is being lost, those were called the loss of heterozygosity regions. And the number of such regions that are spread across the entire genome, number of 15 MB or greater size regions that are there in all across the genome where you have only one allele present, that was defined as LOH. And you'll see the interesting thing is they called it the HRD score. So HRD score has been continuously defined and redefined over the last 12, 13 years. And that thing will continue. But so this was the first definition I could find, which is talking about LOH being the HRD score, right? And then again, a second paper in 2012 is by Popova et al. And there they talk about genomic instability. So the term genomic instability and genomic scarring, all of those have become common language now. The genomic instability here was referring to only large-scale transition events. And here they defined it as the not copy numbers of just small focal loci, not single genes, but 10 MB sized regions undergoing copy number changes. And different types of copy numbers happening next to each other would result in transitions of that copy number. So that's what is called LST, the number of such transitions that you're observing of reasonably sized regions. And then yet another paper in 2012 is talking about the number of telomeric allele imbalances. They talk about, again, the number of subchromosomal regions. Again, you're not talking about an entire arm or an entire chromosome that's being lost, but a subchromosomal region which is extending to the telomere and which is causing a allelic imbalance. So that was the definition here. In each case, when you ran these large-scale SNP arrays on the tumor tissue, people could see all of these aberrations. And everyone is trying to grapple with how do I describe these aberrations and how do I quantify these aberrations. So each of these three papers chose a different way of quantifying those aberrations. And all of these aberrations were predominantly observed in samples which had BRCA mutations. So in samples which had BRCA mutations, they could see these aberrations. So you hypothesized that these aberrations are reflective of homologous recombination deficiency. And from then on, anytime you see these kind of alterations, even if you don't have BRCA mutations, people said that that tissue is homologous recombination deficient because there could be some other mechanism through which it's getting created. Okay. So you have these three papers which came out in 2012, and then exactly the same definitions which these papers came out with in 2012, they were used in 2016 in this study, where they took a sample, they computed LOH, TAI, and LST scores independently, added them up without any weightage, and said this is now yet another definition of the HRD score. And this paper by Telly and Timms is pretty much the start of the myriad testing, my choice testing for HRD calculation. And they added up these three scores, and you can see that because these were three independent studies and they're adding up the score, the same segment can actually contribute to different scores. If you have a region which is copy number altered, it could contribute to the LST score. If it's near the telomeric region, it could contribute to the NTAI score. It could contribute to the allelic imbalance score. It can actually contribute multiple ways. But the simplest thing sometimes is, if it works, it's the best thing to do. So here they just added up those three scores. And if it's greater than 42, they defined it as HRD. So now the question is, why choose 42 as a cutoff? What is magical about 42? And in reality, there's really nothing magical at all about it. They had sequenced, in Myriad, they had sequenced a lot of samples which were BRCA deficient and BRCA intact. So just samples with BRCA mutations or without BRCA mutations. And the whole idea of all of these scores was that the majority of samples which have BRCA mutations, you would expect them to be homologous recombination deficient. So in this graph, it's just plotted in red are all the samples which do not have BRCA mutations, and in blue are the samples which have BRCA mutations. And they plotted the HRD score, which is a summation of LST, NTAI, and LOH for all of these. And the criteria 42 was chosen only because they wanted 95% of the BRCA mutant samples to be above that particular score. So that's the only reason that that magical threshold of 42 exists today. Right? And once they chose that score, multiple trials were done with this particular score, and approvals were given. But it's always hard to argue, what does a score of 41 mean? What does 43 mean? Will it work? Will it not work? Luckily, all of you are clinicians who can make those judgment calls. We don't have to deal with that at a measurement level. So then, based on all of these landmark publications that had happened from 2012 to 2016, many trials were done by creating different cohorts of subjects and trying out PARP inhibitors in different cohorts. So, for instance, you have olaparib, which has multiple trials have been done, and the diagnostics test that was used there is the Myriad My Choice test, which is what I just described, where you compute HRD and check whether the score is greater than 42 or not. In the rucaparib trials, Foundation 1 CDX has been used, which is for LOH, and niraparib again has used the My Choice DX test, right? Most of you would be familiar with trials, so I'm not going to try to get into the medical side of things, but I'll just give a brief idea of what do most of these trials look like. Because now we are looking for a molecular marker, the cohorts that would be involved in the trial would be people who have that marker, people who do not have that marker, people who have a subset of the marker, etc. So this one, for instance, is the Paula-1 trial. And so on the top left, you have patients with tumor BRCA mutations. And you can see that the PARP inhibitor was much more effective in patients with the mutations when they were given olaparib compared to placebo. Then in the bottom right, you have patients who had HRD positive, but they do not have a BRCA mutation. So again, there is a significant response out here, but it is a little bit less than those with BRCA mutations alone. And then you have in the top right, you have patients without a BRCA mutation, and most of them would have a very low HRD score, and there you can see there's almost no benefit. So most of the trials were designed in this particular manner, saying, do only the people with BRCA mutations benefit? Do people with HRD score high benefit irrespective of whether they have BRCA mutation or not? And do people without HRD or without the BRCA mutation, do they also benefit? So roughly these three different cohorts would be analyzed. And depending on those results, the approval would be given either for efficacy or whether testing should be done before the drug is given, etc. And now there are many PARP inhibitor drugs in the market, and for different cancers and for different indications. Some of them rely on BRCA testing, some of them rely on HRD testing, some of them even look into HRR testing for different cancer types. So all of the drugs and the tests that I talked about so far are mainly going with the Foundation 1 test and the Myriad My Choice test. So in many developing markets, it can be challenging to send out samples to central laboratories, and the cost can be expensive. And there are multiple companies now coming up with their own versions of these tests based on the fundamentals of what exactly constitutes the HRD definition. So to understand how exactly would you compute HRD from the ground up, I've talked about LST, LOH and all, but mainly at a pictorial level of there are segments with copy number changes. But exactly how would you compute this HRD from the ground up? I thought I'll just take you through bottom up, starting from a cell level and all the way back to a tissue level. So so let's focus only on the top part of this picture right now. So each of these rectangles out here depicts one particular tissue, let us say. And let us say I have a tissue specimen out here where I have two normal cells and two tumor cells. And in red out here is one particular polymorphism. So I have a heterozygous loci. So that heterozygous loci, that SNP is present in the germline cells also. It is present in the tumor cells also. And so here you have, I'm assuming that's 50% tumor content. So this is one particular specimen where everything is normal. Then you have another specimen where the normal cells will always be the same, but here the tumor cells have suffered one copy loss. So you only have the copy of the DNA without that allele. So this is a loss of heterozygosity going on out here. Then I have a third specimen out here where I have an amplification of the wild type allele in the tumor cells. And the last one is, again, I have yet another specimen where I have a 2-copy gain of the wild type allele. So these are 4 different types of events that could possibly happen. So I'm treating them as 4 different specimens. So let us see what do these 4 different specimens result in when we try to see can we measure LOH or not at a molecular level. When we do sequencing or when you use a microarray, you're going to get DNA from all the cells that are there in that particular specimen. So in the first case out here, I'm going to get DNA from all of these things here, which essentially means that at this particular SNP loci, I'm going to get 1, 2, 3, 4, 5, 6, 7, 8 DNA molecules. 4 of them have the allele, 4 of them don't have the allele. So the allele frequency is 50%, so there's no loss of heterozygosity. Whereas in the second specimen where I do have a loss of heterozygosity, because in the tumor sample I do not have one of the alleles, this is the classic definition of LOH. In this case, I have only 6 molecules and 2 of them have the allele and the other 4 don't. So I have an allele frequency of 33%. So many of us are used to the concept of allele frequency from somatic testing, what fraction of the DNA have that variant. So it's exactly that same concept that's being applied, but it's being applied to germline polymorphisms. So by looking at this germline polymorphism and what is its allele frequency, you get a sense of is there a copy number change happening at this location? And is there an LOH happening at this location? But the picture is not always clear-cut. If you look only at the allele frequency, if you have a 1-copy loss, you will see an allele frequency of 33%. If you have a 2-copy gain, you will still see an allele frequency of 33%. So allele frequency alone cannot help you to determine whether there's LOH or not. You need to take the total DNA, total number of copies at this location, which is kind of a copy number change. A copy number change along with this allele frequency, those two put together can help an accurate determination of LOH, whether it's happening or not. So obviously what I've shown you here is a measurement at a single point, but the same thing is applied at a global scale. So the top left-hand picture out here is showing you how HRD is calculated at a global scale. Every one of these points out here is a germline SNP. And for each of those SNPs you're measuring, on the top chart is measuring what is the allele frequency, and the bottom chart is measuring out here. By the bottom, I mean there are two panels at the top. The top panel is measuring the allele frequency, and the panel below that is measuring the total copies that are there. And you can see there are different types of loci. At this particular region, which is highlighted in pale red, you can see there is a variation in the allele frequency and the total copies are less, because of which there is a chromosome loss that is happening out there. Whereas you have this other region on chromosome 14 probably, where you have multiple variations that are happening, the allele frequency, you have a noisy copy number calling thing, and because of that you have multiple segments that are happening. So using these two kinds of measurements, this plot was derived by checking at variations at 20,000 SNPs. The myriad test uses 50,000 SNPs. You can use anywhere from 20,000 to 70,000, any number of SNPs that you do. Ultimately, what you're going to get as a result of that is the picture that is shown in the bottom left-hand corner, where you're trying to measure for every part of the chromosome. Do I have equal amounts of copies of both of those chromosomes? Do I have unequal numbers? And you get a segmental breakup of the entire chromosome, whole genome. And quantifying, and all that HRD is doing is quantifying all of the segmental variations and saying, do I see a lot of segmental variations? Do I see a lot of LOH, LST, and TAI? Or do I see very few of it, is what HRD is actually calculating. So the picture on the left has a small number of variations. So you'd call it a low genomic instability sample. Whereas the picture on the right, you can see that there are a lot of segmental variations happening, and many of them are not entire chromosome or entire ploidy level changes. They're actually 10 MB to 15 MB region changes that are happening in multiple ways, and that would be a high genomic instability sample. Okay. So hopefully I've given you a perspective of, how do you start from a single SNP? How do you measure the allele frequency? But a single SNP is not going to give you the answer. You need hundreds and thousands of those SNPs. And using that entire set of SNP details, you can now figure out what is happening at the segment level in the genome. And then you compute all these segments. And then we just need to look at each segment and say, is the segment overlapping the telomere? Is it an LOH segment? Are there a lot of transitions happening? And that is how we measure HRD. So the pictures that I've shown you here are coming from measuring 20,000 SNPs distributed across the whole genome. But you could also do it with targeted sequencing and directly jump to whole genome sequencing. And quite a few academic groups and others, even commercial groups, are exploring this because you don't have to get probes, you don't have to enrich for the DNA, it's a shorter process. You just sequence the entire genome at a particular depth. So here, for instance, as part of a research activity, we sequence the genome at 7x. And when you sequence the entire genome, you don't have to be restricted to only 20,000 locations for analysis. We were analyzing 500,000 SNP locations across the entire genome. And when we do all of that analysis, every individual SNP will be noisy because you're only doing a 7x or a 10x sequencing. But because you have 500,000 measurements that you're making, with the appropriate statistics and bioinformatics, you can find out the signal. And if you stare closely at it, you'll see that the signal that is coming out here from low-pass whole genome sequencing is actually very similar to the targeted sequencing out here. You can see here on the P arm of chromosome 1, there's something happening. The Q arm is relatively flat. So the same signal can be recapitulated by a low-pass whole genome sequencing as well. So essentially, if the HRD, if a sample really has HRD, there are multiple ways of measuring it, and all of them will more or less agree, right? So this is not just something that we have done. Multiple other groups have done it in a systematic manner. There was a paper published by Luca et al., I think, 2 years ago, where they started off by doing 70x whole genome sequencing and checked to see can they call out LOH, LST, and NTAI and HRD. Oh, I really need to speed up. Okay. And then they downsampled it to different depths to see whether they could calculate all of those accurately or not. And as you would expect, LOH is the one that suffers the most. But if you still are interested in the final outcome of HRD and not on the individual measures, even at 10x, you get a very good correlation of whole genome sequencing on the HRD score. Now, until now, I talked about LOH, LST, and NTAI and adding them up to compute the HRD. But there are people who jump directly to HRD itself because that's ultimately what is being used for the final decision and not necessarily the individual parts. And for instance, the MOI company, they have something called the genomic scar score. They take every segment and they categorize it in 3 ways. What is the length of the event? What is the type of the event? What is the location of the event? So one segment could be large. It could be an LOH segment in a telomere. Another one could be medium. It could be a copy number change in a centromere. So they have these different ways of categorizing the segments and then coming up with a weighted score. And recently, a paper has been published by an Italian academic group, I think, where they ran the same 100 samples through both myriad my choice testing and through the MOIDX test, and they categorized the amount of agreement in it. So in their study, whatever was positive by myriad is also positive by the MOIDX test. But there are a small set of samples which MOIDX called positive, which are negative by myriad. There will always be some amount of these discrepancies. And now there is a whole variety of tests which have been published that are all talking about different ways of calculating HRD, HRD detect, sigma, scar HRD, shallow HRD, multiple others who are trying to use alternate ways of doing this. Right? So I'll just jump quickly into what we have seen so far. You start off with sequencing, and once you get the data, you need to check for the BRCA1, BRCA2 mutations. You also need to assess the genomic instability across those 20,000 loci. And from the variants, you'll know whether it's BRCA positive or negative. From the whole genome data, you'll get the genomic scar score, and you can assess instability, and then you can generate a report. And the logic is the same as my choice or anybody else. Whether you have BRCA positivity or you have high genomic instability, you'll say the HRD status is positive. Only if you do not have a BRCA mutation and you do not have high scarring, the report would be negative. And the report would look something like that. It would give you, if it's a mutation and GIS high sample, it will talk about the mutation. It will talk about, we do a lot of germline testing also. We have done more than 15,000 HBOC tests. So we have a database of all the mutations. So the implications of the BRCA mutations will be written. And we also provide the score and not just the status of positive or negative. And if it is mutation is negative, but the GIS is still high, we would write something else in the report. I won't go into those details. So coming to the summary stats of 478 samples that we had processed as of last week, I think. So this is showing you the score distribution. The BRCA positive samples are in red and the BRCA negative are in pale green. And there's a cutoff of around 50 here. And you can see that most of the BRCA positive samples do get a high score. There are some BRCA samples that get a low score. And if you were to make a pie chart out of it, yeah, there are 41% of the samples. Now, this is very, very preliminary data. I haven't looked into the tumor content and other attributes. I just calculated this yesterday for the purpose of this meeting. So please treat it as preliminary data. But you have around 41 to 45%, which would come negative. And then you have, if you're doing only BRCA testing, you would get this 21 plus this 5. 26% is what you'd get with somatic BRCA testing. By adding the GSS component, you get this additional 30%, which is 25 to 30% extra is what you get here. Right? So we will be working on the stats and try to publish a more rigorous one a little bit later. So I know it's close to lunchtime, but I'll just stop with this final picture. So most of the assays that are coming up now are DNA-based assays, and in the spirit of, a picture is worth 1,000 words. Ultimately, in the genome, this is a kind of segmental variation that happens to be present in a BRCA deficient sample. And most of these assays, which are DNA-based, are trying to convert this picture into a number and use a threshold for that particular number and see are samples higher than that number or not. So initially, people started off 10 years ago with just translating this picture into just an LOH score, which was called HRD first. Then people have tried to use the LSD score, NTAI score, then the combination of those scores. So I think this work will keep happening. People will find different ways of summarizing this picture into a number. And obviously, they'll always keep correlating with the myriad and foundation ways of assessing that score. But there will also be new scores that come. If you come up with a completely new score, then obviously it has a very high burden of having to go through a clinical trial before you can believe on its threshold. But if you show equivalence to existing methods of computing that score, and if there is a much cheaper way of doing it, hopefully HRD testing will become much more affordable in India. Okay. Thank you all for your attention. Which one? The data is commercial. We offer HRD testing in a laboratory for the last 1.5 years. It's commercial.
Thank you for the detailed presentation. I just have two questions here.
Sorry.
So you mentioned repeatedly in your presentation quite well that HRD is a scale. There is a scoring which is derived by myriad and foundation in prospective trials. Whatever analytical equivalence we might achieve in laboratory, do you think it is sufficient to justify without a prospective clinical validation to offer scoring? Because the EGFR, we are reporting 1% or 20%, clinician is still going to treat because there is no difference between liquid biopsy showing 1% versus 20% of MAP. But it is not exactly similar when it comes to a test which is based on scoring.
Yeah.
So I'm just kind of pointing out with how relevant or how accurate will a lab providing HRD score will be if there is no prospective. Because even in Ariel 2 part 1, they changed from 14 to 16 because they themselves felt that 14 was not really distinguishing well the cohorts of responders versus non-responders. And same happened with Myriad initially. From 36, I think they also migrated to 42.
Mm-hmm.
So how would you address that?
Yeah, this is a tough question because if you wanted, I think for any assay that is there, you can either show equivalence with an existing assay. So you can send the same sample for testing to Myriad and then publish what is the equivalence. And that is what this group from Italy had done, saying for one of these, for the MOIDX test, they've done roughly around 100 samples and they're showing the agreement. So if you look at it very closely, you would say that, maybe the disagreement is there in the intermediate scale of 50 to 70 is where most of the disagreement is. And then maybe you would say that I would trust it only if it, and beyond that, the equivalence is almost perfect in terms of what gets called out as positive and negative. So more of these results are needed where you can say that even if there is an 85% agreement, if I want 100% agreement, should I restrict to should I increase my own thresholds? So in this particular chart, for instance, if you were to say that anything above 80 on the MOIDX thing has a very low false positivity rate, maybe I will do that. So some judgment calls like that would need to be taken. And yeah. So. Yeah, so that's a
polymorphism, or are there higher frequency polymorphism?
Yeah.
And have you done that work for Indian population or the population that you are dealing to say that this will work equally effectively and the scores will be equal?
Yeah, that's a great question. So most of these assays, when they start off with the GNOMAD database, and you do not want to take any polymorphisms which are very high allele frequency because they'll always turn out to be, those things. So you do not also want to take very low frequency polymorphisms because they may turn out to be wild type most of the time and you don't want to waste your sequencing depth on it. So usually these assays go through 2 rounds where they take the GNOMAD database, they look into multiple populations and they choose representative polymorphisms which are between 0.3 to 0.7 allele frequency in the global population. And assuming that in reality, even if you choose 20,000 probes, most of the, even if 10,000 of them happen to be heterozygous in the target population, it works out fine. So usually they choose double or triple of that because they know that in any individual population, the subset of those polymorphisms that are heterozygous will be different.
But suppose they reside in a segment of interest?
Yeah, but here you're trying to compute an entire, each of these segments that are out here are fairly large segments, and the segments are usually around 10 MB, 20 MB, 15 MB and all. So you have multiple polymorphisms that fall in that, which gives you confidence in it. But if you're small regions of LOH, you cannot find out using this method.
So do we have enough data for Indian population to say that these are low frequency polymorphisms?
Yeah, I think across the entire numbers. So when we did the low pass sequencing, when we did 500,000 loci, we had roughly around 350,000 of them turning out to be heterozygous. So I think if you're looking very, very specifically at some polymorphisms, that you're always in danger that we do not have a database to start with. But if you're working with tens of thousands of these things, the numbers usually work out. Any other questions? Yeah, thank you.
Thank you for such an enlightening talk, sir. I request everyone to join us for lunch on ground floor. Let's meet again in half an hour. You can use the lifts, elevators. The lunch will be served in front of fine dining restaurant.
Ambani believed, a hospital is not a place where money and profit is important. Every single life saved or a patient cured would give me more satisfaction than mere financial gains.
Indians deserve the very best healthcare the world has to offer. And we have made it our mission to deliver it. Driven by purpose, not profit, we are determined to bridge the gaps in the healthcare fabric and extend the embrace of care across the communities. After all, no man is an island. It is our communities that nourish us and empower us. And this is the genesis of our institution. Going forward, we will strive to reach more people, touch and save more lives. This is our commitment, and we dedicate ourselves to fulfilling it.
Built on the 4 pillars: talent, technology, infrastructure, and care pathways, Kokilaben Hospital comprises of 10 lakh square feet of space and spread over 19 floors, built in conformity with the best of global standards. Talent. No effort has been spared to scout and bring on board the best medical professionals in various clinical specialties from across the globe. We are the only hospital in Mumbai to function with a full-time doctor system, which ensures doctors' availability around the clock. This system is in line with global best practice and is patient-centric. The system ensures transparency, accountability in the treatment, and the doctor has no compulsion or incentive for unnecessary procedures. And this helps in giving dedicated time to each patient. Cardiac Science. The Center for Cardiac Science provides an all-inclusive program for the management of heart disease from newborns to seniors, including prevention, diagnosis, treatment, and rehabilitation. It is supported by 4 cath labs, the largest number in the city of Mumbai. The center is supported by 2 advanced cardiac CAT scans that has made diagnosis a lot easier for the patient. The Center for Bone and Joint. This center is a hub for latest in technology, advanced technical skills, and medical expertise, with facilities focusing on every aspect of orthopedic care and rehabilitation. The department has super specialists for minimally invasive spine surgeries, joint replacements, arthroscopic surgeries, trauma, pediatric orthopedic surgeries, and orthopedics and musculoskeletal cancers. The center has dedicated operation theaters installed with computer-aided navigation systems for joint replacement and arthroscopic surgeries that provide accuracy and better long-term results. The center has the first of its kind spine surgery suite, which includes the latest O-arm with a specialized spine table and an advanced navigation system for accurate and safe spine surgeries with reduced risk of repeat surgeries and other complications like paralysis. Center for Children. Care of sick children has been one of the cornerstones in our planning and delivers complete services for robust child health. The center provides specialized and comprehensive support for children. It has dedicated pediatric ICUs and neonatal ICUs to provide special care to critically ill children and newborns.
Hello.
Our center additionally specializes in pediatric oncology, child psychiatry, pediatric neurology, rehabilitation, and learning disorders, with our specialist doctors available at all times under one roof. Children's Heart Center. Kokilaben Hospital's Children's Heart Center is the most comprehensive facility of its kind in Western India. We have the largest registry of complex surgical and interventional cardiology procedures performed at this center, with more than 100 procedures performed per month. Babies as young as a day old and weighing as little as 2.5 kilograms undergo complex cardiac surgeries here. Center for Mother and Child. Our maternity care center is located on a single floor, offering mother and child services, including fetal, neonatal, and pediatric services. An advanced fetal care center is specially designed for the evaluation of unborn babies with medical problems. Our experts perform minimal access surgeries and robotic surgeries to treat various gynecological disorders. Besides maternity care, the department also offers reproductive endocrinology, IVF treatment, and gynecological oncology services. The Center for Physical Medicine and Rehabilitation. India's largest and most comprehensive rehabilitation center encompasses remedial care for stroke patients, children with cerebral palsy, sports injuries, and chronic pain. The center is supported by dedicated inpatient beds, a first of its kind. A key feature at the center is its ability to manage disease related to aging and its work towards getting seniors back on their feet at the earliest, filling the gap with comprehensive services and latest technologies, like 2 locomats and 2 armios, which are robotic-driven orthosis and computer-enabled rehabilitation devices to improve lower and upper limb impairments, respectively, in patients with brain injuries, neurological disorders, or strokes. The center also has 2 hyperbaric oxygen chambers. Center for Sports Medicine. The Center for Sports Medicine focuses on treating patients be it professional athletes or any other patients with musculoskeletal problems with excellent rehabilitation facilities. Should a patient require surgical intervention, the expertise and experience of the Arthroscopy and Sports Orthopedics Department at the Center for Sports Medicine is unparalleled. Center for Minimal Access and Robotic Surgery offers minimally invasive surgery and robotic surgery. Breakthrough surgical technique using 2 Da Vinci surgical systems, including the latest XI system, which is an effective, minimally invasive alternative to both open and laparoscopic surgery. We have experts performing advanced robotic surgeries in conditions of urology and uro-oncology, gynecology and gynec-oncology, head and neck, gastroenterology, ENT, thoracic, pediatrics, and obesity surgery. Center for Cosmetology and Plastic Surgery.
Check.
Aesthetic
Hello,
clinic
mic check, test,
offers a
test.
complete range of medical and surgical aesthetic
Ketan.
solutions for hair, skin, heart, lung, and bone marrow transplant program with a multidisciplinary team of experts. The kidney and liver transplants are both cadaveric and living-related transplants. 2 operation theaters.
Good afternoon, everyone. Welcome back. Before the postprandial hyperglycemia sets in, let's start the next session. The topic for the talk is multiomics in precision oncology. I would like to invite the speaker, Dr. Anu, specialist in precision oncology and multiomics and head of clinical biochemistry in MVR CCRI Kerala. To chair this session, I would like to invite Dr. Arun Shahi, who's assistant professor and head of medical oncology, Patan Academy of Health Sciences, Kathmandu, Nepal. Dr. Vaibhav Chaudhary, consultant medical oncologist, Kokilaben Dhirubhai Ambani Hospital.
Good afternoon. Thank you, organizers, for having me here, especially Dr. Amrit. Yeah, as rightly said, before serotonin puts you all to sleep, let me rush through. So my topic is multiomics in precision oncology. The morning sessions, if any of you all raised eyebrows at the advances, this is going to make you roll your eyes back. So let me just start with a case, just to put the real world scenario in perspective. There's a 71-year-old female, negative family history, ex-smoker, presented with headache, blurred vision, and difficulty in speaking. The MRI brain showed a left frontotemporal mass, diagnosed as glioblastoma. Underwent total resection, followed by radiotherapy plus temozolomide, followed by adjuvant temozolomide. Now, this is what the NGS showed. FGFR3, TACC3 rearrangement, HRAS overexpression, with a couple of other variations. She was put on Bev and futibatinib, but then she relapsed after 2 months. Progressed. Now they put the case onto the MTB. The decision came out as let's add trametinib. Now, why do you think you all see patients, you put them on targeted therapy? Why do you think targeted therapy fails at times, or maybe is not as efficacious as you think it needs to be? Now, this is a stunning 3D image of a cancer cell. This is produced by Z stacking of images. You can see that obviously the one in the center is a nucleus, a lot of secretory Golgi apparatus here, and these filaments that you see are protein threads or protein filaments, which exactly are the ones that we are trying to target using those targeted therapy agents. Now, in the clinic, for an oncologist, it's always a reductionist approach. You want to look at one actionable mutation. The moment you get your NGS reports, you want to see what is targetable. Does this have a drug or not? But then the cell or the cancer cell never thinks in that way. It's always a holistic approach for the cell. It's a cohesion or coordinated network of signaling pathways and proteins that are in action, and never one mutation or one fusion. This exactly is what the signaling pathway in a cancer cell looks like. Now, the challenge is, how do you pick out one pathway or one mutation or one fusion or one indolent target it? And that is where multiomics, the application of multiomics, and the relevance of selecting the right patient comes into purview. Now, this is multiomics. It's the integration of multiple omic data sets such as genomics, transcriptomics, proteomics, and metabolomics to provide a more comprehensive understanding of the tumor biology to aid personalized treatments. So, fundamental or standard omic approaches are focused on genomics, transcriptomics, and proteomics. Everybody here knows that. But there are others as well, which are underutilized but still very much relevant. For example, metabolomics, Like if I say, for example, if you look at 2-hydroxyglutarate levels in an IDH mutant glioma, or pharmacogenomics, when you're looking at DPYD variations before you start 5-fluorouracil, or immunomics, before you start immunotherapy, why not analyze the tumor immune microenvironment, look at the immune signature? Doesn't that make more sense rather than looking at just one omic parameter? Now, combining all this in a real world, in an ideal world, you combine data from all these omic variables, integrate it using AI and your thinking process, then also add in the clinical data, and then decide on the targeted therapy or immunotherapy that you want to use. Now, how do we do this? As I said, we combine these parameters, we add in data from medical imaging and clinical information using machine learning. There's supervised as well as unsupervised learning. This part is not routinely done in the clinic as of today. And now the resultant are these clinical tasks that you get. The supervised or unsupervised learning is going to give a dimensionality reduction in sense that you input multiple, like millions of data points. They reduce it down to few so that you can analyze those few and then convert it to use as a signature for maybe screening, for diagnosis, for response assessment, or prognosis prediction. Now, my team, we put this hypothesis to test. We started with invasive breast cancer. And now our idea was to differentiate or see if there was a multi-omic differentiation between IDC and ILC. I know the ILC numbers are low, so we took 409 cases of IDC and 134 cases of ILC. We ran it through multi-omic analysis. Here you can see at the transcript, so we usually run the RNA-seq analysis first. This is the heat map. Those who can read the heat map would automatically understand that there is a significant separation between these two tumor types as well as matched normal tissue. Looking at the KEGG pathways, we see different pathways that are active in both these cohorts. We could also predict certain potential oncogenes and tumor suppressor genes, which worked independently in IDC and ILC. The methylome, the 0.87 is the Pearson correlation coefficient, which indicates that methylome or the epigenome had the upper hand in differentiating both these histological subtypes. We could also find the proteomic analysis found out that CDH1 as well as the miRNA 218.1, these two were fundamentally like a signature in IBC. So this is trying to differentiate. Now in the clinic, this is treated as IBC. You don't have separate targeted therapy for IDC or ILC, but we're trying to show that both are again different. Now further, we went down to stratify colorectal cancer. In the morning, we heard Dr. Govind Babu talk about the differentiation of left and right colorectal cancers. We went a few steps further ahead to look at it at a multi-omic level. We took in 852 cases of the left side and 170 cases of the right. Most of them were stage 2, so early. And this is what we found. At all omic levels, be it the transcriptome, be it the genome, the mutations, be it the methylome, the methylation levels, or the interactome, how these parameters interact with each other. We found there was significant difference between the left and the right. I know the one point that we missed doing was subtype like separating rectum from ascending colon or cecum, which we were underpowered for the study. But this itself was enough for to prove our hypothesis. Like, please don't segregate all of colorectal cancers under one umbrella when you run an RCT or when you look at it at the clinic. We were also able to find out a signature for early colorectal cancer, which comprised of RNF217AS1, which is a ubiquitin ligase, another miRNA 10B, which is actually a predictor of chemoresistance, and a couple of other 8 novel genes. This work was done with the MSKC data set. Now, actually, we took this work to AACR last year, and we had the data that we used were of Memorial Sloan. So they actually came to see our presentation. They were quite happy that we could pull this out from a data set. So this is to help improve precision onco, at least a perspective, to aid in that perspective so that tomorrow you don't think of CRC as a single entity. Not just CRC, I just showed you breast. We're moving on to actually peritoneal metastasis now. That's our next research that is happening. So use these to stratify. Now, this paper is just published. It is in print. That was for the cancer part. We tried taking it one step ahead. We're using multiomic analysis in association with scientists of NASA and European Space Agency. What we're trying to do is doing a multiomic analysis on rodent tissue that has come back from space flight, and then trying to pick out cancer-specific genes and trying to look at them in a perspective of screening so that, astronauts are at a high risk of radiation-induced cancer. So we're trying to put a signature in so that you can prevent or at least try and think about it. This is very new concept in space biology. So that is happening. This is the interim analysis that we have. You can see that post-space flight, you already have pathways of breast cancer, NOD signaling, neovascularization, circadian clock dysregulation, and tryptophan degradation. Each of them are specific and quite popular in the onco scenario as well. So we are already seeing similarities. So this is the one extent of application of multiomics. This was what ASCO said last year, the application of AI to analyze large volume multiomics data combined with clinically annotated data sets has led to the identification of drug susceptibility genes, variant detection, new cancer biology insights, and prediction of RNA splice sites. This is just the beginning. We can do much more, in fact. Now, all this looks very fancy when I present, but doesn't go without complexities and challenges. As already mentioned by previous speakers, tumor heterogeneity, the spatial and temporal heterogeneity is a challenge. So looking at a cross-sectional or one-time sample, it's quite difficult. So this needs to be like a continuous process. You need to sequence and look at the analysis at different time points in the same patient. Now again, the tissue that you're sending in is the true representation of the tumor. That's where probably the liquid biopsy would come into effect. Again, are you looking at the right clone? Is that what you get in your result? Again, intra-patient, intermetastatic heterogeneity. We forget about the TME or the tumor microenvironment many a time. The metabolome, which is actually the metabolic molecules are the ones that are the workforce, not the mutations or the fusions. That is this concept of next generation immunotherapy is coming in, combining metabolomic inhibitors with Pembro or IPI. Again, non-canonical variants, which are actually under addressed. We always talk about canonical variants. We do see patients do harbor non-canonical variants, but we don't look at them. Even if we look at them, there's hardly any data to understand or analyze. So what do we do with those? Again, challenges of validation. So we run these multi-omic analysis in a data set. Now we've run it in the US data set. Is it going to work in the Indian population? Unless we have a database at hand, unless we have our own data to run such complicated analysis, we can never be very sure. It can differ from one ethnic population to another. And you already know the challenge of monoomic representation that you see in the clinics. For example, you look at, there might be a BRCA pathogenic mutation. You're not looking at the promoter level. Might be methylated, might be switched off. So these are things that you keep in mind before you choose a targeted therapy, therapeutic agent or IO for that matter. However, these are the advantages. One is improved accuracy of diagnosis, so that you can identify molecular markers that are specific to the cancer subtypes, just as I showed in the previous slides. That is what we are trying to do. Predicting treatment response, identifying those mutations which affect metabolism or resistance, identifying new drug targets by revealing newer and specific molecular pathways. So there'll be a lot of pathways in a particular cancer or just in one patient sitting in front of you in the clinic. But you need to know which is the dominant pathway, not the driver or the passenger mutation. It's not what I'm talking about. It's what pathway is active, or what pathway is driving the cancer. What is the protein that is active there? Or for that matter, what is the metabolomic parameter that is high there, which is driving the growth and metastasis? Of course, better understanding of cancer biology. We are yet to see the full picture. We just know half, or maybe we are just half there. And obviously, this is going to help with personalized medicine by identifying the exact molecular features in a patient's cancer so that clinicians can actually choose the right. The failure or the efficacy, I don't think is related to the failure of the drug or the molecule that you're using. The most important thing is selecting the right patient. So if you don't select the right patient, I have seen where VAFs such as 5, 10 are targeted just because it looks very nice on the report. It's there in the front page, pathogenic mutation. So that is not the way that we need to go about it. You have to think of the pathways, think of what is actually active in the cancer. Now, overall, this multiomics is going to help you. This is not all AI. So the AI or the machine learning part is only to help us bring down the dimension or the numbers, because it's humanly not possible to analyze 1 million data points. So, and data points are going to come up more and more. You've just like how approvals are coming up for drugs. So it's going to be like exponential. And tomorrow in the clinic, it is going to be challenging to sit and analyze one by one. So definitely you need machine learning or the help of artificial intelligence. But again, at the end of the day, what report or the result the machine gives you, you need to think and make a sensible decision out of it. That is what is most important. So multiomics is going to help that way. Thank you. These are my collaborators and mentors. Thank you so much. Oh, oh, it is such a pleasure speaking in front of him. He has taught me one session in Harvard in 2019.
So I have a question between research and clinical practice, right? From a research standpoint, there are, of course, infinite different omic opportunities. In clinical practice, certainly DNA is widespread, RNA is used a lot, it has some failure issues. What is the next of the omics you described that you think is going to make it into routine clinical practice, right? Which of these bubbles to the top as being the most important, would you say, for the future of cancer care?
It should be the proteomics or the metabolomics, because there's a Taiwan group actually, I don't know if somebody else is doing it, using mass spec analysis to look at EGFR, like post-treatment. So that is more of a definitive answer. Rather than looking at a mutation, you yourself know when you deal with your lung patients, some works with osimertinib, some doesn't work, even if you think it would work. So there, what is happening is that the protein, which you think the mutation has caused it to not function, is actually functional. So, or even vice versa. You may think the protein is non-functional. For example, if it's a heterozygous state of BRCA1, as we saw one case in the morning, Dr. Shonanags, it's heterozygous. That means there's one copy still working. The protein is not at the zero level, or the enzyme is not at zero levels. Most of these are enzymes. And enzymes, you don't need 100% in the body for the pathway to work. Even 25% could work. So protein is actually the answer, irrespective of whatever happens upstream. And also in some cases, methylation, I would say. But if you look at the end, if the gene expression is switched off, if you're not looking at it, you wouldn't know. Yeah, thank you for that question.
Regarding metabolomics of tumor metabolomics as a maybe prognostic marker or a predictive marker, are you aware of certain studies which are being conducted, or maybe you are involved in one of those, to define what are bad varieties of tumor, like for example a triple negative breast cancer, where even after giving complete chemotherapy we should be vigilant about, because we, as of now, ctDNA obviously it is coming up in a big way, but are there any metabolic markers, are there any proteomics which also can actually help us to increase or just keep a tighter watch on the patient? Because once the disease comes back, once it is radiological progression, then it is stage 4 ultimately. It's virtually incurable. Some patients might require longer treatment. Some patients might be chemorefractory. So there actually, that's a big scope for this. But I just wanted to know what is going on right now in India in this field, because ultimately, honestly speaking, I'm not aware much about the metabolomics.
Well, thank you for that comment. Actually, it is right in a way that, for example, 2-hydroxyglutarate, as I was mentioning in IDH mutant glioma, it's a more reliable marker than the mutation or the state of any other variant in the gene, because that is the end product. A gene is something which has a protein product. Those are the ones that we look at. So if you can look at simple example, CA99 or a CEA, it's an easier biomarker. That is also a protein. It's just the nature of protein differs, and it's very difficult to quantify enzymes in the lab. That's why, but with a mass spec analysis, it's easier to quantify. So yes, these things are going on. In breast in particular, I'm not sure of.
Spectrometry, actually in 2012, I came across one paper from Angelo Di Leo's group in Germany. They were actually taking on this bad prognostic variety of triple negative breast cancer, and they had developed metabolomic markers for early reps, early phase study. So is something like that happening in India? Mass spectrometry obviously are available with us. You might be having.
I, for one, am doing a project in Belgium. We are trying to look at, to differentiate intra-patient heterogeneity, actually. We're looking at primary versus metastatic and trying to pick out markers, metabolomic and protein markers using mass spec. Because I now know that there is no point in looking at the genome level alone.
Thank you for very enlightening presentation. So I want to ask, like, when is the right time to look for these metabolic markers? Whether like before starting the treatment, or as soon as there is resistance to treatment or relapse after treatment?
Theoretically, it should be upfront before you start a therapy, because again, the heterogeneity, the temporal heterogeneity will come into play if you add in the pressure of a chemotherapeutic agent. And again, not just upfront and leave it there, you'll have to do serial assays. And that will help with your follow-up prognosis as well.
Thank you.
Thank you.
Thank you, ma'am. It was a very insightful lecture. The next talk is about artificial intelligence in precision oncology. I would like to invite the speaker, Dr. Istvan Peter from Hungary, PhD from Semmelweis University, founder and CEO of Oncopass Medicine, founder and CEO Genomate Health USA. To chair this talk, I would like to invite Dr. Dinesh Pendharkar, Director of Oncology, Sarvodaya Hospital, Chairman, National Cancer Society, past President, ISO, ISMPO, past Chair, Internal Affairs, Common American Society of Clinical Oncology, Fellow American Society of Clinical Oncology. and Dr. Hemant Malhotra, past President, ISMPO, President, Immuno-Oncology Society of India, Member, Scientific Advisory Board, International CML Foundation, Director, Oncology Services, Shri Ram Cancer and Super Speciality Center, and Professor and Head of Department of Medical Oncology, Mahatma Gandhi Medical College and Hospital.
Good afternoon. So we have just introduced Dr. Iswan Petek. I would just like to inform you that he is in this field of AI in precision oncology for nearly now 25 years. So what he's working on is he's working on many years. And I'm really happy to say that we got two people from Boston today. So he is also based with his company called Foundation, also from Boston. So probably we are very lucky today to have these two esteemed speakers on precision oncology. Eastman, please go.
Thank you very much, dear Chairman and dear Professor Pentharkar. Thank you very much for inviting me. It's a pleasure and it's very exciting. Yes, we have met Professor Pentharkar for several years now, and he has been following our work in the past 8 years when we have been working on this new technology I'm going to present to you. Actually, I'm also a physician by training, and I started in pediatric oncology, and I had to treat with children with ALL, and most of them actually responded very well to chemotherapy back then, 28 years ago. It was in 1995. That was before the precision oncology era. We didn't have really any targeted therapies, but already at that time, we could detect the genetic underlying of many cancers. For example, we could see that 5% of ALL patients harbor the BCR-ABL translocation, the Philadelphia chromosome. But that was only a bad prognostic marker. So we knew that they failed to respond to chemotherapy. And it was extremely painful that we knew that the patient would fail, but we had to give the same chemotherapy anyway. So I just took samples from this patient, took it to the molecular pathology lab, and tried to figure out how to really target the real cause of cancer. Because that's our dream, to really understand why the cells started to grow and really choose a therapy according to the mechanism of the disease and not just based on the symptom, which is the tumor growth, which is the result of an event. So just for the game of our minds after lunch, I would like to ask you the question, or just ask you to imagine a situation when you are in an emergency room and as a patient is presented to you and he complains for headache, terrible headache. And you go closer and you see that there is a nail in his head. So what would you do? What would you think? I mean, has anybody of you ever seen a patient with a nail in the head? Probably not. I hope so. But it can happen. And I think all of us have an idea what is the link between the nail and the pain. It's called reasoning, it's called inference, it's deduction. So we humans have the capacity to use models in our brain. This is what the child actually learns about the world, the model. And then we use this model to predict events and understand connections. So we understand causation. And that's the one way to think. The other way to think is to look for correlation, statistical correlation. So if events occur in the same time at a higher frequency, that's the correlation. This is the two types of methods we use in our thinking. So if we talk about precision oncology, our dream is to really understand the cause and then match a therapy. This is what we talk about. So, but this is not what we usually have been doing. In oncology, we have been using correlation-based evidence on clinical trials. So how we are going to match this to provide precision oncology and still providing evidence-based medicine? That's the challenge. So we are excited about AI, and we are all aware that it's revolutionizing medicine also, not just in our general life, but also oncology. So starting from the diagnostics, I mean, FDA just approved a software which can be used by gastroenterologists to detect colorectal cancer at a higher rate, just based on the image analysis. It's just amazing. And so then, of course, there's a race to develop different AI methods for radiology to detect tumors on images better. And also now digital pathology is here. And AI is helping pathologists to recognize the cancer cells and characterize them better. So we already have companies who can predict the presence of mutations just based on the image analysis. And also now we are using AI in drug discovery. But the big question is, can we really use AI in precision oncology where we want to choose the right drug for an individual person, which is an individual? So it's not based on large groups. So how can we apply AI when actually we don't have a pattern to recognize? So, but why do we need AI in precision oncology? So this was my first big breakthrough in my life, and I really saw the power of precision oncology. This is my story in 2003, actually, when gefitinib was tried in the INTACT trial, and it just failed in unselected lung cancer patient. In the very year, in 2003, we had a lung cancer patient, non-smoker, 60 years old lady, who we examined, and we found that the tumor harbored in amplification and mutation in the EGFR gene. But that time, there was no publication which linked the mutation and amplification to the response to gefitinib. So we just used reasoning, like we saw this as a nail, because we thought that this is a growth factor receptor. And now this growth factor receptor is amplified, and there is a mutation, an activating mutation in the tyrosine kinase domain. We want to inhibit this. We want to pull this out. Even if the drug failed in a phase 3 trial, of course, in unselected patients, we organized a one-patient clinical trial and actually got the permission to treat this patient. And of course, that was a wow effect. You can imagine how dramatic the response was. And this patient had a complete response, even with brain mets, and she lived for over 5 years, and she died of unrelated disease after a heavy dinner caused pancreatitis. So that was really the success of the amazing success. So the question is here, do we think about EGFR mutation as a biomarker, or is the cause of this tumor? So that's the big question. So of course, later we had to wait 5 painful years to actually have the iPass that Geoffrey already showed, that actually now we generated evidence-based evidence, statistical evidence that EGFR mutants better respond to the, so it's a good idea to pull the nail out. So that's it turned out that now we have statistical evidence so far. So I thought that in 2010 that, oh, it's fine, we can just combine evidence-based medicine and precision oncology, and we will just develop drugs in combination with companion diagnostic tests, and we will co-register them. So we will have a test and a drug pairs for all. So that was the vision when we wrote this review in 2010. So when in 2022, I looked at the website of the FDA, and I saw this, I counted 28 registered approved companion diagnostic tests. I was not really satisfied. I mean, this is progress. But after 20 years of the human genome, that after 20 years of this first patient, I wanted to see something more. And I started to thinking, why is this? And of course, in the previous presentation, we already started to hear the reason, is that the cancer genomics is just much more complex than we thought. And So these are the magic numbers up there. So there are, according to Cosmic Database, the census of cancer genes, now we know about 733 driver genes. Now the good news is that it's countable. And we are getting to the end. So we are discovering less and less more because the human genome is huge, but it's limited. So it's 2 meters long. There's a beginning and an end. So we will get to the end eventually. So there is the only bad news about the 700, it is more than 100. So if it's more than 100, the average frequency is less than 1%. So now imagine this when we translate this to clinical research or evidence-based medicine. That's staggering. And also each gene can harbor thousands of different types of mutations, and it matters which mutation they have. So you have millions of mutations, and on top of it, each cancer harbors a combination of these mutations, like on average, one we know 4 and 5. The good news is it's really more than 10, according to Bert Forgerstein, the great scientist. So there is a limited number of mutations, which makes sense, but at least this is a combination of 4 or 5. So how are we going to tackle this? So actually, I made this calculation, how much time we need, and you see the next magic number, the 14.4 million years. So this is the number of years we will need to conduct all the clinical trials to get the answer, which is the best drug for each combination of mutations. So we really have to think out of the box, and we need to solve this differently. So this is the situation today. We already, in the previous section, we discussed cases like this. So for example, just one example, this is a 40-year-old female. It was originally thought to be a triple-negative breast cancer, but then an NGS was performed, and it revealed that the patient was carrying a BRCA alteration, but also a tyrosine kinase mutation in the HER2 gene. So it's basically HER2 positive on a genomic level, but also is a BRCA positive. Now, okay, so we can match treatment options to each of these genetic alterations, and we have multiple PARP inhibitors, we have multiple HER2 inhibitors now, and of course we have to think about which PARP inhibitor we want to choose based on the specific BRCA mutation, but it can matter. And also we have to think about, okay, what do we know about this exact mutation of G77.6V in the HER2? Is it sensitive to trastuzumab? Is it sensitive to naratinib or not? Or we should use the trastuzumab? And what about patients who also have MYC amplification and ROT2? And what about if we have already clinical trials of drugs against the MYC and ROT? So to really know what is the best therapy for this patient, we have to run a randomized trial of patients who harbor this exact HER2 mutation and the BRCA mutation, and probably maybe the MYC and the ROT21, and randomize them to different therapies, and then we will know. So you can think about that will be in 1 million years, for maybe not 14. So this is the question. So the other possibility is the molecular tumor boards. That's great. So this is what we can do is we just think about it together. So the only problem with this is that if we send the same profile to 2 different molecular tumor boards and we ask their opinion, guess what is the concordance between their opinions? Actually, there have been studies who have published this, and the concordance is around 50%. So they agree or they do not agree. There's a 50% chance. So in some studies, it's actually even lower. Actually, it's staggering that even in the case of level 1 alterations, the concordance is around 60%. So it's not just in other cases. So to solve this, we started to develop this system we call computational reasoning or causal AI system. Is a knowledge representation system. So you see a knowledge graph here where there is a causation between each gene and target and potential compound in a network of 34,000 connections driven by algorithms. We trained this on 10,000 cases, but this is not machine learning. We just we did what the child is doing, trying 10,000 times what is the best model. And this is what we came up with this model. We published in 2021. And we integrated into a software system. Now it's ready to be used. So you can use it with any NGS data. So you already have a list of variants based on any comprehensive molecular profiling or any test. It can be even a foundation medicine or other advanced profiling assay as an input. And then you can use this system to actually rank treatment options for the patient. Actually, it's a CE marked in Europe. And so what is important to keep in mind that in our first step of interpreting a molecular profile, we first list the genetic alterations, like let's see 5, and then we in current software system, in current reports, what you see the corresponding therapy which corresponds to each of these genetic alterations, and the evidence behind is evidence how that drug worked in patients who share the same mutation. But the problem is that this patient can be put in these 5 different populations. So what should we do with this patient who is in the cross-section of these 5 populations? So this is why, as a next step, we have to combine all what we know and make a reasoning, a deduction, to actually come up with a logical order of treatment options for this patient. So that's really the next level, and then we can really make an objective decision on, for example, also for this patient with these multiple alterations. Just for fun fact, if we change the exact mutation in the HER2 or the BRCA, the order changes, whether the PARP inhibitor is the first or is the HER2 inhibitor first. So the exact mutations will change the actual order of the list. So what is very exciting is that now this type of method we developed is getting closer to the clinic. Just this January, the American Medical Association just announced that there is a new code announced. It's called Pharmaco-Oncologic Algorithmic Treatment Planning. So I practice a lot to say it fast. But the whole idea is that to use validated algorithms to make this type of decisions and rankings. And now it's a great news that oncologists will have a new tool. They can report to payers as a new activity using tools like this to make the final decision. I want to emphasize that this code starts after the first molecular pathology report is issued. So it's after the post-analysis of an already created report. So the next step is not, so that's really important. And I want to really thank to Razel Kusrok. She was also on the previous slide, and she was really instrumental working on this code, and thank her from this place as well. And so of course, the big question is, does it work? I mean, how we can prove that such algorithm actually does work? So if we rely on this ranking, whether we make a better decision or not, and the first trial we went back is the SHIVO-1, because that was the first randomized clinical trial in precision oncology in Institute Curie, led by Christophe Tourneau. He's an excellent guy and pioneer of precision oncology. And in this trial, they chose 11 drugs, and they set up a list of mutations they were looking for as an inclusion criteria. And then if the patient harbored that mutation, they either matched with the corresponding therapy, or the patient received the chemotherapy as another arm. So that was a randomized trial. And so what happened was that although they did achieve responses in this precision oncology approach, but it was not superior than chemotherapy. That was the disappointment. So that's why it was so exciting to go back and see if now this computational model, this AI, can really help us identify a group of patients who do benefit from targeted therapy more than from chemotherapy. So that was very important, and we actually achieved that. So 30% of these patients actually in this trial could be selected who really benefited from precision oncology. Precision oncology, I mean today, is matching the therapy just based on our understanding the presence of the mutation without any prior clinical trial results. So that's the issue. So that's what's exciting. So in this trial, all patients received the matching therapy, and now we could show that with this new methodology, we can improve the treatment prediction beyond matching the therapies on a single gene level. How does it work in a clinical practice? It's I just really love this case report. This was a 50-year-old lady with a neuroendocrine tumor in the pancreas. And when she presented to the doctor, she already had a lot of metastasis in the liver. So the liver function was very bad. So the oncologist called me that we have to make a very quick decision, and it's a life or death decision, because the first line will decide the fate. So in this situation, she said that I can give chemotherapy, but the liver function is so bad, I'm afraid to give. But there are two approved targeted therapies, everolimus and sunitinib. So which one? Chemotherapy, everolimus, sunitinib. And so we did a liquid biopsy assay, actually, and we came up with this multiple genetic alteration from the blood, from the liquid biopsy. We ran the algorithm, and we came up with the suggestion of everolimus. And it was so exciting to call the oncologist everolimus. It's like in the films when you want to this mental bomb, and you call in the action that now it's everolimus. And it did work, and she actually improved very rapidly. So this was excellent. So here you see a situation when there is no approved biomarker for sunitinib or everolimus. They are all approved based on their own efficacy data. So now, how can we use the NGS data, which can be available easily for the first decision? So of course you can say, let's wait until FDA approves a biomarker for everolimus in neuroendocrine pancreatic tumor and also for sunitinib, and then, okay, it will never happen. So we have to make a decision. Do we want to use the molecular information? Do we want to think about these nails we see, or we just ignore them? Do we want to make a better decision? Do we really want to practice precision oncology? Do we want to use the molecular information or not? And that's, I think, the only way to go ahead is to develop approved algorithms to make these decisions, or the other solution is to wait 40 million years. So, but even if you just look at these very common and main targets like ALK or EGFR, based on the presence of co-occurring other mutations or the exact type of mutation, we have shown that we can improve decisions between approved therapies. So you have like 5 different types of EGFR inhibitors. Now, based on evidence-based medicine, we use osimertinib because that's the best on a statistical level for most patients. But for example, here we show a case report where it was afatinib was the best choice based on the exact mutation. So we are abandoning previous therapies because there is a new one which more frequently work, but these not overlapping groups. So there might be patients who benefit more from the other drug with the previous drug. And so we also monitor in real world how the system works, and to see how we constantly ensure a quality in the daily care of oncology patients with oncologists who already use this system. And we are excited about the traction we generate both in Europe and in the US from organizations. And I think we want to use this tool to make precision oncology available for everyone. So our ambitious goal is to make it available for 1 million patients in 5 years. So that's the beauty of AI and computational technologies, the scalability that is really can be implemented in the daily practice of many, many oncologists all around the world. And the latest news is that we are proud to be also part of the Cancer X initiative, where we really want to work together with public and private sector to really lower the tumor burden, but also lower the financial toxicity and increase equity and equality in oncology all around the world and also in the US. And I hope that finally AI arrived, and this is our new tool, our new friend, so please welcome. And I hope that we can also work together on also to help cancer patients in India. So with that, thank you very much for your kind attention.
Thank you very much, Dr. Eastman. So I just wanted to stress one point here for all of you. Dr. Eastman showed us that this procedure has got a CPT code in America. So what a CPT code means, few of you may know, few of you do not know. So when a cancer patient comes to you, you bill the patient for a visit of a doctor, you bill the visit for chemotherapy services. So this is, and you bill for the investigations you do. So in America, if you have to do the billing, you need a code. If the code, like you do Ayushman Bharat, there is a code. If there is no code, you cannot bill anything. You cannot bill the patient. So this AI software in precision oncology has been given a CPT code. So now any American doctor, so if you get a foundation report in your hand and you still want a second opinion, either you can use that test and start treatment, or maybe you would like to use and get a second opinion on that. So you can use an AI. So you already have done foundation. You have paid for the foundation. The report is there with you. Then you go to this code. You can still use this code, bill the patient. The insurance company will pay for that. And you can come to the next level of decision, how to use precision medicine drugs. So this is really, I think, AI has been put on a very high level. And this is what probably we should be also be aiming for. Thank you very much, Iswan, for bringing up this information.
Yeah, really great talk. The talk is now open for questions and comments. Yes, please
Hi.
go ahead.
I
Go
have
ahead.
one question here. So you mentioned that the process starts with already having the list of mutations in a patient sample, and then based on that, it will recommend which therapy is likely to work better. So because there are so many different tests available to do the mutation profiling, will it also recommend which test to do, what subset of genes need to be profiled, or how large the profiling has to be before you come into this assessment?
Yeah, so the system is growing every month, of course, or every week. So we actually rank the genetic alteration, 5,000 genetic alterations already. So you would think about we need whole genome, but no, actually the alterations in 400 genes actually alter the ranking. So I can provide you with the list of these 400 genes, which it's great if it's available. Of course, you can use the system with a smaller panel. For example, in the Shivo trial, patients were only profiled for 50 genes. But if you do a 50 gene panel, the average number of drivers were 3. So even if you just test 50 genes, most patients will have 3 different genetic alterations. So then the system can be useful to take into account the biological effect of the co-occurring other mutations, how it changes your decision, which targeted therapy you choose or not. So I would say that we try to make this agnostic. And also what is also very important, you can use it in combination of 2 different tests, because that's a big headache also for the oncologist without a nail even, that you get a report like a PD-L1 immunotherapy and it's 50%. Hey, it's great. Now I know based on that, I can use immune checkpoint. But then the NGS comes in STK11 mutant, and it's so okay. And maybe there is a CMAT skipping mutation. So should I start with CMAT, or should I think about this STK1, or should I consider the PDL positivity? So so what you can do with this system, you upload all the free tests, and then it will just combine and make a final ranking based on average 1,000 published evidence. So the system is based on evidence. It's just combining those evidences to make a list of recommended therapies. Thank you.
Can I ask you a question from here?
Yeah, sure.
So are you incorporating some clinical features into the AI system also? Say, for example, the way the patient presents, what kind of imaging parameters the patient has, plus the molecular analysis, or is it only genome analysis based?
Very good question. Thank you very much. So it is only genome based. So you have to see the limitations. So we have to set the limitations to AI. So we want to give them specific narrow task, which needs a lot of computation and repetition, and use them for that. But that's why it's very important to emphasize that the clinician has to take into account all the clinical situation to make the final decision, because the system does not include any knowledge about the side effects, availability, patient preference, and stage, previous therapies. So sorry, sorry, oncologists, you still need to work a lot. It's just, we just concentrate on a task which is not visible, is the level of the molecular level, and we try to make a reduction. So it's, I give this example, which is easier to drive a car or a fighter jet. Of course, the fighter jet, because there's a lot of AI system which help you. So it's just, so if you want to really be the driver of a fighter jets in oncology, we will need a lot of AI tools. So this is how we will go to the next level. Oh, sorry, that was a...
So I have another question. So
yeah, sorry, that was also...
You'll get your chance.
Yeah.
So the pudding is ready or almost ready. And as Dinesh is saying that the US FDA is paying for it also. So do we have proof of the pudding also, like X number of patients used this algorithm, and out of the X, 50% benefited or showed a response? Do we have proof of the pudding also?
Yeah, so so it's still, first of all, it's a clinical decision support system. So it's according to FDA, this is exempt. So that's why it's only for oncologists support, not a standalone product. It's a service. But it's an exciting question. In the EU, you have to report it and register it as a device, and it has been done. And for the second question is, so we're constantly working on providing more and more evidence for the pudding. And the first one was that I showed actually that was a prospective trial on existing data. That's the beauty of AI-based tools. So you can simulate a prospective trial. If you don't use the data to train the system, only to test the train system, you can use databases, which high-quality databases. But also we monitor the real-world performance, and I showed one slide on that we are collecting data, of course, from the outcome of patients who have been treated according to the recommendation of the system. Please.
Yes, please, go ahead.
Thank you.
Hi, great presentation. You know, clearly AI is expanding throughout many facets of human life, but in medicine per se, so I saw your algorithm. I'm sure it's much more complex than you can present on a slide. But the question was, how do you account for two things? Number one, the tissue context of that genomic mutation, and also discrepant evidence, right? So we know that most of our published evidence is very much, there is a publication bias towards positive outcomes, right? So, you'll see every patient with an mTOR inhibitor who's ever responded to everolimus in a journal somewhere, but all the patients that never responded to that mTOR inhibitor will never show up on that line. So how do you account for those two things? Because when we choose between sunitinib and everolimus, which are both approved therapies, and it's great that the case report, the patient worked, but the absence of the fact that we don't know what would have happened to that patient on sunitinib is still an evidence that we need to create.
Absolutely agree on all your comments. First of all, the problem of conflicting evidence. This is one of the drivers why we developed this system. That was one of the motives, because I saw that there are so many conflicting evidence, and now what is happening is in current databases we use to interpret reports, there is a group of well-trained individuals curate the data, and they make the call. Those humans make a call which publication they believe in. And then all our ranking is based on a subjective selection of one publication we think the best or the more reliable or the highest, because it was a randomized trial, so that's a stronger evidence. But that was a randomized trial. First we saw 20 years ago, which showed that gefitinib is ineffective. So, okay, so how to combine a randomized trial like that and a case report, another case report, how we will give weight to each and how we combine. So that's a big question. And in this system, we do not do any bias. We introduce both the supporting and the contradicting evidence and let the algorithm decide which one it gives more weight and makes a final conclusion, because it has to be standardized. And the algorithm tries to favor publications or evidences which are more relevant to this patient based on the level of matching of the clinical and molecular parameters of subjects tested in that trial and your patient. And so therefore there is a mathematical algorithm which tries to eliminate the errors in publications and make a better decision. But that's a very important problem, and this is what we are trying to solve, one of them. So, and the other question is, of course, that's why for everolimus. That's why the oncologist said, I don't want to use everolimus because I have a very bad experience. It never worked for me. So it was very difficult to convince her to choose everolimus, just because the AI said. But so the question, you answer your question, this is a case report. It just shows the utility. It's just an example of the utility. It's not example of proof. The example has to be a proof on higher numbers. Absolutely. So that's why we work on clinical trial data, and we also be present on ASCO, and we continue to present more and more evidences as we go ahead. So.
Thank you very much, Dr. Esteban. Thank you very much. Please join us
Thank you.
Giving him a big round of applause. And all of the questions will be off dais to Dr. Esteban. And on behalf of my co-chair and myself, thank you very much for the organizers for this opportunity. Thank you.
Thank you, sir, for giving us a futuristic perspective. The next talk is about the role of hereditary germline testing in personalized medicine. I would like to invite the speaker, Dr. Amrit Kaler, Consultant Molecular Pathology, Kokilaben Dhirubhai Ambani Hospital. To chair this session, I would like to invite Dr. Rekha Pai Vellore, Professor Molecular Pathology Lab, Christian Medical College and Hospital, Dr. T.B. Yuraja, Head Robotic Surgery, Consultant Uro-Oncology, Kokilaben Dhirubhai Ambani Hospital.
I think I would like to welcome Dr. Rekha Pai once again for coming here and taking out time for our session. Thank you, Dr. Yuvraja, for chairing the session. And without losing much time, I think we will go to the role of germline testing in clinical oncology practice. We have actually established a 113 gene panel in-house, and we are in an active consideration towards screening even the normal individuals other than the cancer patients. So we provide them genetic counseling, we run the test in-house, and then we do a proper consultation with all the surveillance and the risk-reducing treatments if available, and also the targeted treatments if they are available for the cancer patients. So with that, I think I will start with my talk, and I will take you through a series of steps in which I'll be talking about what are germline cancers, why the screening is important, what are the patterns that you see in the clinical scenario to think that it's a hereditary cancer, and what should we go for? Either should we go for single gene or a multi-gene? What should be your criteria? And I'll classify them based on the pathways that are seen and the role of the personalized medicines, the FDA approvals which has happened in germline cancers, some real case scenarios which we saw in Kokila Bandiru Bayabani Hospital, and also finally we'll have a discussion whether there's a need to include germline testing in the routine oncology practice. So with that, I will explain what are germline cancers, what are hereditary cancers. They are the cancers which are passed from parents to the children in the subsequent generations. So it is, since it's come from the parents, every cell in the body, as it was discussed in the morning, that every cell in the body has that mutation. So unlikely sporadic mutations which are acquired, and they will be present only inside the tumor cells. So about 5 to 10% of the cases are germline, and about 75% are acquired. And 15 to 20% are usually familial. They occur after clustering because of the interaction between the environmental and the genetic factors, but they are not transmitted ahead in their children or in their family members. So what is the etiology? We have a gatekeeper and the caretaker genes. In the gatekeeper, we have a tumor suppressor genes, and we have the oncogenes. Oncogenes are very rarely seen, but tumor suppressor genes, because of the Knudsen hypothesis, they occur as monoallelic, or sometimes biallelic. And in the caretaker genes, we have the DNA repair pathway, and which are the most common and most commonly talked genes responsible for hereditary cancers. Now, in clinical aspect, if a patient without cancer comes and he gives you a history that, probably he has multiple cancers in the family, or, father was diagnosed with prostate, or the mother was diagnosed with pancreatic. So you have, or maybe the cousins or the other family members were diagnosed with the cancer. That is the time you need to pick it up and, tell the patient to go for a germline testing. And sometimes clinically, with a history of cancer, the patient himself presents with the history of cancer at a very young age, and involvement bilaterally, suppose kidneys or in the breast, or sometimes the cancer which rarely occurs in the opposite sex, like a male person with the breast cancer. And there is presence of another certain other traits like congenital defects or some skin tumors like sebaceous adenomas or keratoacanthomas, and sometimes sebaceous carcinomas, which might help you to understand that we are probably dealing with a germline cancer. And a special ethnicity is something which we need to look into, some Black, some Ashkenazi, some Jewish population, in which some cancers are pretty common. So there were some ACMG guidelines which I went through, and I found them really helpful, so I thought I should discuss with you. In the breast cancer, it has been told that if it's a triple negative breast cancer, you should definitely go for germline testing, but now I think the protocols, change here and there. But I've seen ER positive breast cancers also presenting with the BRCA2 mutation. So this is something which recently we have seen. And if there's a presence of additional symptom for the LFS, Leigh-Fermoni syndrome, or the Cowden syndrome, or the PJ syndrome, and that is applicable to all our cancers. So in colorectal, if you see a mismatched repair pathway or deficiency, or even the MSI instability, that is something which you should go for a germline testing. And also the presence of clinically lots of adenomas, more than 10 is something significant, but if you're looking up at familial adenosis, adenomatous polyposis, you're looking at adenomas of more than 100. So in the endometrial, if you see a synchronous or a metachronous colorectal or endometrial cancers, that is something giveaway. And then if it is an ovarian cancer, definitely all the patients should be put up for the germline testing. In the prostate, metastatic, and on histology, either it is a cribriform or an intraductal histology, Gleason scores more than 7. And in pancreas, invariably, all of them we should look into. And histology of intraductal papillary mucinous neoplasm is something, it's a giveaway. In the thyroid, medullary carcinoma Men's syndrome, then we have a familial adenomatous polyposis presenting as cribriform, modular subtype, and then we have a papillary or a follicular carcinoma with the Carnes or Cowden syndrome. In gastric, diffuse, signet ring cell, mismatched repair pathway, and then melanomas, of course, you need to look into it. And all the neuroendocrine tumors. And in the renals, very interestingly, we have, if the presentation is multifocal or if it is bilateral, or if it's like clear cell, papillary cell, FH associated, BHT morphology. So all these are some indications which says that probably you are dealing with a germline cancer. Now the question is single gene testing or a multi-gene testing? I think we have gone a long way from a single gene testing. There were so many hereditary cancers in which BRCA1 and 2 were wild type, but still the patient presented with cancers. And MLPA was done on those cases, and we could see some micro deletions happening in those areas where BRCA1 and BRCA2 were there. So that was a giveaway that probably we are dealing some other mutations, other genes which we need to look into, and it was further studied, and we found out that there were DNA repair genes which were involved, like BRIP1, BARD1, FANC-A, FANC-C, which were involved, and probably we are having cancers because of that. So it's a time when you get not only one pathogenic gene, we sometimes do get two pathogenic genes with some VUSs. So it's an option. I think now that we have to go for a multi-gene panel testing rather than just a single gene testing. So it's a time-saving, cost-effective, decrease in the testing fatigue for the patients and the co-workers, BRCA1, BRCA2 negative, then go for a bigger panel. Once for all, you should just do a multi-gene panel and you have all the answers. And sometimes you have information on a high penetrance, moderate penetrance, and the mild penetrance of the genes. That's very significant because there are some genes which is an absolute risk of having a cancer. Some gives you a moderate risk, some gives you a low risk. So that also helps you in categorizing the patient. Then genetic counseling is something which I need to specify that you need to have it's just not just a piece of paper. We can say it's a consent is something in which you're giving the information to the patient, and it is a process in which you tell the patient that this is what are the risks you're going to go through if you get positive, since you have a family history positive, and you need to understand the risk, benefits. The patient undergoes through a psychological effects, and we need to pass through his journey and help him out with all the treatment decisions that need to be taken later. So in our in-house, we have a genetic counselor, and we provide her, we give proper, with proper consent, we provide her genetic counseling in which detailed family history, medical, surgical history, everything is taken, and the treatment protocols are shared with the patient. So this is the ACMG guidelines in which we provide the type of the variant, whether this is pathogenic, likely pathogenic, VUS, benign, or likely benign. So there are different parameters which are being followed. Yes, I thought this will be a great break in which why the long phase, and the person is saying, no, it's hereditary. You don't have to bother much about it. So let's see about the categorization of the molecular pathways in hereditary cancers. We have a PIK3 pathway involved. We have RAS kinase pathway involved, angiogenesis defects, and then we have defects in DNA repair pathways, in the growth factor regulations, and the other polyposis syndromes which we can see. So let's look at the personalized therapies which has been already approved by FDA and some of the other drugs which are still under the trial phase. So if I look at the TSC1 gene, which is associated with the tuberous sclerosis complex, now in this one, mTOR inhibitor has already been approved by FDA in 2019 in TSC-associated SIGA and renal angiomyolipomas. So this is something, the drug is already available. Number two is the VHL1 Hippel-induced syndrome, in which the pathway, which is this hypoxia-induced factor alpha, and the inhibitor of this is already approved in 2021. And in VHL-associated renal cell carcinomas, CNS hemangioblastomas, or the pancreatic neuroendocrine cancers, not requiring immediate surgery. So you can see as that there are so many drugs which are working along with the syndromes. And then I did not say about BRCA1 and BRCA2, HRR pathways involved, and HBOC syndrome. We have carboplatin and cisplatin, which has increased sensitivity platinum therapy. And then we have the PARP inhibitors, which are approved in prostate, pancreatic, ovary, and even the prostate and the pancreatic and the breast cancers. Okay. So we have Lynch syndrome, we have APC gene which is involved, in which several cohort studies and observational studies have said that aspirin and NSAIDs, gives a good results. And in TP53, as we are discussing that, the genotoxic agents like etoposide and radiotherapy shows resistance, and carboplatin in breast cancer shows sensitivity based on the cohort studies. But the RET gene, which is again proven to be a agnostic marker recently, and it has been approved in 2022 for the tyrosine kinase inhibitors, palisetinib and the salpersetinib. So these drugs have been approved as a pan marker for RET mutations, fusions, which happens in lung cancer, mutations happens in men in the thyroid cancers. So they has already been approved. So talking about the SDH A, B, and C, based on the observational study, obviously TKIs will not work since if the diagnosis is of GIST, and also it will show sensitivity towards the metastatic paragangliomas, and I think it applies to all three of them. So if there is a normal patient, so if he comes for testing, let's suppose the case scenario is hereditary breast and ovarian cancer, we do recommend regular screening for the patient based on the gene which is involved, which might involve some MRIs and also yearly scans and mammographs after 30 years. And then we have a chemo prevention of tamoxifen, which is offered to the patient, and the risk-reducing surgeries are also which can be given to the patient, and the patient does that on the basis of their own personal decisions. And the reproductive options, if the patient comes out to be positive, then you have to screen your partner. That things is also being offered to the patients. So I'll take you through the 4 case scenarios which we have from Kokila and Dhirubhai Ambani Hospital. And the case one is, the person is 57-year-old male. He was diagnosed with the carcinoma of the sigmoid colon. Now, the histopathology diagnosis was sigmoid ring cell carcinoma. Obviously, we were looking at CDH1 gene, probably, in those lines. And then the MSI was run, and all the 5 markers were unstable on PCR. And then we took the family history, we called the patient, and we saw that the patient has a strong maternal and paternal family history. In the maternal side, the patient had a stomach and an oral cancer. On the paternal side, there was a huge history of carcinoma colon, and both the patients had died. And even the sister had a neuroendocrine cancer. So MLH1 gene has been already reported in neuroendocrine cancer. So we did the germline testing here, and we got this beautiful variant, which was likely pathogenic in this particular case. So we can say that, a timely screening, might help the patient in getting a cancer, might delay in getting the cancer. And you need to do a screening for CNS, for urothelial cancers, for even prostate cancers. And in these cases, Lynch syndrome, obviously MSI is unstable, so it's a less benefit from the conventional chemotherapy, but definitely immunotherapy is something which is to be considered in this patient. So, it is a whole body, whole person workup, which we have done it here, offered him chemo and less chemo, more immuno, and offered him all the protective measures which are given here. So case number 2, she's again a 57-year-old female. She came with the right localized advanced breast cancer, and the clinical diagnosis was triple negative breast cancer. And the patient came, and among the local, the family history, we saw that the father's side, the grandmother had the breast cancer. And from the mother's side, we have the carcinoma of the cervix and oral cavity. So we screened it, and very surprisingly, we didn't get BRCA1, BRCA2. We got a DNA repair pathway gene, which is BRIP1 gene. So it came out to be pathogenic in this particular case. So this was a very good example that it's time that we move on from single gene testing to multiple gene testing. And in this patient, since olaparib is already approved in castration-resistant prostate cancers, so that opportunity, that can be offered to a patient if the patient wants it. But the surveillance for ovary was offered to the patient, and since the lady was 57 years old, so already the reproductive history was over, so we didn't have to tell her to screen her partner for if she wants to go ahead, because there is chances of Fanconi's anemia if there is a biallelic, and 2 biallelic patients they marry. So this was a good case. And then we have a case number 3. She was again 55-year-old female. She was reported with the invasive ductal carcinoma of no special type of the right side. And again, the clinical diagnosis was triple negative breast cancer. So, and again, we called the patient triple negative breast cancer, so we took the proper history. So on the paternal side, we had lots of cancer. So when we screened the patient, we had a pathogenic gene mutation in MUTYH, MAP-associated polyposis, and then we had a likely pathogenic in BARD1. And in the history, the father had a colorectal cancer, and the other cousins, they had a breast cancer. So we could trace that the patient's breast cancer is coming from BARD1, not from the MUTYH. So since she had this positive, she is positive for the gene, so she was given all the screening protocols for the even FAP-associated polyposis. So this is something, I think this running a germline testing give us a lot of information which can be processed later. The last case is case number 4. We had a 29-year-old female who is presented with a breast cancer. And again, she was reported as triple negative breast cancer. So you can see in triple negative also there is a huge variety. So this is something which we need to see. And the father had a leukemia. So that was a giveaway, young age, and also the father had a leukemia. So we screened it, and it was TP53 gene which was involved. Obviously, all the Bs, bone, breast, and also something with the B. All the cancers were the patient had blood leukemia, blood cancers. So all these screening protocols was given to the patient, and of course the patient has increased sensitivity to radiation and chemo resistance. And again, that's a question of debate. So now the next question is, do you need to incorporate germline testing in routine oncology practice? Well, it is based on every clinician. I leave it up to you, but it definitely impacts your approach to cancer. I just read one article just few days back. It was saying if you don't screen your patients for genomic testings, both somatic and germline, 10 years down the line, you're going to think, how come I did not do this? How come I did not look into the family history? How come I missed this? So this is my argument, because every person has its own way of approaching, because we as oncologists or molecular pathologists, we look into the treatment aspect. We want to know which is a driver mutation, which can be targeted, which can be healed faster, But we forget to look into the family history. We forget to screen the family members where we can give them more information and prevent them from cancer. So this is something which we actually need to look into, expand our horizons here. Of course, more data generation will help you with more number of mutations, which might give you answers to your cancers. Effective screening strategies are given. Therapeutic treatments are available. As we all know, it's coming up. Yes, some patients are not able to afford. Sometimes we get VUSs, variants of unknown significance. We don't have answers for that, how to approach. And those patients can be followed up every 6 months or 1 year. And some people also argue that there's not enough statistics available. But I will argue that maybe you should not feel bad after 10 years. So there was a very recent article which says comparison of universal genetic testing versus guideline-directed targeted therapies in hereditary cancer syndromes. So this article did both ways, and they actually proved that by doing a universal genetic testing, they could improve the patients, they could do the modifications in the treatment of the patients in more than 30% of the cases. So this is my talk, and I will just conclude. There's a need for the identification for germline predisposition, for treatment decisions, for risk-reducing interventions, cancer screening, and germline testing. Thank you. The simple act of caring is heroic. I'll just end up with this.
Thanks, Dr. Amrit. That was very comprehensive, very beautifully covered. I'm glad you touched upon that last paper.
I think that paper was given to me by ma'am itself.
I think the idea was to communicate to everyone that actually there is a push towards universal screening of germline, basically at the germline configuration, even if they present it to you as any solid tumor. So the question is whether every single solid tumor, that's where the world is headed, every single solid tumor, whether you need to look at it from the germline perspective as well. And that paper, and beyond that, there have been many other publications as well. They all went on to show that the percentage of hereditary cancer is far higher than what we think. Okay. Earlier, the thought was that it was 8 to maybe 10%. Now that MSKCC study went on to show there's nearly 14%. And they also altered therapy accordingly. So there's a lot of proof coming out, and there's a lot of focus on testing every single solid tumor from the germline perspective. Okay, so I'd like to quickly also add in, there's a huge benefit. I know we are looking at personalized medicine and about treating each individual here, but there is a huge benefit for the family as well. Many of these are autosomal dominant, and as we know, it's better to screen the siblings, offsprings, first-degree relatives who are at risk. We at Velo have very large number of patients with medullary. We have a large database of patients with medullary thyroid carcinomas, and the family draws a huge benefit when they know that the patient, the sibling or the offspring is also likely to develop tumor at some stage, and prophylactic thyroidectomy is a possibility. So similarly, such risk-reducing surgeries can be offered, and I think there's a huge benefit. So would you like to, would anyone have some
Can
questions?
I make a comment? Thank you, Dr. Amrit, for a very nice topic which is very close to my heart. And we have a recommendation from our country published in the Journal of Clinical Oncology a few years back, and we are revising it, and we'll have a revised publication this year on the indication for genetic testing for hereditary breast and ovarian cancers. And it is not just the fact that 10, 15 years down, you will feel bad. Why did I not order testing? The patient's relatives will take you to court. So it is mandated now legally that for the relevant patient, you must get it tested. Yeah.
Thank you
So
so
it has
much.
to be emphasized a lot more than mere ko bura lagega. You will be in court and you will have to pay damages. You may have to pay damages.
Thank you, sir.
Thank you, ma'am, for giving us a simplified view of hereditary testing. The next talk is about precision oncology in cancer of unknown primary. I would like to invite the speaker, Dr. Kanwal Raghav, Associate Professor, Department of GI Medicine Oncology, Division of Cancer Medicine, the University of Texas, MD Anderson Cancer Center, Houston, Executive Medical Director, Ambulatory Treatment Centers, the University of Texas, MD Anderson Cancer Center, Houston.
Hello, everyone. Good evening. I know it's quite late in the day and you've heard the word gene so many times, but now that if I repeat it once again, everyone will probably go to sleep. But I'm Raghav. I'm one of the GI medical oncologists. My clinical practice centers around biomarker-driven therapy in colorectal cancer and management of some really rare cancers such as peritoneal mesothelioma and cancers of unknown primary. And despite whatever you might have heard today, when you're a practicing clinical oncologist, you realize that cancer medicine practice in today's world is anything but precise oncology, and it is anything but personalized treatment. So our dream of precision oncology and personalized treatment still stands, and there's a long way to go. But it is good to hear that there are many tools that are available for us. With that preface, I'd like to start with precision oncology in one of the hardest and more challenging tumor types that you ever see in the clinic, and these are cancers of unknown primary. So cancer of unknown primary, by definition, is any cancer that is present in your body and you have no idea where the primary source is. So nobody's going to tell you, I have breast cancer, I have colon cancer, I have lung cancer, which is the case with almost 98% of the cancers. Only about 2 to 3% of all diagnosed invasive cancers are cancers of unknown primary. And this unknown primary definition is defined by a diagnostic evaluation, right? An adequate diagnostic evaluation. The one thing that we know about all these cancers of unknown primary is they have very poor prognosis in general. Median overall survival for a large unselected group of cancer of unknown primary still tends to be about a year. So what is adequate workup? Unfortunately, after a long time, these are very recent updates. These are the most updated NCCN and ESMO guidelines. And, apart from the routine history, physical, imaging, immunotherapy, pathology, for the first time, both NCCN as well as ESMO guidelines have endorsed use of molecular profiling for management purposes in cancers of unknown primary, right? So and all of this is being driven by a series of tissue agnostic approvals that have happened in the recent times. Again, we have to be very careful of calling these true precision oncology because they've still been derived from trials that statistically show us improved overall response rates and progression-free survivals compared to what we currently have, which is standard of care and chemotherapy. But molecular profiling is definitely a part of treatment modalities in these cases. There is also tissue of origin profiling. So molecular profiling in cancer of unknown primary can be used to reflect which primary is the putative primary. But so far, none of these are endorsed by the chief guidelines. And the reason for that is there are no outcome-based studies on this. So I just want to be very clear. We're talking about cancers of unknown primary in a room full of oncologists. We have to be very, very specific about what unknown primary is. It is not an uncertain or unworked up primary. And hand to God, these are real cases that I see in clinic. Refer to a tertiary level center, 52-year-old woman, old woman, non-smoker, headaches, has a mass, done craniotomy, shows metastatic adenocarcinoma, and patient is sent to the unknown primary clinic. All you need to do is get a CT scan and you have your answer. So this is not an unknown primary. This is non-small cell lung cancer. So when I talk about unknown primary, that's you've done your diligent work and you still have no idea what the source is. And this is where the biology of unknown primary comes into picture, right? The central dogma of cancer is it starts in an organ and then it grows and spreads to other places, right? That's why a T1 colorectal cancer is unlikely to metastasize to lymph nodes, whereas a T4 has a high likelihood of metastases. By definition, when you look at these tumors, this is a spectrum of a place where your primary is easily seen to a place where your primary is just not present, and somewhere in between is the issue of diagnostics. So you did not do adequate diagnostics, or our current diagnostics are not just good enough to look at these tumors. But if that is the case, it still begs the purpose that the biology of these tumors is very different because they have a tendency for early dissemination and metastases, because they are very diminutive primaries, very small primaries that create a lot of metastatic catastrophe in the body. So when it comes to personalized and precision medicine, CUP is the epitome of personalized and precision therapy, right? Because you have to tailor it to every patient individually, including diagnostics, therapeutics, and prognostication. There are no randomized clinical trials in CUP that tell you that ER/PR positive breast cancer will benefit from hormonal therapy in general, or triple negative breast cancer will have benefit from a particular therapy or HER2. So as a disease factor, treatment factor, as well as prognostic factor, these are very heterogeneous entities, and one has to step back a little bit, even before the genetic issue, and put the whole patient into context. So when you look at the CUP diagnostics, when you look at the symptom and presentation of the patient, you look at their imaging and tumor markers, and more recently, the greatest cornerstone of diagnosis in CUP is immunohistochemistry and molecular profiling. And yes, believe it or not, even in the 21st century, immunohistochemistry and pathology is a very valid and important tool in the hands of oncologists to diagnose cancers of unknown primary. Quick thing about tumor markers, just like precision oncology, or is often referred to as molecular oncology, but precision oncology and personalized treatment is all about tailored therapy. And if you have to arrive at that question of tailored therapy, you have to think about how you're going to diagnose that primary. And tumor markers have no role in the diagnosis of putative primaries in these tumors. You can follow them for treatment response, but once a tumor is de-differentiated, there is no rule that the tumor follows. So a gastric cancer can produce HCG, a liver cancer can produce CEA, and a mesothelioma can produce CA125. When you look at this case, for example, this is a woman who came to us with an extremely elevated HCG level and was told that she has liver cancer or HCC when she had no risk factors whatsoever for liver cancer. And actually, we found that this was a poorly differentiated carcinoma with hepatoid differentiation. And as you can see, the patient was treated with carbotaxol and gemdocetaxel, and those tumor marker trends are all based on chemotherapy. The patient never got an HCC-directed treatment and responded very well and was not treated with sorafenib at that time. The second aspect of personalized therapy or precision medicine in cancer of unknown primary is what is the imaging? In a way, we image everyone with CT chest, abdomen, pelvis. We have specific indications for PET, and just like that in cancer of unknown primary, even though CT chest, abdomen, pelvis is the central testing, the PET scan has some value in increasing the detection of primary rate, but only in a small proportion of patients. This is an example of an ex-smoker who came with hip and back pain, and they found this pelvic lesion, which was biopsied, and it was a malignant neoplasm, but there was a non-specific IHC pattern. And this is a CT chest, abdomen, pelvis with no discernible primary. When you get a PET CT scan, as you can see, the CT still had a very diminutive lung cancer, but on the PET CT scan, not only did you see the primary, but you could also see better the other sites of disease. And this is a classic example of personalized application of PET scans in cancer of unknown primary, depending on what you think is the. Contrary to that, there was another person who came to us who was only getting PET scans and has been treated as a poorly differentiated carcinoma with the IHC that was non-specific, and the patient had a PET scan without contrast. And when you actually did a CT with contrast, you could see a contrast enhancing renal cell carcinoma, and the pathology confirmed that on biopsy. So there are specific and personalized use of PET imaging in CUP, especially with head and neck squamous cell carcinoma, some follow-up with patients who have osseous metastases, and those that have iodine allergy. But it shouldn't be applied indiscriminately in all cases. Prospective trials about this use is, of course, not existent, as is the case for many other applications in unknown primary. We then come across pathology, and this is a very large slide. I always tell my fellows that, as a joke, that you have to remember each of these stains, but the bottom line is you actually don't have to. One of the things that you have to remember about immunostaining is the same thing as tumor markers. When a tumor is de-differentiated, it doesn't follow any rules or patterns. So if you do not see mammoglobulin in a patient with unknown primary, that does not mean the patient doesn't have breast cancer, because the sensitivity of mammoglobulin in a well-differentiated breast cancer is about 90%. But the same sensitivity in a triple negative breast cancer falls down to 50%. That's flip of a coin, right? And a lot of times that these things come to us. The other issue, especially in era of precision oncology with cancer of unknown primary, is the issue of tissue. You cannot keep biopsying a patient multiple number of times. And in cancer of unknown primary, we spend so much effort and so much tissue in doing immunopanels that we exhaust that tissue indiscriminately. In some studies, prospective profiling trials, you have only been able to do profiling in about 40% of these cases, because in 60% of the cases, all the tissue was exhausted with immunostains. The median number of immunohistochemistries done on a patient with cancer of unknown primary is 9 in our practice. The range is anywhere from 3 to 25. And this study tells you that you do not have to indiscriminately keep doing every test, but instead devise smart panels wherein you can use a combination of these immunopanels that can help you discern this primary. Unfortunately, AI is now being used in pathology to determine the kind of tiered approach towards doing different immunopanels. Immunohistochemistry also help us define some subsets, like the GI subset of primaries. And these are very important, as was the case with Dr. Pitak said. You see a patient with PD-1 expression of 50%, you're tempted to use immunotherapy, but then you start seeing other mutations. Maybe you start seeing a KRAS mutation, an APC mutation, a TP53 mutation. We all know which direction I'm going. These are GI primary tumors, and there is no role of PD-1 expression in GI primary tumors when it comes to response to immunotherapy, especially with peritoneal carcinomatosis. So IHC can actually further define these simplistic groups of cancers of unknown primary. As you can see, the whole point of this tailored approach is to keep digging down these large heterogeneous groups into small homogeneous therapies. And this study showed us that when you treat these patients with GI tumors with a GI type regime, their median survivals are about 37 months, which is much higher than what you would expect in a cancer of unknown primary population. So this is an example of IHC in cancer of unknown primary. 72-year-old non-smoker, had stage 1 breast cancer, which was ER/PR positive, had surgery, radiation, was getting a surveillance PET scan, and was found to have a poorly differentiated adenocarcinoma recurrence. This recurrence was ER negative, HER2 negative. It was TTF1 negative and negative for breast markers like mammoglobulin and GCDFP15. We had a tumor board on this, and the arguments for CUP by the breast medical oncologist was mammoglobulin is negative, GCDFP15 is negative, the primary tumor was ER/PR positive, it was originally moderately differentiated, and stage 1, it's unlikely to occur. But now compare this to the argument against CUP. So the likelihood of a stage 1 breast cancer recurring in 10 years is about 13%. The chances that a person has a cancer of unknown primary period is much lower than that risk rate. Furthermore, when you look at mammoglobulin, you do not find GCDFP15 or mammoglobulin in poorly differentiated breast cancers to the degree that you would find them in moderately differentiated tumors. And when we got together with our pathologist and said, can you please review the breast specimen, they actually found a small focus of high-grade triple-negative breast cancer within that original specimen, right? So this was treated as a triple-negative breast cancer. Now we come to how we have applied molecular profiling in cancers of unknown primary. Molecular profiling in cancers of unknown primary has largely been used to date to answer the biggest question: what is the tissue of origin, right? And the basic hypothesis is very simple. If breast cancer has this molecular profile and a cancer of unknown primary has the profile that matches it, then the unknown primary is breast cancer, right? This is the simple hypothesis. You can apply this to genetic profiling, DNA sequencing, RNA sequencing, whatever you like. So what you do is you take a large group of known primary tumors, you profile them, then you find genes that can differentiate between those tumors, and then you apply that same algorithm to an unknown primary patient, and then you decide, okay, this is what the unknown primary patient is most likely to be. And prediction levels can go up to 90% because you are developing an algorithm to differentiate between that two. But the basic premise in this is that whatever your profile is for the primary tumor is what your unknown primary represents. Now, when you look at colorectal cancer, for example, we now know that just based on superficial gene profiling, there are at least 4 different subtypes of colorectal cancer: CMS1, CMS2, CMS3, and CMS4. They all differ significantly in their response to chemo, their prevalence of targeted therapy, targeted agents, targets as well as targeted therapy, right? So this begs that when I'm training my set everything that I develop is based on my training set, right? So this is whatever data I input. So if I take colorectal cancer and I just ask the hospital to give me 1,000 colorectal cancer specimens, I know that majority of those colorectal cancer specimens are going to be high in CMS2 and CMS3 because CMS1 and CMS4 are rarer. So you will never catch that variety within those expression profiles. However, despite that fallacy, RNA-based profiling has been used to detect tissue of origin. It's used in clinical practice. I showed you that as far as the guidelines are concerned, they do not endorse it. But there have been studies which show that the prediction is good. So there was a prospective trial in which they took 289 patients of unknown primary. They did the tissue of origin profiling. It was successful 98% of the times, and they found biliary tract, urothelial, colorectal, all kinds of tumors. And they said that the median survival was about 12.5, but the tumors where you expect good survival had good survival, and tumors that you expect bad survival had bad survival. And therefore, this is a good indication of the use of tissue of origin, as we know that all this means is this is a prognostic tool. So going next step, they said, well, RNA sequencing is not just helping us. So why don't we just do a comprehensive molecular profiling? So why don't we do a DNA sequencing and whole transcriptome data? And they couple this with machine learning to aid in the diagnosis of cancer. And that's the new class of tissue of origin tests that is coming up. And these have been trained again on tumors that have known primary that had this testing done. This particular one is by Caris. This has been validated in 19,000 cases, and it predicts the tumor type with a 94% accuracy. But when you try to do that in a cancer of unknown primary, that first of all, that prediction drops, and we still do not know the answer whether that prediction really matters. So this is just the accuracy of all of these tissue of origin predictions as far as cancer of unknown primary is concerned. And I think that most of these should be used in terms of a clinical trial, but out in the clinical practice, as with every tool, do not take it off the clinical context. So there have been cases where we saw the profile come back as a mesothelioma when the clear diagnosis was an adenocarcinoma with positive cytokeratin. So this is an example of such a case, non-smoker, CNS symptoms, multiple brain metastases, papillary adenocarcinoma, and somebody sent a tissue of origin profiling, and it turned out to be pancreatic. And when we did a PET CT scan and an endoscopy, it showed a clear gastroesophageal carcinoma. So when it comes to CUP, one of the biggest problems is how much to do and when to do it, right? So if you had all the time in the world and you had all the finances in the world, you could do any number of tests. But these patients are sick. They are progressing rapidly. Many times they get multiple biopsies before they even start treatment. The median time to starting treatment in cancer of unknown primaries is about 4 months, which is very big for somebody with a metastatic cancer. And it adds to the cost of care, leave alone the cost of time and quality of life. So the simple approach is, if you think a patient has unknown primary, think again. If your primary is detected, then it's not unknown primary. If it's a favorable subset of unknown primary, then you treat as per the subset. Otherwise, you have to rely on multiple tools to determine whether you're going to go with just empiric chemo or you're going to tailor the therapy. So these are the NCCN guidelines as of date for cancers of unknown primary. And as you can see, this is a picture of anything but precision oncology. This is carbotaxol, gemcitabine, cisplatin, 5-FU-based treatments, docetaxel. The only place where there is possibly some hint of precision-tailored medicine is MSI or deficient mismatch repair tumors, where pembrolizumab and dostarlimab have been approved as tissue agnostic, and then selpercatinib for the RET gene fusions. The same thing goes for squamous cell carcinomas. And as far as empiric therapy is concerned in cancer of unknown primary, you can see that this one figure tells you that no matter what treatment you use, the survival of these patients is very poor, right? The 1-year-old overall survival is 46 or 35%. These were largest randomized trials looking at empiric chemotherapy, various combinations, and they only showed minimal improvement in overall survival over others. When you do the meta-analysis, you find that there are only 7 randomized controlled trials here. The median survival is still very much around that 9 to 10-month period. And no treatment particularly appears better. So now the question is, if you were able to predict the site, and instead of just choosing one chemotherapy, can you tailor treatment according to that site? And that's called site-specific therapy. This was the largest trial that was done to answer that question. They wanted to enroll a lot of patients. They could not enroll all of those patients. Only about 100 patients were enrolled. And they predicted the tissue of origin based on gene expression profiling, and they gave profile-directed therapy versus empiric chemotherapy to patients. And what you find is that the overall survival and PFS was exactly the same. So there was no difference, right? Now, the issue here could be many, and which we'll discuss later, but it failed to show any improvement with site-specific therapy. And this has been a big hit to the hypothesis that tissue of origin really matters. The Jeff Cappy 04 study was a phase 3 trial answering the same question in Europe, and it failed to show any improvement in PFS or OS. Now, there are many limitations to this so-called personalized approach. Number one is that 26% of the patients did not receive tailored treatments in these trials, right? So at best, I would say first of all, these trials were underpowered to answer these questions because none of them reached their accrual, but many patients did not receive the tailored treatment. In cases where they received tailored treatment, the treatments were suboptimal because treatments are changing with application of immunotherapy and targeted therapy. A lot of this has changed, right? And the profiling was very restricted, only specific to gene expression profiling. So there was no incorporation of targeted therapy as first-line treatment for many tumors, and we know that that is not the case in standard of care. So I still think that there is a value to site-specific therapy and looking at tissue of origin. So the second application of molecular profiling is for therapy. And we've discussed a lot of that. This is, one of the largest sets of unknown primary, which has been profiled by tissue. What you find is that a large majority of the top players in this graph are non-targetable mutations, or at least non-targetable mutations from clinically applicable drugs currently, right? TP53, the KRAS appears to be targetable more recently, but most of these were not. KRAS 12C, CDKN2A, MYC, MCL1. Then comes this battery of like a few sub 1% prevalence biomarkers like HER2, BRAF. But nonetheless, in the absence of any good options for treatment, we should use this. Fortunately, tissue agnostic approvals are coming into picture. Deficient mismatch repair, NTRK fusion, TMB high, FGFR hopefully at some point of time, and HER2, a variety of drugs, and dabrafenib and trabetinib more recently for BRAF V600 mutation. So when you do an immune profiling for these tumors, you find that TMB high is defined in about 11% of these cancers. Deficient mismatch is about 2% of these cancers. So PD-L1 expression is 22%. So overall, the conclusion of some of these studies is about 28% of cancers of unknown primary would respond to immunotherapy. But that's not really true because even within high TMB, your response rates are 30% with a TMB cutoff of 10, right? So I think that immune profiling has selective role in CUP, and this was proven by our phase 2 study of pembrolizumab along with another study of nivolumab, where the response rates were about 22% in an unselected CUP population. So then comes the last but not the least is prognostication. For a long time, the Culin prognostic group, which was basically performance status and liver metastases, was used to tell you whether you had a good risk CUP or a poor risk CUP. Survival of both of these was poor either ways, 11.7 and 3.9 months. Our group recently worked on the largest CUP data set with discovery and validation cohorts with multiple centers to define this nomogram, which is based on simple clinically available measures. The next step of this nomogram is to apply molecular profiling to it, which is the work that's ongoing. And this nomogram is available clinically. So in summary, CUP is a metastatic cancer. You have to apply the diagnostics very carefully. And even before that, you have to ask whether there is any primary present or not. Imaging, immunohistochemistry, tissue of origin profiling should always be tailored to each and individual patient, depending on their clinical context. We always perform sequencing on first day we see a patient with cancer of unknown primary, because we are always looking for clinical trials, or we are looking for at least tailored targeted agents that we can use in this setting. But as has been discussed in the day before, you have to apply this with appropriate tools and appropriate precision. And always see the big picture. You pick up Foundation Medicine report, you will see that HER3 mutations can be targeted by trastuzumab, but all of us know that that's not the case. So as is the case with any tool, one has to exercise it very carefully. With that, I'd like to acknowledge my long-term friend and mentor, Dr. Vardachari, who died about 2 years ago with, ironically, cancer of unknown primary that was later diagnosed as lung cancer, and the other group of investigators in this field, and then subsequently our patients that help us understand this disease. Thank you. I greatly appreciate your patience.
It's okay.
Aga,
It's okay.
can
It's
I
okay.
ask you?
Yeah, sure. So, sorry. Yeah, I got it. So thank you very much for this fantastic talk, and you really opened my eyes and maybe others that we should think about cancer of unknown origin as a new biological entity rather than an artifact of not finding the primary. So can you elaborate a little bit more that how you should think about this, and maybe it's a completely new tumor type. So we should consider it as not a case where we don't know what the primary is, but rather to think about it as a new type of cancer with a very unique biological background.
Yeah, so I think this is the step that we are taking, in our clinic. One of the major issues with cancer of unknown primary is this tendency of early dissemination, right? Even if you believed that, the only reason why we're calling it an unknown primary is because I just don't have a high resolution CT scan, which is the resolution high enough to see that really, really small tumor. That basic presumption is against everything that you know about cancer, right? Because in cancer, most of our things that we base our staging is on the AGCC criteria, right? And we know that across all tumor types, the simple note is the size of the tumor is directly correlates with the extent of metastases that tumor does, right? So when you now we have data about RNA sequencing and gene expression profiling across multiple tumor types, which show that almost every tumor type, breast, colorectal, pancreas, gastric, GI in general, lung, have these EMT phenotype of cancers, or a subset of tumors that have this epithelial mesenchymal transition phenotype, which has this early chance of dissemination. They are enriched in stem cells. They have chemorefractoriness. And they do not respond to even the standard treatments that you use for those cancers in general. Our hypothesis is that cancer of unknown primary probably reflects a compendium of tumor types that share that biological property together, right? So I think the greatest emphasis here is that in this tumor type, there are so many contexts that you have to put together. And that was where my question about molecular profiling and tissue context was stemming from, is that an appropriate application of machine learning algorithms, right? Because even in our cancer of unknown primary clinic, where we see about 200 patients a year, it becomes challenging to remember every permutation and combination of an immunophenotype and a molecular profiling with a tissue context and a clinical pattern of presentation. That a tool created to answer that question would go a long way in helping people treat this out in the community and in every ward. Thank you.
I have a question which appear very simple and may not be even, but it's a practical clinical question. So when a patient comes to you, for example, your clinic, with a report of foundation in hand, which shows one mutation which you know, and another two mutations which you probably would take time to understand. I'm sure there are such mutations, or there are some VUS which you would like to maybe think what to do with them. So in a typical clinic, how would you approach this patient? Would you give your judgment immediately, or would you take time to give judgment?
That's it's a very clinically oriented question. So I'll give you my clinical recommendation. So fortunately, many times at MD Anderson, we are not faced with that dilemma, because when we see molecular profiling, we often try to move the patients towards clinical trials. So that's the benefit that we have there. But if I wasn't practicing at a referral center, this would be a big challenge, especially because off-protocol and off-label use of drugs is rampant across the board, right? So one of the things that Dr. Pidak was mentioning is that, you have these tools that are now available to clinicians, right? Everybody of you has probably treated at least one patient off-protocol drug, right? You have no idea how those patients performed. We have no real-world evidence of what we are doing for these patients. I have patients that have been treated with cetuximab just because they were RAS wild type, irrespective of what cancer phenotype they had. And we know cetuximab doesn't work in gastric cancer. We know it doesn't work in, and I'm just talking about GI cancers in general. I haven't even talked about like breast cancer or other tumor types, right? So whenever patients come with this kind of question, I think this is a big challenge. AI tools will be helpful in answering that question to a certain limit, because there are two categories of drugs. When instead of looking at what is your molecular profiling and what you can do, let's look at what you can do and what is your molecular profiling, right? So that category changes things to two. Number one are drugs that have known activity in a tumor type. And now you're selecting between different therapies to decide what is the optimal treatment. That was the example that was given to us, right? So I think that is a very different question, because at least you're not at fault of treating that patient. But if BRAF mutation comes up and it's a colon cancer patient, you are never going to treat the patient with a single agent BRAF inhibitor, right? In fact, all cancer tissue agnostic approval for BRAF V600 mutation is trametinib plus dabrafenib, right? But that is not the tumor, that is not the combination you would use in colorectal cancer. So I think that tissue context still plays a very important role in tumor biology and tumor response, and good tools have to incorporate that along with the data, right? So in our clinical practice, we recommend against use of off-label drugs, irrespective of whatever level of evidence that is created, because level of evidence from cell lines and anecdotal evidence is not sufficient enough to treat patients, because at the end of the day, quality of life is also important. And I'm not even talking about pharmacogenomics and how the patient would respond to that.
Can I ask you one question? I think the diagnosis of the pathological diagnosis, the pathologist tells you it's adenocarcinoma. Then they write also metastatic adenoma. Now, there's no character of metastatic adenocarcinoma, but they write that because they feel adenocarcinoma cannot occur in the brain, or it cannot occur in the vertebra, and therefore they write metastatic.
Yeah. I mean, I work very close with pathologists, and I have great respect for their work because it is just so difficult without a clinical picture, just looking at a slide to determine what you should do best, right? So in our clinic, our general purpose is that we need to talk to the pathologist, and that's very important because you need to conserve tissue, right? Like a lot of patients that I see just keep getting panels after panels after panels. I cannot like I have never seen, almost never seen a patient that was referred to us who was a woman with a metastatic cancer that did not have one of the breast markers done, irrespective of how the patient presented. So I think a continuous dialogue with the pathologists, before they start ordering tests is vital. Unless, of course, it's an obvious thing. And then sometimes I think pathologists would benefit from reading the presentation of the patient before they actually start giving out their diagnosis.
Actually, my question was, why can't adenocarcinoma can occur in the brain? I remember 20, 30 years ago, we were taught that lymphoma cannot occur in the brain. And now we know how common it is, primary lymphoma of the brain.
Yeah,
So why can't the adenocarcinoma can occur in the brain
Yeah.
through some cells?
Dr. Advani, I actually think that cancers don't follow any rules. So anything can happen anywhere. We're just people who, human beings generally are probabilistic by nature, right? Like the reason why you drive carefully is because you know that the probability of like being in an accident if you drive fast is higher than if you drive slow. That does not mean slow drivers are not in accident or fast drivers always meet an accident. It's just a probability issue, right? So I actually remember a very distinct case of unknown primary where a patient came in with an adenocarcinoma brain diagnosis. After proper profiling and looking back at the cases in history, it was actually an epithelioid variant of GBM, which is very, very rare, very, very rare. I had not even heard of that throughout my training, right? So, and again, when you look at adenocarcinoma, there are crush artifacts, how you are processing the tissue, what you are seeing under the slide, what section did you see? So it can happen. It's just rare, and therefore I cannot blame anyone for saying, this is not metastatic this is metastatic adenocarcinoma. Thank you. Greatly appreciate patience. Thank you.
Thank you, sir, for giving us a clinician's perspective. The next panel discussion is on head and neck cancers. To chair this session, I would like to invite Dr. J.P. Agarwal, Head of Department of Radiation Oncology and Chief Vigilance Officer, Tata Memorial Hospital, Dr. Mandar Deshpande, Senior Consultant, Surgical Oncology, Head and Neck, Kokilaben Dhirubhen Ambani Hospital. The moderator for the session is Professor Dr. Vijay M. Patil, Consultant, PD Hinduja Hospital. The panelists for this session are Dr. Vaibhav Chaudhary, Consultant Medical Oncologist, Kokilaben Ambani Hospital, Dr. Rohit Pai, Assistant Professor, Medical Oncology, Topiwala National Medical College, and by Yamunabai Lakshman Nair Charitable Hospital, Dr. Advait Gore, Associate Director, Medical Oncology at Nanavati Max Institute of Cancer Care, Dr. Vidya Veldore, Clinical Director, Base Care, Bangalore, Dr. Bhavesh Parekh, Head of Medical Oncology, Shalby Cancer and Research Institute, Ahmedabad, Dr. Anup Toshniwal, Consultant Medical Oncologist, Shri V Care Clinic, Aurangabad.
So I thank the organizers for this opportunity. I'll request my panelists to be brief. The time for the panel discussion has already got cut down from 45 minutes to 30 minutes. So without any ado, we'll start. So we can have questions going from Anup towards Advait side. So my first question is, when you look at head and neck cancer, when do you order an NGS? And let's say that there's nothing right or wrong because this won't be tested in any randomized study. So in your practice, let's not have the podium syndrome of telling the absolutely diplomatically correct. In your practice, in head and neck cancer, when do you order NGS? Is it upfront? Is it if upfront locally advanced? If it's a recurrence or if it's like post first line of recurrence? So you don't ever order an NGS? Post second line. Okay, post second line. Okay. I think the mic is not working.
It's post third line.
Okay.
Practically never in squamous histology.
Okay. We won't let Vidya answer.
I've never asked for an NGS so far.
Okay, great. So what we can understand is when you look at, yeah. Yeah.
But sometimes we also feel that
The mic is not working.
It's not working.
in head and neck cancer also gradually it's like breast or lung cancer. Sometimes people are surviving beyond our hope also. So at that time we feel that NGS will be much better.
Okay. Okay. So what we could see from here is there is very limited experience in doing NGS upfront. Most people would do it when their back is at the wall, when they're post first line or second line, and that would this. Okay. Oops. Oh my God. Oh, no, I was actually expecting it to be a long panel, so I had a lot of side. Would this change if I change the site of the tumor? Let me tell you, you are now dealing with a differentiated thyroid cancer. You are now dealing with a salivary gland cancer because all these also are part of head and neck cancer. So would you, or you are doing a rare type of a Merkel cell or a soft tissue sarcoma? Would this change? We'll again start from Advait. So
Yeah,
now, would your timing of NGS change if the site of the primary changes?
Absolutely. Today when we are looking at certain rare tumors, you would want the NGS maybe upfront itself to take a decision. Because in situations like say a Merkel cell carcinoma or a soft tissue sarcoma which is coming in, you would want to know what are the potentially targetable mutations. In salivary gland tumors also you would want to know that because there are so many different targeted therapies which are currently available and where we know that the conventional chemotherapy just doesn't work.
Okay. Rohit, any other one?
So yes, sinonasal, salivary, thyroid, all that probably right at the beginning. I would like to get that info.
So all those which are listed below larynx, you would want to get it upfront, even sinonasal anesthesia?
Probably yes.
Okay, great. Bhavesh sir?
Especially salivary gland and sinonasal. And again, you had mentioned that again in their rare, that's Merkel carcinoma or soft tissue sarcoma. Sometimes we had, even in head and neck, the report is like they have reported a sarcomatoid variant.
Yeah.
So again, we feel that most probably, since so many years, we feel nothing is work. So in that case, when NGS I had done 1 or 2 cases and suddenly there was a targetable mutations.
Okay.
So I think there is definitely, so that word head and neck cancer, I think these 3 different or where exactly, also one word used squamous cell carcinoma.
Yeah.
So whenever there is non-squamous or other than squamous or other than routine, and might be gradually like that carcinoma of unknown primary, when as a clinician, when we thought, then actually it was like such other malignancy also in head and neck cancer is mostly more than 20%.
Okay. So what is coming is when you look at, when you get the condition like head and neck cancer, what comes in mind is head and neck squamous cell carcinoma. And in that situation, you could see if the panelists were not quite willing to do the next generation sequencing upfront. They wanted to do it after first line of therapy. But when you look at rare tumors, when you look at thyroid cancers, when you look at salivary gland cancer, sinonasal cancers, you know they have a lot of more targets. And these targets do determine the treatment. So Vaibhav, let's say that you had this thyroid or salivary kind of a cancer, and you had the option of all these things. Which of them would be your choice? And a quick one-liner why?
In ideal case scenario, comprehensive genomic profiling should be done. It will take care of these mutations as well, plus tumor mutation burden as well. That's the thing.
Okay, so you want to look at tumor mutation burden also, and Anup?
Sir, CGP.
Okay, Advait?
Yeah, so cost apart CGP.
Cost apart. Rohit, is that the same with you? But let me be a devil's advocate. Let's say that you are looking at a differential thyroid cancer. You want BRAF, RAS, RET, NTRK. Why not a panel of, because these 4-5 genes would cover nearly 90% of the year. Why not, let's say, a PCR? Oh, Vidya might tell you, or Dr. Anuradha might tell you, she would give you the report much faster than a CGP. And you may require a faster report if it's an anaplastic thyroid cancer. You don't want to wait for 21 to 28 days. So a limited panel which might give you answer, let's say in 4 days or 5 days. Why not that?
Your question is valid, but again, as a clinician, so many times we had burned our fingers by doing PCR or by limited panels. And ultimately, we had that better to do CGP.
Okay.
So I think it's a continuous process. Might be another 1 or 2 years. We all are agree. At present, might not be, but CGP is the more better answer.
I'll get
And
Vidya
another
yet.
another
Yeah.
issue asking for limited panel NGS is that not all labs give you everything. You
Correct.
have to ask for
Correct.
multiple different investigations from that lab,
Yeah.
in which ultimately you are going to be taking 2 weeks to get
Correct.
that report. So current situation is such that none of the labs will give you a limited NGS for a head and neck cancer, for a rare tumor. You will have to ask these separately.
Correct. Exactly the whatever. So it looks very fine when you say, okay, limited panel NGS, which is in pan, but what we must understand is when you practically work in a clinic, there are very limited panel which are made for salivary, anaplastic thyroid, differentiated thyroid, or for medullary. And such have been made, but they have been made for lung cancer, which we could say that the poster boy of precision oncology. So with that, let me come to Vidya. Vidya, what do you look in a report to say that, okay, this is good quality? We all are clinicians. And believe me, when Advait, me, Rohit, and all, we were getting trained, we were never taught what to see in the report to say that, okay, this is of good quality. So can you just tell us if you are looking at a tissue, what should be the tumor proportion? What should be the DNA content? What are the QC checks and how many bioinformatics algorithms should have been run for you to be say, okay, this is something which I should rely upon?
So the first and foremost is tumor proportion or tumor percentage or tumor burden present in the FFP block. A minimum of 20%, 20 to 30%, but 20%, the word by itself is a very relative term. So 20% can mean 20 cells in a background of 80 normal cells. But what is 20% that constitutes the block is a very important factor. So I will not go into too much of mathematical details, but a minimum NGS would require 100 nanograms of tumor-derived DNA. Okay, to arrive at that, one has to have at least 150 malignant cells in a given high-power field as assessed by a pathologist. So that is a very important criteria, and one has to follow that if we are wanting to see a true positive report and no false negative reports, because that's a very important factor which one has to consider. There will be coexisting challenges with that, like necrosis could be one of the factors. Tissue coming post neoadjuvant chemoradiotherapy would definitely go through mutations and also a lot of fragmentation of DNA. That can be a problem. Next comes the DNA yield and quality check. So as I mentioned earlier, minimum of 100 nanograms, more the merrier. You can go at the max to 200 nanograms. And QC check, as I mentioned, what kind of tissue you are taking for testing. Like in all breast and ovarian cancers, the olaparib, when it was promoted, it was very clearly told, please use the diagnostic specimen. Do not use the post-platinum sensitive cancer patients' surgical specimen for your BRCA evaluation. Because of this post-neoadjuvant therapy, a lot of necrosis happens and your diagnostic yield significantly comes down. So NGS is a game of sequencing the same region of DNA at least 100 times to get more confidence. So if you are unable to sequence at least 100 or 200 or 250 times, you are not getting the right answer for the patient's BRCA status. It's an example I'm just sharing. So it's very important that we take diagnostic specimen, which is treatment naive is preferable to understand the molecular landscape. However, when you are looking at patients who are post-therapy, third line, fourth line, you have no choice. Then we need to go with some technology like macro dissection. So tumor marked area where necrosis is not there is important to get good yield of mutational data. I think I am not very technical, hopefully, right?
It's okay.
Fine. Then the last point, the bioinformatics algorithm. So there are some standard practices given by Broad Institute in the America. Okay, these are called GATK Best Practices Network. Okay, most of the NGS labs practice that, and they write it in their methodology. And some platforms like Illumina, when they develop their tool, they use this platform. That's very important, that which bioinformatic algorithm is being used. And this GATK is a robust framework which is supported by the clinical trials in most of the NGS trials like TAPUR study or MATCH or any of these trials. They do support these algorithms. And downstream analysis, standard softwares, standard databases which clinicians are already aware of is CleanVar, then OncoKB and CBio portal. These are well curated information available in the literature, which most of the NGS labs verify when they make the mutational profile report. Beyond this, of course, every lab maintains their own mutational database, which they keep referring to. Did they come across this mutation in the past? I think that's a very important practice, which even recommended by CAP and American Society for Molecular Pathology.
Okay. One quick question. You told that you need around 100, 140 nanogram, but the Illumina with the NovaSeq says that even 40 nanogram of DNA is enough. So do you think that labs should also put the machine which they are using? Because the NovaSeq Illumina is very clear, 40 nanogram to 50 is enough for them to do the whole CGP, in fact.
They can do. We can also do. In fact, 10 nanogram is also enough. Okay. So it's the question is not how much nanograms. Okay. The question is, we are looking at the patient's tumor burden. That's very important. The Illumina, Thermo Fisher, all these technology platforms, they talk nanogram because they are only technology partners. But for us, we want to see whether it is integrating to help patient care. So what is the seed material that goes in? If you put in garbage, it will come out only. If your majority is wild type cell, you will get only negative report. But if majority is tumor cell, you get a good report. So essentially, it's not the nanogram that matters. It's how we quantify and how you establish in your own laboratory. That matters a lot.
Okay. So just to summarize, at least 20% of tumor cells, 100 to 140 nanogram of A, it should have got QC checks, preferably chemotherapy samples and standard bioinformatics algorithms to be used. Now, can you, 1 minute, all these parameters for liquid biopsy?
Okay. So even in liquid biopsy, the same philosophy holds good. So liquid biopsy is a very dicey domain today, except for lung cancer and probably to some extent in colorectal cancer and in lymphoma. We don't understand the dynamics of tumor in tissue versus liquid in a big way across all cancers. There are few studies about different cancers, but number of patients are less, and the learning is very, very limited to that specific subgroup of cancer patients. We cannot generalize. The tumor grows through a very broad journey when it goes from stage 1 to stage 4 through the course of treatment for the patient. So molecular evolution or disease evolution is something given in a cancer patient management. So the dynamics of the tumor releasing the blood into circulation will vary from cancer to cancer based on its biology.
One quick question. If a clinician is seeing a report with respect to tissue versus liquid, how many reads or coverage or depth of coverage should be there?
So in tissue, if you go by the classical guidelines given by American Society for Molecular Pathology and CAP, they recommend a minimum of 200 to 250x depth if you want to confidently being able to predict 5% of tumor mutations, 5% mutant allele burden. That means in your 100 tumor cells, 5 cells carried the clone for a KRAS mutation. So if that is the level of accuracy you want to look for, you need a depth of 250x. But if you want to go to a level of accuracy of even a 1 cell, I want to check, then probably you need to go 500 or 1000x. The math is very clear. So 5 cells, if you read 250 times, you are able to see 25 read supporting the mutation. And if it is 1 in 100, you are essentially seeing only 10 reads in 1000. So are you confident to treat the disease at 1%? Do you think that is a true burden or not? So that is a clinician's call. Okay. But technologically, technology can go, as you keep pulling, it can go. But beyond a certain point, technology can give false positive answers. So that is why even, a major sequencing provider like Illumina Technology, they themselves say deep sequencing can lead to sequencing artifacts beyond a certain point. So 1000x to 5000x is kind of a safe game to play. But beyond that, if you go to like 0.001 and all, do you really want to believe that is a true mutation or not? Is something we need to take a call.
Okay. A quick question again, and this is the last question to you. When you look at NGS report for tissue, what valid VAF, if you see, you would tell the clinician, okay, you need to take cognizance of this mutation in solid and in liquid. One-liners for both.
Anything above 5% is considered significant. It depends upon the limit of detection of the assay just now, as I mentioned. So that is a significant number. And pathogenic mutations are actionable. VUS mutations are not actionable.
Okay, great.
And for liquid biopsy, we can go up to 0.1%. Even ddPCR, although they claim that 0.01%, if you ask the technology provider Biorad, they themselves say 0.05% is the best we can call it as a good value. Because when you see doing it on an analytical validation is easy, synthetic sample. But when you're dealing with patient samples, it's a very dynamic scenario.
Okay. We'll quickly now take cases. We have 10 minutes left.
Okay. Done.
So this first
Thank
case is
you.
of a dedifferentiated thyroid cancer, and she is 55-year-old. She's PTC. She has undergone post-surgery, post-radioactive iodine, and now she has disseminated disease in bones and lungs, and there's no radioiodine uptake. We'll have two scenarios to discuss. One, she's asymptomatic, and second, she's symptomatic. And we'll start with Anup this time. Anup, what would you order? Would you order NGS here, or you would say, let's take the first situation, she's asymptomatic.
Asymptomatic, I will order, sir. Symptomatic, right, or start the treatment and later.
I think that was not working.
Symptomatic, we will start with treatment, sir.
Okay.
Asymptomatic, we can wait for the CGP report.
Okay, perfect. So we, according to ATC guideline, if it's asymptomatic, we'll wait. Fantastic. And you would order in both situations or only if it's?
Both situations, sir, but we'll start the treatment for.
Okay. Vaibhav, what would you, let's say the patient is symptomatic and we decided to start treatment and the NGS report comes, it comes out to be has BRAF V600E mutation, which is one of the commonest mutation which you see in papillary thyroid cancer. And it has a good VAF of around 20%. Okay. And now the patient family wants to discuss what is the agent we need to start.
First of all, in this scenario, there is, I think, sufficient data to start lenvatinib upfront or sorafenib. So usually I don't do this upfront. But if thus this scenario arises, then obviously I would tell them that there is a prescribed therapy. I would first put you on a therapy, and this discussion can actually be done later while relapse is there.
Anyone among the panelists would start a BRAF inhibitor before giving lenvatinib or sorafenib in this situation? The patient comes with an NGS report.
No.
No. Okay, great. The reason being, lenvatinib and sorafenib have good randomized data. We could see that the shrinkages, the lenvatinib response is in the range of 64%. And if you look at the shrinkage, it happens in nearly 94% of the patients. And irrespective of the BRAF status, this drug works. irrespective of the KRAS status, this drug works. And if you look at the waterfall plot of lenvatinib, which is shown above, you could see that in all patients, there is shrinkage. 94% patients have a shrinkage. And this has been the experience from this is the data from Tata, which we published last year, which also shows that this is the experience in India also. We do get mutations, but somehow BRAF inhibitors, when given in thyroid cancers, the response rates are in the range of 30 to 40% and not as high as what we see with lenvatinib. So yes, and that's the reason why the panelists chose. Would the things change if this patient came with a RET fusion? Papillary thyroid cancers can also show RET fusion.
So we have an active drug with a very this thing.
It's also available on compassionate ground.
Yeah. So reasons to believe. Yeah. I will choose that. But as I told you, I don't do it upfront.
So you would always choose the drug after you are given lenvatinib and anyone has any difference of opinion, Advait? No. And that's correct. Even selplectinib in this situation gives you a good response rates, and the response rates are to the tune of 80 to 90%. Let's go to the next situation. We have 7 minutes left. 55-year-old female, stage 4C, ATC. And that is actually the scan of that patient. We'll start from Advait. Advait, what do you want to do for this patient? The NGS will take some time, and the scan itself tells you that she may not wait till that time.
So this patient actually has such a heavy burden of disease, and I'm sure the PET scan shows that this patient also has a respiratory compromise, and this patient is actually not probably going to survive till the time you get your NGS. So you would start off in such a scenario. It's a very difficult choice as to what chemotherapy to offer. Most of us would give a taxane with platinum as a combination therapy as a first line. Maybe addition of immunotherapy is also one of the factors that one would look at in such an aggressive disease, without waiting for the NGS. However, that is up to an individual decision after discussing with the patient.
And if the patient comes, this patient comes with an NGS as opposed to this patient comes with an NGS, and you know that in anaplastic thyroid cancer, also 30% of the time you might get a BRAF. So what would you do if you say that an anaplastic thyroid cancer upfront, that patient actually came with an NGS upfront and had a BRAF P600D? So still your choice will be chemotherapy, or your choice will be now a targeted therapy?
So we also have to look into what is the biology of the disease that we are dealing with. We know that anaplastic thyroid carcinomas, in the best of scenarios, your chemotherapy responses are going to be less than about 20% or so. So in that scenario, if we find that there is a potentially actionable target, yes, that targeted therapy would work better than the chemo.
So this is the difference between a dedifferentiated thyroid cancer, where you would want to give it lenvatinib and then go to the targeted therapies, as opposed to an anaplastic thyroid cancer, where the response rates with chemo are at the best what we would say dismal. And this is the data from Tata, actually, which we published a year back, which actually shows that there is very limited survival in anaplastic thyroid cancers with chemotherapy. Whether giving chemotherapy adds anything also is an open question. We can have a debate on that. But if you use BRAF inhibitors, you get response rates in the range of 60 to 70% in this situation. And I think I missed a slide here. There's a new data for ATLP which actually was presented in ESMO last year, which showed that a combination of pembrolizumab and lenvatinib, if you don't have any mutation, actually gives you a response rate of 67% in this situation. Let's say that this lady now was medullary carcinoma thyroid and was symptomatic. We have 5 minutes left. We'll start from you, Advait. Would you wait for an NGS to come? Medullary thyroid cancer this time.
We would wait for an NGS, but along with this, we would also look at the RET and see what the RET mutation is. Obviously, this would be a part of MEN, so that evaluation would also be necessary. Medullary carcinoma thyroids generally do not present with such bulky disease.
No.
So that is a different scenario. But yes, some medullary carcinoma thyroid, if a patient is symptomatic, they would be treated on the same lines of a dedifferentiated thyroid carcinoma.
So you would wait for an NGS for the medullary thyroid cancer. And the reason being, RET mutations are quite common. The commonest RET you see is M9187. And the good thing with RET mutation, not only RET, you also get RAS and RAF mutations in medullary thyroid cancers. And with RET mutation, as you could see here, that near the response rate again is upwards of 90%. And again, this drug at present at least is available on compassionate ground in India. Now let's change the tune. We have 4 minutes left and let's take a parotid case. This is actually the case which I saw yesterday. 82-year-old male, parotid malignancy, undergoes surgery, refuses radiation. It came out as actually a salivary duct carcinoma. ER, PR, AR are negative. HER2 also is negative. He has bone mets. He is asymptomatic. Was kept on observation. He now has progressed. Now, would you now want to ask for an NGS, or you said no?
So progress to lung, liver, another
So progress to lung and bones both.
and symptomatic now.
And now symptomatic.
So I think NGS will be much better answer to treat such type of patient.
Okay, so in such type of cases, NGS is a much better answer. He actually was an NTRK, came out to be positive and has been applied for compassionate access for both larotrectinib and entrectinib. And this is the data from TMH of salivary gland tumors. This is under review at present, which shows that I think 63% of them would have some part of mutations with different agents. And in this, if you have NTRK, they actually do much better. But you could see that the curve in this situation shows a response rate of 70% with a duration of response which is really high. We have 2 minutes left and we'll just take one more case. Sinonasal carcinoma. What are the mutations? One line for all clinicians you are looking for in a sinonasal carcinoma, because all of you said that upfront you wanted to do NGS in a sinonasal carcinoma. 1, 2, 3, 4. Which mutations?
Sir, actually, I don't know the frequency, but routinely tumor agnostic, whatever we're looking, NTRK, RET, all those.
Okay, so you're looking for NTRK RET. Vaibhav?
It might be KIT mutation.
Okay, you're looking for KIT. Okay.
NTRK and RET.
Okay.
NTRK, RET, EGFR.
EGFR, correct. Yes. EGFR. Sinonasal squamous cell carcinomas have an 20 to 30% rate of having exon 20 insertions seen in this situation. And this has been seen also in a paper from Sher Kashmir Institute. Advait, anything more? We have KIT, RET, NTRK, and exon 20 insertions.
HER2 also in certain
HER2 also, that is correct. HER2 also is in. The issue with sinonasal comes is, if it's a sinonasal esthesioneuroblastoma, you have less probability of mutation. If it's a sinonasal adenocarcinoma intestinal type, the probability changes. With sinonasal teratocarcinomas, the probability changes. In fact, in sinonasal adenocarcinoma, you actually look at the P53 mutations, because if you have a high P53 mutations in this, they don't respond to neoadjuvant chemotherapy. If we have 1 minute, I'll just show you a case. This was a adenocarcinoma sinonasal. We operated at Tata, and after that, this patient actually had progressed, and he then came and saw me. His tissue report came out to be negative, but his liquid biopsy was sent, and it actually showed EGFR T790M mutation. He had disseminated mets. It started in an osimertinib, and he actually had a good response, and so much so that it's repeat liquid when we did, it actually showed that that mutation is not there anymore. We have only 12 seconds left, so I thank the panelists for the wonderful discussion. I hope I have finished on time. Thank you.
Thank you, Vijay. Thank you, all the panelists. So the message is clear. See the context, work with an open mind, accrue in trials.
Thank you all for the wonderful discussion. Let us all give a warm welcome to Mrs. Tina Ambani, Chairperson Kokilaben Dhirubhai Ambani Hospital. She's arriving shortly. We welcome you, ma'am. Let us all give a warm welcome to Mrs. Tina Ambani, Chairperson, Kokilaben Dhirubhai Ambani Hospital. I would now like to invite Dr. Sandeep Goyal to conduct the felicitation ceremony.
Thank you, Dr. Purna. Thank you very much. I'm Dr. Sandeep Goyal, Head Medical Oncology, Kokilaben Dhirubhai Ambani Hospital. And finally, we come to the end of our academic session. But as I was telling my colleague, picture abhi baki hai mere dost, we are going to now do the felicitation ceremony. So for the felicitation ceremony, I would like to invite our chairperson, Mrs. Ambani. Mrs. Tina Ambani, please. Dr. Santosh Shetty, our CEO and Executive Director, and Dr. Rajesh Misri, Director of Oncology on the dais to felicitate the dignitaries.
Thank you, sir.
The Kokilaben Dhirubhai Ambani Hospital and Medical Research Center has been in the forefront of medical expertise for the last 14 years. In addition to providing excellent and affordable healthcare with the motto, "Every life matters," we also take pride in recognizing the contribution of medical professionals both within and outside our hospital. Felicitation of doctors is our way of expressing our gratitude and thanks to them for their invaluable service towards mankind. The doctors who will be felicitated today are being felicitated not just because of their academic achievements. It is because, in addition to their lifetime medical achievements, it is their hard work, dedication, sincerity, passion towards their work, honest and empathetic approach for cancer patients, selfless service, and perseverance to reach such heights in their profession. They have been excellent teachers and role models for junior doctors and paramedical staff, and above all, they have been good human beings. In the beginning, we would like to felicitate our invited guest faculty who have traveled from all across the world to be with us here today, share their knowledge and experience, and enlighten us with their wisdom, and also, obviously, for their commendable work in the field of oncology. First, I would like to invite Dr. Jeffrey Oxnard to be felicitated. Please, sir. We invite Dr. Iswan Petak for his contribution towards the meeting and our work. Dr. Raghav Kanwal. Thank you. Before we move on to the next set of felicitation, I would request our chairperson, Mrs. Ambani, to give a few words.
Oops. Thank you, Sandeep, for giving me the mic. Good evening, everyone, and a very warm welcome. It is wonderful to be part of such an august gathering. I'm sure you all have had a stimulating day, sharing tremendous insight with each other. Standing here as a layperson, I'm both humbled and inspired by the commitment and zeal you bring to your profession. Friends, cancer is indeed one of the biggest public health challenges of our times, and India is no exception. Worse, the denial about the disease runs rampant, and in India, diagnosis is delayed due to the lack of skill and facilities. That's why cancer care is an overarching priority for Kokilaben Hospital. Since the opening of our Mumbai flagship in 2009, our Center for Cancer has always been ahead of the curve in terms of technology and talent, establishing us as one of India's best multi-speciality oncology hospitals. Thank you. I recognize that. We recognize that precision oncology, personalized medicine is the subject of today's event and is the new frontier in cancer care, and we are happy to offer these services at Kokilaben Hospital. But there's a greater India beyond our cities. Considering the vast geographic divide between urban centers and the rest of the country in terms of access to cancer care, we have endeavored to bridge the gap by establishing cancer care centers in smaller towns closer to us within Maharashtra. The first 3 of these centers are fully operational in Akola, Sholapur, and Gondia. These are not just clinical outposts, but equipped with the best in-class technology supported by the expertise of Kokilaben Hospital, Mumbai. The same expertise underlines the oncology departments of Kokilaben hospitals in Navi Mumbai and Indore, which are an extension of our healthcare footprint. Indeed, we believe that with ability comes responsibility, and we are proud to assume this responsibility to deliver world-class care and spread greater awareness with a mission to contain, combat, and conquer cancer. Thank you. And that's why events like today's symposium are so significant. They provide a wealth of information, a platform for deliberation, and an opportunity for interaction, and a forum to felicitate excellence. And on this occasion, I'm so delighted to announce that we are continuing to focus on precision oncology and personalized medicine by launching a hereditary cancer clinic, which will help predict familial risks for cancer and take measures to control the same. Once again, friends, thank you all for being here today, and we wish you all the very best as you continue to wage your battle against cancer. Thank you very much.
Thank you, madam, for those wonderful words of inspiration. Now we move on to our felicitation ceremony, and we'll be felicitating our dignitaries from all across the country. The list is in alphabetical order. First and foremost, we would like to invite Dr. Suresh Advani to be felicitated. Dr. Advani everybody knows him. There's no introduction to be given to him. But still, I would like to say a few words. He's the Director Chief of Medical Oncology, Jaslok Hospital and Research Center, Shushruth Hospital, Mumbai. He has been a specialist medical oncologist, developmental therapeutics, clinical research, and clinical oncology. He was the first oncologist to have successfully done a bone marrow transplant. He has been actively involved with over 500 national and international publications, received a Lifetime Achievement Award in Oncology 2005 by Harvard Medical International Institute, awarded the Padma Shri in 2002 and Padma Bhushan in 2012. Everybody knows him. Dr. Advani, please. Big round of applause. Next, I would like to introduce Dr. J.B. Agarwal from Mumbai. Dr. Agarwal is a professor and head Department of Radiation Oncology, Tata Memorial Center, Mumbai. He is also the Chief Vigilance Officer of Tata Memorial Center, Mumbai. He graduated from Tata Memorial, then became professor and now head of the Department of Radiation Oncology. He has a long career, extinguished career, successfully mentored 26 postgraduate students and also several PhD students. He has been on several committees for Government of India, AIIMS, Government of Maharashtra, and several departments. Next, we would like to invite Dr. Shyam Agrawal from Delhi. Dr. Agrawal is head of department and senior consultant, Department of Medical Oncology, Sir Gangaram Hospital, New Delhi. He has done a lot of work in stem cell transplantation, also trained from Germany, Australia, and Los Angeles. He has more than 100 articles published in peer-reviewed journals and is a member of many international committees. Dr. Shyam Agrawal. Big round of applause. The next person on the list again doesn't need an introduction. He is currently the director of Tata Memorial Center and has more than 34 years of diverse experience as surgeon and oncologist. And as a director, he has led Tata Memorial Hospital to be a world-renowned institution in field of cancer care. Dr. Rajendra Barve. Thank you. We now move on down south, and the next person we call from Bengaluru, Dr. K. Govind Babu. Dr. Govind Babu is a consultant medical oncologist at St. John's Medical College and Hospital and SCG Hospitals, Bangalore. He is formerly professor and head, Goodbye Memorial Institute of Oncology, Bangalore. Our next distinguished doctor is Dr. Bibhash Chandra Goswami from Guwahati. Dr. Goswami is a MD in radiation oncology from Assam Medical College, and he's currently working at Dr. P. Bura Cancer Institute, Guwahati, whom he established. He has been the consultant and head of Department of Radiation Oncology at Jaslok Center, Mumbai from 1997 to 2016, and then he moved on to Guwahati. A big round of applause for Dr. Bibhash Goswami. We now call upon Dr. Ramesh Hariharan from Bengaluru. He is a co-founder and CEO at Strand Diagnostics and adjunct professor at the Computer Science Department of the Indian Institute of Science, IISc, Bangalore. Dr. Ramesh Hariharan. We next invite Dr. Hemant Malhotra from Jaipur. Dr. Malhotra is a very senior medical oncologist. He's the director, Sri Ram Cancer Center, and head of Department of Medical Oncology at Mahatma Gandhi Medical College Hospital, Jaipur, India. Now I would like to call upon Dr. Dinesh Pendarkar from New Delhi. Dr. Pendarkar is Director, Sarvodaya Cancer Institute, Medical Oncology, Hemato-Oncology and Bone Marrow Transplantation. He has a specialty in medical oncology and is a visiting professor in many countries in the field of oncology as well. Dr. Dinesh Pendarkar. I would now call upon Dr. J.K. Singh. Dr. J.K. Singh is Director of SS Hospital Research Center, Patna. He was former Director of Mahavir Cancer Sansthan, Patna and Paras Cancer Center. He has got outstanding contribution in the field of oncology and has been awarded the Padma Shri in the year 2012. Dr. J.K. Singh. We would also like to felicitate the following doctors who could not join us today in this meeting because of their prior commitments. We'll be sending their souvenirs by courier to them. The list includes Dr. Anita Borges from Mumbai, Dr. Doval from Delhi, Dr. Anand Pathak from Nagpur, Dr. Purvesh Parikh from Mumbai, Dr. B.K. Smriti from Mumbai, Dr. Rajiv Sareen from Mumbai, Dr. Pankaj Shah from Ahmedabad, Dr. Tapan Seke from Mumbai, and Dr. A.K. Ved from Delhi. A big round of applause to all of them, please, for their immense contribution in the field of oncology. Now I'd like to call upon our CEO and Executive Director, Dr. Santosh Shetty, to felicitate another special person for his immense contribution. Dr. Santosh, please.
Thank you, Sandeep. A very good evening, respected Chairperson, Mrs. Ambani, eminent dignitaries, faculty members, delegates, and my dear colleagues. At the outset, I'd like to compliment and congratulate all the awardees of today for their outstanding contribution towards cancer care. I think all of you deserve a huge round of applause. On this occasion, as we felicitate and honor some of the doyens of the field, it's also an occasion to recognize one of our own. The Center for Cancer at Kokilaben Dhirubhai Ambani Hospital has truly lived up to the vision of our chairperson, Mrs. Tina Ambani. Whether it's clinical excellence, academics, or research, this center today enjoys the full trust and confidence of patients from across the country. In addition, this center is also amongst the most respected centers amongst the peer group. The credit for this and goes to the entire leadership of our director, Center for Cancer, Dr. Rajesh Mistry. How do we describe Dr. Rajesh Mistry? I mean, a couple of days ago, I met one of the senior most oncosurgeons in the country, a doyen whom we had felicitated a few years ago. And he mentioned that you are very lucky. You have Rajesh, and Rajesh is a solid guy. The word solid really stuck in my head because this is one word which truly exemplifies what Dr. Rajesh Mistry is. Behind the calm and composed demeanor and manner is a solid guy, a solid cancer surgeon, and above all, a solid leader. I'm sure, Dr. Mistry, under your leadership, our cancer center is only going to grow from strength to strength. May I request Mrs. Ambani to please felicitate Dr. Rajesh Mistry.
Thank you, Dr. Santosh, for doing those honors. Just wanted to inform that all the dignitaries, if you want to give a bite, Dr. Amrit Kala will be outside with the mic, so you can share your experience and your thoughts and all with her, and that will be recorded. Finally, we come towards the end of the meeting and the vote of thanks. So, as an event chair, it is my humble duty and responsibility to express my sincere gratitude and thanks to all those who have worked for the last 1 to 2 months hard to make this meeting possible as well as a grand success. At the outset, I would like to thank our chairperson, Mrs. Tina Ambani, who was instrumental in sowing the seeds of this international symposium in our brains, so that encouraging us to organize this conference, and hopefully we have done her proud. Our governing council members, Mr. K. Narayan, Dr. Tushar Motiwal, and Mr. Dharmendra Bhandari, without their guidance, this meeting would not have been possible. A big round of applause to them. Dr. Santosh Shetty, our CEO and Executive Director, for his immense support and presence during the planning process, as well as in the conference today. He's been there since morning 8:30, and so that's really thanks to you, Dr. Santosh. Your presence has made a big difference, to us. Dr. Mihir Dalal and Dr. Dhaval Bhatt, I think the entire organization of this meeting has been done by them. The stage setup, hall setup, Dhaval was there last night as well. Hotel accommodation, delegate case, souvenirs, they have participated in everything. So a very special thanks to both of them. Our organizing committee, Dr. Mistry, obviously, Dr. Amrit Kaler, and my two colleagues, Dr. Vaibhav and Dr. Imran, without their help, the agenda would not have been finalized. Contacting the faculty, delegates, I think it's a big job, and I think they have really helped us a lot. Our scientific committee members, Dr. Mandar Nadkarni, Dr. Mandar Deshpande, Dr. Yuvraj, Dr. Yogesh Kulkarni, Dr. Chadda, and Dr. Sumit Basu. To spend the whole day for surgeons in a medical oncology meeting is not easy, and they're going to kill me for that, but I hope I have the backup of all of them. So, but thanks, guys. Thanks for your support. It really means, to just see you there, it really gives a good feeling, Right. The event management partner, Mice Ideas, for helping us organizing this meeting. finalizing the agenda and logistic support. It makes our life much easier when we have event managers for the meeting. Mr. Shrenik Mehta for making our presence felt in the media, organizing journalists and media coverage. Our general admin team for logistic support and overall management of the event, corporate communications team for designing the brochures and the mementos, clinical admin team for helping us get the all-important 2 MMC points. That's why we have got a lot of support from physicians and oncologists. The F&B team for the delicious lunch and lunch snacks, and also in tea and coffee, for helping us to keep awake during the sessions. Media personnel, special thanks to all the journalists who have come from far and for taking the time out of the busy schedules and being with us here. Sponsors and supporters of this event, especially Mr. Dhyanraj from Roche, who got Dr. Oxnard all the way from US. Our team of CCOs, for helping us out with the presentations, the registration batches. And marketing team for organizing such a good audience, attendance as well. Last but not the least, our faculty, the international, national, local faculty and delegates, all the oncologists, physicians, students, and junior doctors. Without their participation, this meeting would have been meaningless. I sincerely hope that this meeting would have been worth their time and effort, and all of us would have learned something new and worthwhile during the course of the meeting. And last but not the least, thanks to Lord Almighty. Without His blessings, this would not have been possible. So thank you, everyone. Thanks a lot, and have a nice evening and a safe journey back home. Yes, I've told. So again, just reiterating, if anybody would like to say a few words outside respected dignitaries, please, there's a mic outside in Dr. Amrit's hand. Thank you very much.
Not necessary.
It was overdue.
Friends, you can also join us for high tea on the ground floor. We would really appreciate if you can join us for high tea. Thank you.